is where extraordinary breakthroughs happen. We've been preventing and treating life-threatening diseases for over a century. We've pioneered new antibiotics and led practice-changing research for childhood diseases, cancer, HIV, heart disease, and diabetes. And we're only just getting started. Every day, our scientists from all backgrounds and disciplines work together to use the power of leading-edge science to save and improve lives. Because we believe research is the will to the impossible. And that science will lead the way.
Ladies and gentlemen, please take your seats. We're about to begin. Wow, suddenly a quiet room. I should have been a teacher. Good morning, everybody, and a very warm welcome to this, the fourth annual summit. Our theme is Greece's determination to fight cancer. I'm Alistair Ross. I'd like to welcome you on behalf of The Economist and of our generous sponsors, EOPE, ELOC, and MSD. I think we need a new word for cancer. For people of my generation, the big C, as we call it, still rings out with all the weight of a death sentence. But this complex and challenging disease is gradually, little by little, surrendering to an unrelenting campaign of research. And it's as if the pace of advance in prevention, diagnosis, and treatment is accelerating. That's how it feels at the moment. Technologies including personalized medicines and targeted therapies, immunotherapy and gene editing are delivering benefits and will continue to do so. AI and machine learning and big data promise new advances in detection and treatment, raising the chances of early detection and more effective prevention. Greece is sharing in these advances, but there's room for improvement. Greece has lower screening rates than the European average, particularly in rural areas, and waiting times in the public health system are long. Still, recent years have seen progress, and Greece has a strong cadre of skilled professionals, some of whom are with us and will be meeting today. Indeed, to look more deeply into these areas, we're privileged to be joined today by an impressive lineup of public officials, health professionals, and academics. So let's get started. Our first session of the morning is a panel session, and I'm delighted to be able to welcome to join me on the stage our panelists for the day, for this morning. And the first of them, who I notice is busy with a phone call, so if it takes him a second or two to come up, we'll forgive him on this occasion, is Adonis Georgiadis, who is the Minister of Health for Greece. I'd also like to welcome Xenia Zaridaki Soras, who is the medical oncologist and the President of the Board of Directors of the Hellenic Society of Medical Oncology, and the Director of the First Oncology Department at the Metropolitan Hospital in Athens and Asklepios Diagnosis in Crete, a very busy woman. Please come and join me on the stage. And George Kapithanakis, who is the President of the Hellenic Cancer Federation, ELOC, and Mike Holmes, who is Vice President of the Global Medical and Scientific Affairs Oncology Therapeutic Area for MSD Global. Ladies and gentlemen, please join me on the stage. Thank you. I'm just going to make an adjustment or two to my table. Take a seat, then, Minister, please. Excellent. Well, let's get going. Without any further ado, I'm going to hand straight across to the Minister, who's going to give us his opening thoughts on Greece's progress and future in the fight against cancer. You're relatively new to the portfolio, so I'm interested to hear what you're going to tell us.
First of all, thank you for the invitation. I'm not so new, to be honest, because it's my second term in the ministry. So I remember some things, but one of the things that really amazed me is the progress science has done against cancer in the recent 10 years. Patients that 10 years ago, they were totally convicted to die, with the new medicines of very prestigious companies that manage to produce therapies that are really innovated, they manage to give not only hope, but a very good standard of living to these patients for a lot of years. And this is amazing, because for the first time, humanity can really say that we can fight cancer back. And this is great, to be honest. As Minister of Health, of course, I have to deal with a challenge that comes with all this great news. You know that the ancient Greeks were saying that you can never find something that is absolutely bad or absolutely good. Bad and good are inside everywhere, like yin and yang, something like that. So, in this case, the challenges of the budget are coming with the new innovative therapies. And it is a challenge not only of our budget, of Greece. I think it will be the biggest challenge for all public healthcare systems around the world. And we have to deal with the reality that our population is aging, so the needs for health treatment are increasing. The new therapies are coming fast but expensive, and the state budget we have are always under some limits. This is the challenge we're dealing with now in my ministry, and we're trying to deliver. I'm optimistic that at the end, in good faith, and with the Society of the Doctors and the Oncologists that are here to help, I want to publicly acknowledge, you permit me to address the Greek language?
Of course.
Okay.
So, I would like to congratulate Mrs. Zaridaki Zora and, of course, the HESMO and her associates, because from the very first moment I joined the ministry, they didn't talk to me about the need of innovative therapies only, which they support, which they cater for their patients, but they also shared with us specific recommendations and proposals so that the use of these new novel drugs will be done in a responsible way, both vis-a-vis the patient, because if you administer a drug to a patient who doesn't need it, it's not good, but also in a way responsible towards then the challenge of fiscal limitations, let's say. It is quite critical in order to ensure good health for more people. If we want to do that, we have also to achieve the second target, because if we have irrational use and consumption of drugs, and this goes well beyond our budget, if this goes well beyond a certain point, then it goes without saying that big companies will not provide these novel drugs to Greece. And if there is someone who truly needs this drug, he won't be able to have it. And this will be our own failure, 100%. Our responsibility lies in the following. If there is a patient who truly needs a medicinal product, which is life-saving, we have to provide that. So the Greek government will not be able to solve this riddle unless we have the cooperation of the physicians. And this is my last point. In the last days, actually yesterday, we had a meeting in the ministry. Together with the Hellenic Association of Neurologists, we had to deal with the delirium. It's not an oncological drug. It is a drug against neuromyopathy. But in Greece, it's being prescribed non-stop. It's a very expensive therapy. Actually, the cost of it was amounted to 15 million euros last year. In the first 2 months of 24, we have to pay more than 3 million euros already. And 2 days ago, this drug, which has been has been approved by FDA phase 2, not by EMA, still it was prescribed. The company, however, decided to withdraw it from the market because it failed to go well beyond the phase 3 trials, so it doesn't work. So we found out that it doesn't deliver after we have spent 15 million euros in the past year. So it's a failure of not the ministry, but a failure of the doctors themselves. They couldn't contain themselves. They couldn't put the rules in place. They couldn't isolate their poorly performing colleagues, let's say, because some of them tried to prescribe the drug in order to show off to the relatives of the patient, or because they thought that the drug actually delivered, or because they had other reasons. I don't know. I want to make clear that we have to have very clear rules in place from now on how these drugs will be prescribed and administered. And before I rest my case and talking about oncology, and that's the most critical thing, therapies is not like Elivrio, do not have a cost like Elivrion, 70,000 euros. They cost 700,000 euros. So if we follow the same pattern, we will not be able to afford an aspirin. So we have to come to terms. And let me repeat myself. The Hellenic Association of Oncology, Mrs. Saridaki and her colleagues, have been amazing in our meetings, always very responsible, and I would like to publicly thank them.
Very much. Just before I move on, I wanted to ask you a sort of framing question. I don't know how easy this is to answer, but I wanted to get a sense for you in your portfolio of how much of a priority cancer is compared to everything else that you're dealing with. So how does it sort of fit into the overall picture for you?
Cancer is the top priority for all healthcare systems. It's the biggest challenge, no doubt about it. For many years in Greece, we were calling cancer not by its own name, but we were naming it the bad disease. I'm happy that now less people refer to cancer like that and more people refer to cancer as cancer. Mm-hmm. It is one more disease, a very heavy disease, but I'm telling you again, for the first time in human history, with great hopes that the person that will have it, will learn that will have it, that doesn't mean that he has to die. And this is very important.
Okay, let's move along. Xenia Saridaki-Zoras, medical oncologist, president of the board of directors of the Hellenic Society of Medical Oncology. I don't know if you want to respond specifically to what you've heard, feel free to do so, but I'm sure you have your own thoughts on this topic.
Yes, I also have a small presentation. I'm not sure if this is the right time to...
This is the only time, so it's either now or never, but
So
I
the
will
right
ask you
time
to
is
try
now.
and keep to your time, so you don't have very long. We'll have to move along quite quickly.
So first I would like to thank the Minister of Health for his kind words. We are all here to support the society as a whole, not only our patients, but also their families and caregivers. And I would also like to thank, of course, MSD and the economists for the fourth time an annual presence in our country dealing with what is for us the big issue, which is cancer. And I would like to switch to Greek. If I can have my presentation, please.
So I would like to thank MSD and the economists. It is true that for a fourth consecutive year, we have this event in Greece. This is my last slide, says the speaker. This fourth year is different because in a month's time, as of the new minister being in office, we are having the neoplasms national register. This is not a coincidence because the minister is a person fully knowledgeable of the situation, and now it's in her hands to put it in place. A job, a piece of work that we know how to realize through pilots, good practices, mandatory implementation, and connection with the prescription so that we can use all data, that we can have digitization and interoperability. All of those issues that were put forward by this administration. And of course, precise actions connected to oncology, the national health care, the onco committees, and of course, involving cheap drugs. And possibly this is the right time to discuss prescription of onco drugs only by oncologists, or rather in the framework of an onco committee. We need to proceed with clinical trials, and all the above could be implemented very easily through protocols. For the past 10 years, we have been renewing them annually. They are posted on the ministry. They need to get integrated and connected with the national action plan so that there's digitization at all levels. On our side, we have started with the electronic file that is given for free to all our medical oncologists in a way that they become familiar with this environment, and the biomarkers, which is the next big challenge. Medical precision is not something expensive. It's a matter of justice. The consensus of biomarkers has been already agreed, and we are currently shaping a legal proposal that needs to be passed. For the past 10 years, we've been having all of those programs for all cancer types, thanks to our own resources and, of course, donations from the pharmacology community. Hundreds and thousands and millions were invested so that we come up with those molecular biomarkers. And again, we've kept working through the pandemic last year as well, investing enormous amounts. NGS for lung cancer has covered everything thanks to its own resources. And again, I would like to thank the pharma community and MSD. We're referring from more than €500,000 scholarships that were given, and colleagues who were trained abroad and are back servicing and helping all patients through the Global Center, collaboration with Colombia, and with Christie's in the UK. All the above so that our oncologists may get properly trained. And a gem of our company, IACO, the Onco Academy, again, in cooperation with the Open University, which allows all young oncologists, along with the internship, to get a certification of short training. And let me stress that being open, being extrovert, being well updated, speaking about patients is essential. As the Minister mentioned earlier, the healthcare system can't be sustainable unless we have trusted information for patients, and this is what we've been trying to do, connected with the primary health care, thanks to videos, different campaigns that we have organized in 22 and 23, and we've been awarded for those campaigns. We wish to stress that prevention is essential, and I believe that this is again a concept promoted by the ministry. This administration was the first one to have in place a well-organized prevention program for mammographies, and its vision is very clear. We know how to move ahead, and we are thankful to have them next to us. Thank you.
Indeed, thank you. Let's move straight along to George Kapetanakis, who's the president of the Hellenic Cancer Federation.
Good morning.
Good morning.
Καλημέρα σας. Καλημέρα, κύριε Υπουργέ.
Good morning, Minister. I've got a presentation that I would like to have it on. Let me say that I'm very pleased to be here with you today. We are very happy because we put out our auspices this event, and we would like to thank the organizing committee, MSD, for giving us this pleasure and bestowing this honor. Comparing to the last year and the expectation we had, well, today, as of the beginning of the year, we have accelerated our pace, and the announcement of the National Action Plan and whatever put forward by Mrs. Saridaki are two steps have been standing requests on our part, and they are two very strong or rooted steps ahead. But why do we need a national cancer plan? What does practically means for us patients and the overall community, and what is the picture in Europe and Greece? What are the challenges that we need to deal with, speaking about sustainability? According to the data, cancer is the second reasons of death following cardiovascular diseases, whereas according to Global MEC, up until 2040, the rate shall increase by 21%, occupying the first reasons of mortality. The average prevalence shall increase by 29%, and in Europe, 20 million people survive after cancer diagnosis, whereas we have 3.5 million cancer diagnoses annually. If we combine all the above, it is clear that there's a strong need for the creation of a plan that would deal with all those challenges. After the decision of the EU Commission for the creation of a national action plan, today we got 20 countries having one such, most of them starting back at 2021. Out of the 27 EU countries, our country is in a very creative mobility stage, if I could put it this way. And there are more plans for the future. The development of a national action plan against cancer shall not annihilate and eliminate the projects already in place. It shall rather maximize and rationalize everything already in place by continuous assessment and adjustments. The great picture, the big picture, requires a plan that would be human-centered, focusing on care by utilizing all human, financial, and technological resources, coordinating and encouraging the cooperation between all involved parties, all stakeholders, breaking the silos existing, guaranteeing its sustainability. The National Action Plan Against Cancer shall be a catalyst for the development of a holistic approach, which shall be expressed through the engagement and the commitment of the state to invest strategically more in dealing with the disease, involving the entire range spectrum of care, horizontally throughout all fields involved. The challenges in this path are numerous. Ensuring an equity access to care is the top one. By this term, we believe that the state needs to deal with the inequalities existing at social, religious, financial level, groups of people that must be protected. And again, the legal framework which is required for the reimbursement of biomarkers, which is something that needs to be resolved. The second challenge, quality of care, which is of primary importance as of the provision of healthcare, high quality services may only guarantee the improvement of the life standard of patients. We need to enhance the patients to be further involved in the decision making, in the organization of and drafting of all support programs, and focusing on infrastructures, staffing, equipment, the workforce, which is relevant to the quality of services. We need to get connected with the comprehensive cancer centers, which may ensuring new resources for the development of the operability of the existing infrastructures by putting forward standards. Agios Savas is a first beacon in that spirit. Research and innovation, which is an enormous challenge in terms of the promotion of those two fields in our country. For this reason, we need diffusion of innovation in the prevention, diagnosis and treatment of cancer, the final goal being to come up with higher, better results for our patients. And again, more clinical trials combined with this new approach and a new drug policy will be further very helpful. In the era of digital transformation, embedding new technologies is mandatory throughout the entire medical path. Gradually, we're getting into a new environment where we need to promote electronic files in full interoperability and use by secondary use and data analysis, real-time monitoring. And we are expecting a relevant study on the part of VOV conducted last year. And again, new resources, funding and optimal allocation of the existing one. Those are challenges which may allow, once in place, full implementation of all the above. Without including RRF, more than 4 billion were made available as of 2021 thanks to EU tools on cancer care. MSD has recently conducted a survey. The results haven't been announced yet, and it demonstrates that it's still a large margin of 3 billion euros. Well, and our country is expected to get a good share of it. And last but not least, to have everything successfully implemented, we need to have a good and consistent monitoring of everything. Minister, there are people working for all the above, an entire ecosystem, well-equipped, with a long experience, professionals, the academia, research centers, enterprises from the pharma community, hospitals. We officially representing the patients, we know how to put forward proposals. We know how to cooperate and promote excellence in our field. And there we are to keep in that spirit, working with you. And we are simply asking you to utilize this momentum which already exists.
Thank you very much. Minister, I'm going to give you an opportunity to respond to that, but after we've heard from Mike. Mike Holmes, Vice President, Global Medical and Scientific Affairs, Oncology Therapeutic Area for MSD. Your thoughts, please.
Thank you very much, and good morning, everybody. And thank you to the organising committee for inviting me to this, I think, really very important, really critical meeting. And I was just reflecting on what the Minister and the distinguished oncologist here have been saying. And actually, I think that we at MSD are very much aligned with many of the sentiments that we've heard here. And I really have three reflections that I would like to make over the next 5 or 6 minutes. So the first thing that I would like to reflect on is the great progress that has been made over the last 20 years. It was interesting, the Minister was talking about the general public or general population not wanting to even mention cancer. So the country I'm from, the United Kingdom, people used to talk about the big C. but they wouldn't say the word cancer. That's changing. There's a lot more openness to discuss cancer. There's a lot more, I think the stigma, although it's not totally removed, I think the stigma is actually being reduced around cancer diagnosis, which is really very good. I think we have made great progress. We're seeing mortality rates are dropping across many cancers. I think some of you may have seen that the American Cancer Society recently published their annual survey of mortality rates, and across almost all of the most common cancers we are seeing in general: lung cancer, colorectal cancer, breast cancer. There was possibly a slight increase in the US for mortality over the last year, but in general we're seeing mortality is improving. And we've seen a lot of technology, and we've already heard from the previous discussants about how technology is making a real difference, whether it's immune-oncology drugs, whether it's targeted drugs, better earlier diagnosis, screening, the use of biomarkers. All of these things, I think, are contributing to the great progress that we're making. And if I may mention one or two specific cancer types where we've seen real progress, I'll give you an example of melanoma. 10 or 15 years ago, melanoma was a disease with metastatic melanoma, unfortunately, the majority of patients were not really surviving beyond 12 months. And we're now seeing really prolonged survival with some of these newer treatments. We're seeing survival which is perhaps 10 times longer than what we've seen before. The same is true for non-small cell lung cancer. Again, the average overall survival for non-small cell lung cancer in the past had been less than 12 months. And we're now seeing that for patients who were diagnosed between 2016 and 2018, 1/3 of those patients are living more than 5 years. We've seen the impact of prevention through vaccination, through HPV vaccination, and the impact on cervical cancer. These are all, I think, examples which give us a great deal of hope. Having said that, we do appreciate that we still can and absolutely must do more. We have an aging population. We are seeing increased rates of cancer globally. It remains a huge health challenge and a huge burden that all the stakeholders, we need to work together to improve that. We are also seeing some concerning trends around increasing rates of cancer in younger patients as well. We should acknowledge that. For example, cervical cancer, we have seen that over in the patients who are 30 to 44 years, over the last 10 years, we've seen an approximately almost 2% increase in the rate of cervical cancer being recorded. So we have to be careful there as well. And there is a great deal that needs to be done for prevention. Probably around half of cancers are preventable. Risk factors of obesity, of smoking, of alcohol. There is a great deal that can be done through public health initiatives, and I know there's work here in Greece on smoking, reducing the rates of smoking, for example, which I think is absolutely critical. And at the same time, screening is essential. And I know also Greece is now really getting much more involved in screening with breast cancer, colorectal, cervical, and I believe also being part of the European pilot to look at lung cancer screening. We know that earlier detection gives better outcomes, more chance to be treated in early stage, more opportunity to have a prolonged remission. So my third reflection is really about, I feel the momentum here. I feel the momentum from the statements that I've heard from the rest of the panel here. I feel a momentum and a real drive and a real willingness to continue to tackle cancer. I think as we have improvements in treatment, new modalities, new biomarkers, I think that will really bring us into an era of our ambition, which is to turn cancer from being a fatal disease to being a disease which becomes a chronic disease that patients live with. And one other point before I close is quality of care. I was very happy to hear you mention quality of care. It's something that we in MSD are very committed to thinking about the whole treatment experience, to have a holistic approach and not just think, of course, we're very much thinking about our phase 3 program and about our outcomes and about registration and about discussions with payers, but we have to think about the whole patient, and I think patients will really demand to have this kind of quality of care approach, quality of life, and looking at the whole treatment rather than just focusing on a more narrow efficacy view. So just in closing, for my three reflections, I wanted to say we at MSD are very interested in policy. We're very interested in working with national governments. We're very interested in working with leading oncology associations. We're excited about the Greek National Cancer Plan. We want to be part of that discussion. That's something that we feel very much committed to. So I really would like again to thank the organisers for this opportunity, just to give some reflections from an MSD perspective, and to say that we feel that we're part of the overall stakeholders that should play a real role in having great impact on the lives of patients with cancer.
Excellent, thank you. Minister, I'd like to come back to you. I'd like to invite you to reflect on what you've heard. But I have a question of my own, which is about the balance between prevention and treatment, clearly of central importance in the public policy area, for a number of reasons, not least because improved prevention saves you on later treatment. So could you reflect, first of all, on what you heard from the rest of the panel, and then maybe come to this question of the balance between prevention and treatment?
Firstly, I would like to publicly thank MSD for the great cooperation we have had and we still have with the Athens-based team with respect to the provision of critical drugs. I don't want to use labels, I don't want to do some kind of promotion, but everybody knows that MSD in this area have been hugely successful. They have saved lives of thousands of patients, and the fact that we have a great collaboration with them is something helpful to save even more lives, and that means the world for us. Now, the National Registry on Cancer is something I have announced back in 2013 in my first term as a Minister of Health. To be honest, when I returned in 2024, I was amazed to see that it hasn't been implemented yet. That's why I launched it immediately, and it was one of the first ministerial decrees I signed in 2024. In order for this to happen, we need collaboration with doctors, and I think that proposals by the Hellenic Oncological Society are very good and will be implemented because we are interested in having the registry. We're not interested just in having the ministerial decision published. It will be a great tool for the ministry, for the government, and of course for the scientific community. The National Cancer Action Plan means the world. We cannot have a national plan without your contribution, Mr. Kapetanakis. We need you, because this action plan is not addressed to the ministers, because it's not an action plan owned by the ministry. It's something holistic. We need many co-competent ministries to be involved. The Ministry of Health, of course, will be the lead partner because we are mainly interested in having this national action plan against cancer, but we have taken into account fiscal issues and other components, if you like. Greece is left behind, yes, and I have a commitment that my term will be identified with the National Action Plan Against Cancer. You know that, and you know very well that when I say something, I truly mean it. I don't want to be beating around the bush. Today we have the first day of evening surgeries. That's something we tried since my first term. I said that we will have this kind of late evening or afternoon surgeries in national hospitals, and I said it will happen, and it happens. Because, you know, in the case of health, time means survival or not. So we will do that, we'll do it in the right way. Don't have no doubt about that. Now, talking about prevention and treatment, I'm quite happy to say that as the Minister of Health, and thanks to the RRF, anyway, it might be something not that pleasant, but I will say it. There has been no biggest blessing for the European Union, but our participation membership in the EU. One of the great gifts we have had from the EU is the Spiros Doxiadis program under the RRF, handled by the Deputy Minister, Mrs. Agapidaki, and I thank her for that, which is something that, for the very first time in the Greek history, we have the central government being dealing in an organized way in order to screen the entire population, both against breast cancer. We have the Phofis Genematas project. We have the cervical cancer program. The program has just been launched. Together with Irini, the Deputy Minister, we're going to have the prostate cancer included in the project. And it is the first time in which, thanks to the research, we will be able to have a let's say a general idea of the status of the state of our population, because the sooner you diagnose cancer, the better it will be, the more chances you will have to cure it, or at least to provide the patient with a number of quality years, and of course save money, because if you start treatment when the patient is at the beginning of the disease, and you have to pay, you will spend more money if the person is at the last stage with no hopes of survival. So the Spiros Doxiadis program, the screening program as we call it in Greece, is the most important, the most critical link in this chain in order to meet this huge goal we have set. And I think we will be in line with that. Before I rest my case, let me say that none of these things would have happened, no matter how much money we have, no matter how much willing we are, no matter how much funds we get from the EU. We cannot do it unless we have an alliance with the physicians, because they are the stars, they are the main fighters, they are the ones showing us what to do and recommending us what to do, and we have to provide the ways in order to implement their proposals. So, in this very good atmosphere of collaboration we have, of course, oncological councils will be launched, you know that. Therapeutic protocols is something I truly believe in. And let me repeat that. We have to be clear to our people. Non-squandering money is not something we do just because we are grumpy and or because we want to improve our budget. It's a necessary precondition in order to have the drugs we need at the moment we need them. It's not a fiscal issue. It's a matter of health. Using our resources in the most efficient way, it's really important, not because we are stingy, but because we want to help people when they truly need that.
Excellent. Well, in the spirit of collaboration, I'm going to open this up. I have more questions, but you may well have questions from the floor. So if there's anybody who wants to put a question to our panel, the Minister or our other panellists, now is the time to claim your spot, because it won't last very long. No? Okay, it's back to me then. I wanted to keep that in mind, so we may have time in a second when we've answered this question for one from the audience, so do keep that in mind. I'll open up again. I'm interested in, the human capacity for putting into the past bad things that have happened to us is extraordinary, and it's easy to forget just at the moment that we've just been through an unprecedented pandemic in our parts of the world. It disrupted everything. So what I want to get very briefly from each of you is a sense of how that experience of the pandemic has affected the field of cancer research, of cancer treatment, for good or ill. I'm sure there are answers on both sides, but we have to be brief. So let me start with the Minister.
The pandemic, amongst the very many things and the repercussions it has had, it changed at a pan-European level, at a national level, the approach we used to have towards public health services. The HERA project, owned by EU, was launched in order to deal with a reality which we, the Europeans, came across and we didn't like it. All drug production lines, and especially the raw materials, were located very far away from European soil. And at a certain point, we ran the risk of having no drugs available. I think this was a shock for European governments. And from that point on, we started discussing about the return of production lines to EU, and that's why we have some bold and generous projects by the European Union to fund these initiatives. in research, not just about cancer, but in research in general, Europe is lagging behind. It's not where we used to be. I think that the discussion on patents is detrimental, not beneficial the way it unfolds. It's detrimental to research. Greece will play a constructive role, of course. We're interested in having the EU being at the forefront of research for innovative treatments against cancer and other diseases. And I think that at the end of the day, the pandemic turned us a bit wiser.
Your thoughts?
Συμφωνώ απολύτως.
I totally agree. The pandemic made us a bit wiser and better. What we experienced in the area of oncology was the following. At the beginning, all patients withdrew from everything, diagnosis, screening, etc. And after a certain point, there was a tempest, there was a wave of people coming in for screening, for tests, for delayed therapies, etc. Let me be a bit more concrete about that. In Greece, especially health professionals have been assisted because we were forced to become more digital at a faster pace. And I think that's something we have to do it the same way. In the case of cancer, we have to act in the same way like we did against the pandemic. Cancer is here. It was here before COVID, and it will still be here after COVID. So we have to keep the good practices that we introduced in the past. We have to keep them alive, and the good practices have to do with the swiftness of our response and the swiftness of our introduction of new drugs, the speed in which clinical trials, develop, the same way like the clinical trials for the vaccination, the COVID vaccination unfolded, because cancer is still alive and kicking, as it was with the case with the pandemic 3 years ago. We have to collaborate at a global level because the cancer issue is a global issue. The same way it was against the pandemic, it wasn't a Greek issue or an issue of Italy or Belgium. It was a pan-European problem. It was a global problem. So the same way we have to deal with it right now when we talk about cancer in the global landscape. Thanks to the mRNA vaccines, we paved a new way on how, on what the flagships against cancer will be in the future. We're going to have personalized treatment of every case of cancer, and that was something that turned into reality because of the huge work, the huge efforts made during the pandemic on the vaccines. Of course, this came as a result of multi-year research in the past. And the next thing, which for me as an oncologist, it's something that, apologies. The last thing was the value of reality, of every single day, the value of life, and the value of knowing what is your patient, what your patient is, the person you have before your eyes. Because whenever we had to connect online with a patient, we were able to see their place, their space. It's one thing meeting someone in your practice. It's another thing having access to their surroundings, to their home, to their room. It gives you a completely different approach, a completely different idea of the people you have in front of you. It makes you a bit more humble, more genuine.
Thank you very much indeed for that. George, your thoughts? Briefly, please.
Ευχαριστώ.
Thank you. I would like to add something. Well, I fully agree with the Minister, Ms. Saridaki. However, the pandemic has been indeed a catalyst which hasn't been so far fully recorded, its impacts, even though it has helped in accelerating the developments after the pandemic. Lots of habits, ways of communication have changed, new methods for rendering services, more customized practices, and again, public health has become a priority. We have realized the gaps of the systems. For all those reasons, I believe that We need to capitalize on the experience of the pandemic. As mentioned earlier, we have become wiser and with different reactions in emergency cases. Those have been already reflected on the onco treatment, even though there has been a workforce crisis. I don't know whether the people involved, the professionals in the field, have already reached the balance they used to have before.
Were there elements of the pharmaceutical response to the COVID epidemic that have relevance for MSD's approach to cancer in the future?
Yeah, absolutely. So I think we've already heard about the mRNA platform, which was, of course, used for developing COVID vaccines very quickly. But we're taking that technology and we're going to be able to apply that to a personalized approach for cancer, which has been the dream for us for probably more than 50 years. So that's something that's very exciting. I think there are two other elements that we would think about. One was that I think for MSD, when we realized that this global pandemic was here, we took the view that for our clinical trials that no patient would be left behind. I have to pay tribute to our clinical trials monitors who continued to go into the field and continued to follow up on patients in studies despite the fact that they were unvaccinated. I think that gives us real strength to know that we as an organization are able to overcome some of these challenges. And then my third and final point is that for us at MSD, and I think probably for many of our colleagues in the industry, it really highlighted some of the inequities in health. We saw the differential outcome depending on social determinants for COVID. It's something that we did know before, but I think it's made us even more determined to find a way to reach some of the underserved populations with our drugs. We want to work with policymakers, we want to work with governments, with leading oncologists as well, to find ways to get into some of those communities that we perhaps hadn't been so acutely aware of before, and that for us, I think,
Mike, are you making an international observation? So inequalities between countries. How about within countries?
Yeah, I think we saw the same thing. We saw that social determinants had a big impact on COVID outcome, and this is something, as we're talking to individual governments, we're saying we're here to try to help with that. I know it's complicated, I know there are economic factors and other things, but for example, we're much more aware of our inclusion in our studies, and we're much more aware of trying to include a much broader population of patients from different backgrounds, different ethnic backgrounds. That's something that we're very committed to as a company. It's not going to be solved immediately. We're also hearing this regulatory authorities are now saying, your phase 3 inclusion was far too narrow. And regulatory authorities are now asking us to say, how are you going to take a broader approach and make sure that we're able to truly represent the population of patients with cancer? And I believe COVID was one critical catalyst in opening up this discussion.
Somebody, probably Churchill, usually Churchill, somebody said, don't let a crisis go to waste.
Exactly.
And clearly COVID has brought its, apart from the horrors that it brought, it's brought certain benefits too. We're going to move on, but before we do, please join me in thanking what's been a really interesting and open, collaborative panel. Thank you very much, ladies and gentlemen. Thank you. Thanks. Okay, before our next panel, we have a brief intervention from Andreas Haralambous, who's the past president of the European Cancer Organization, former president of the European Oncology Nursing Society, a professor of oncology and palliative care at Cyprus University of Technology, who's going to address us on the EU Beating Cancer Plan, a legacy for the present and future of cancer control in Europe. Andreas, please join us. Yeah, go ahead.
Καλημέρα σας.
Good morning. First of all, I would like to thank the organizers, MSD, ELOC, for kindly inviting me to join this event and address this conference. As described, the topic involves the European Cancer Plan, the legacy and the prospects ahead in terms of the wider national and European management of such malignancy. The EU Cancer Plan is possibly the greatest commitment at the European level, starting or rather announced in 2019, and being at the forefront in terms of all policies as of that time. The European Cancer Organization is a federation of 41 professional unions and 21 patients associations representing all the fields relevant to the management of the malignancy at a European level. The organization represents all those stakeholders, and we try to articulate a common voice. The National Cancer Plan in Europe was announced in 2019. However, the efforts were already in place, and the European Cancer Organization set and put the framework, trace the direction, the guidelines where this plan had to focus on. In February 2021, the European Cancer Plan was officially announced, involving 40 different actions or pillars, put it as you wish, pillars for the best management of the malignancy. And for the first time, the plan would be fully funded thanks to 4 billion euros. EU for Health, Horizon Europe and Digital Europe programs are only some of those programs where the states may get funding for their national plans. The EU plan, as mentioned earlier, involves different pillars. First, eliminate cervical cancer and other cancers caused by human papillomaviruses. The creation of a tobacco-free generation, so that in the next few years only 5% of the population use tobacco as opposed to 25%, which is the current rate. Ensure that 90% of the EU population who meet the requirement risk for cervical cancers and other cancers may be included in prevention programs, and ensure that up until 2030, 90% of people diagnosed with cancer have access to cancer management centers. Those are the pillars, 9 different pillars. They are not implemented in parallel and simultaneously. Some of them are implemented first in a way to set the grounds, the basement for all others to come. Those are some of the programs that have been funded via the EU and are implemented currently for cancer in practice at a national and EU level. The difference of the EU plan is that it goes beyond the time limit of 2025, and the innovations of such plan are there to stay. Some of those shall be included in the and are included in the EU legislation, namely the need for a healthier environment, water, and again, the EU Cancer Plan, as stressed by the Minister Yorgos Kapetanakis, the national cancer plans are necessary, are those that may allow a systematic management of the malignancy. Unless they are there, those initiatives would end, and this is not our objective. Supporting the national plans, we may continue running vaccination programs against HPV and other prevention programs in a way to better protect our populations. The European Cancer Plan appears to be an excellent one, and it appears to be somehow concluded, which is not the case. We need to come up with a different word for cancer, as we are half the way ahead. The efforts need to continue and become more intense and even accelerate them. The EU Cancer Plan, the national plans on cancer, must be fully implemented. Those plans, for this reason, need to be dynamic in a way to be prepared to incorporate different innovations while being implemented. And this is what the European Cancer Organization wishes to ensure, so that the implementation efforts become true, while having in place 27 different national plans in all different EU countries. Thank you very much.
I don't think we have time for Q&A, much as I would like to. We do have time for a photo, though.
Photo, okay.
There's always time for a photo.
Thank you.
Thank you. Thanks very much. For the next session, I'm going to hand over to my co-chair for today, is Mary Bussell, who is the founder at Trimar Strategies. Mary. Welcome. It's good to see you.
Thank you. Thank you. Good morning. Kalimera. My name is Mary Bussell, and since being with you here last year, I am the founder of Trimar Strategies. It is a true pleasure to be back for the 4th conference, having been integral to each of the previous conferences. It's lovely to see so many of you again, to meet so many new faces too. The topic for our panel now is linking public health, policy, prevention, and cancer. In Greece, 27% of mortality is due to cancer. This is higher than the European average of 18%. Yet between 30 and 50% of all cancer can be prevented. The momentum for action to address the inequalities and the inequities of cancer care is growing across your beautiful country and throughout Europe. We are in a race against time. WHO forecast just at the beginning of February that we will likely see a 77% increase in cancer cases around the world by 2050. We are indeed in a race against time. In February, just a few weeks ago, it was announced that we've already heard, that Greece will establish a population-based cancer registry, providing an enhanced pathway for monitoring cancer prevention, screening, early diagnosis and treatment, as well as survivorship, and thereby enable improvements in the journey of people living with cancer. The anonymized data will have enormous benefits for public health and for research, in addition to providing the underpinning for understanding the necessary steps that are needed to spearhead the updating of Greece's National Cancer Plan. The National Cancer Plan here in Greece has not been updated in the past decade. These plans are vitally important for promoting an integrated approach to cancer prevention and control by establishing how a country plans to address its cancer burden. So please let me now invite the panelists to the stage. Irini Akpadaki, Alternate Minister of Health for Greece. Yanis Toutas, Emeritus Professor of Social Medicine, National and Cappadostrian University of Athens, and Director of the Institute for Social and Preventive Medicine. Adrian Harpidou, Pulmonologist, Head of Clinical Trials Bureau, the 3rd Department of Internal Medicine and Laboratory Medical School at the National Cappadostrian University of Athens, Sotria Hospital. Mikhail Nikolaou, Medical Oncologist, General Anti-Cancer Oncology Hospital of Athens, St. Savas, Vice President of the Board of Directors of HESMO. Vasiliki Rafaela Vakofti is President of the Greek Cancer Patients Association and will have a recorded message. And we have our commentators, Nicholas Tsoukalas, Medical Oncologist, Director of the Oncology Department, the 401 General Military Hospital, and General Secretary of the Board of Directors at HESMO. And Yanis Bukovinas, Medical Oncologist, Head of the Bioclinic Oncology Unit in Thessaloniki. Thank you. Welcome to each of you. Please, may I start with you, Irini Akpadaki. Would you please like to give us some comments on what is happening today in Greece and what we can look forward to moving into the future?
Thank you. Ευχαριστώ πολύ για την ευκαιρία.
I'd like to thank you for giving me the opportunity to be with you 1 year after and take stock of what has happened in the past 12 months in the area of prevention and the area of access to treatment against cancer, and of course also to discuss the quality of life of cancer patients, but specifically when it comes to the link between public health policy and cancer, allow me to stick to 2 important points. 1 month ago, the European Commission suggested to the Council 3 things which our country has already done. It's one of the very few times that we can actually say that we have already implemented changes that currently the Commission is recommending for other member states. A, the HPV vaccination is expanded already in our country. You know that. You know that the vaccine is being reimbursed both for boys and girls, and this will be the case for this year and the coming year. We have adapted the WHO objectives and we want to meet them. So we start a massive campaign on that. It is really important that everybody the scientific community, the health professionals, and our own families, as citizens, mothers, daughters, our grandmothers. We have to recommend them that they do the screening. It's free of charge, and these are tests that have to do with breast cancer or cervical cancer, and new projects that are to be launched. It's a matter of life or death. It's a fight. We are all together in that, and our country has to win. There's no other option. So apart from that, about this new possibility we have to get the vaccine reimbursed for both boys and girls, which the European Commission is recommending, and we have already done it. The European Commission discussed about the so-called digital pediatric booklet. That's something that we already have it in our country since 2022. For reasons of medical follow-up. You understand the importance of this tool. It allows us to collect data, to identify the areas and the population groups in which coverage is deficient. Vaccination is not enough, because before somebody discussed about social inequalities in health. So we have already introduced a number of policies with the contribution of EOD, and I'd like to thank Mr. Hatzichristodoulou, he's the president, because EOD is next to the efforts paid by the ministry in order to have better communication and better penetration in various population groups, especially the ones that are vulnerable because of their low health literacy or for any other reasons. Normally these people are not included in this project, in these programs. Third point, currently we are working with WHO in order to have Greece included in the International Agency for Research on Cancer. It's a very, very important organization on cancer research. This will enable our country, to do the following. We have screening programs in place. So we need research in order to properly assess them, so that in the next rounds of research we will know what the outcomes of the previous ones are, and we can include these outcomes, both about prevention and clinical tests. You know that we're doing great steps ahead in the world of digital technology. So it is important to have access to new tests, the outcomes early enough in order to diagnose cancer. And what we want is also to co-shape developments in the area of cancer. We don't want just to be followers. You know that apart from the breast cancer program, we have a new program launched this month, which is the cervical cancer screening tests. By June, we're going to have another program for colorectal cancer screening tests. The minister said before that our country is one of the very first countries which will implement a lung cancer screening program, the same for skin cancer, and other initiatives like these will be taken in the realm of fighting obesity, enhancing fitness, etc. In both adults and kids. You know them already, we will analyze them further in the future. Let me highlight something. Regardless of the efforts made by the Ministry of Health, and you know we're doing many, many things, it is important for everyone to embrace prevention. We have to realize that for the very first time our country is investing hundreds of millions of euros in something that has never been let's say, highlighted as much as it should. Was it before because of the pandemic? Was it because of fiscal issues? Anyway, we realized that public health is important. We understood that it's very, very important. We are now part of the global cancer research map, and we are turning things into action. We are collaborating with the Athens Kapodistrian University. We have a work group appointed, including specialists and civil society representatives, in order to update our national cancer plan, for our country, and focus by means of executive studies, as we call them, so that palliative care is totally promoted in our country.
Invite Yanis to give a few words. Thank you.
Thank you.
Good morning. I would like to thank the organizers for the invitation to be this year again with you. I'll describe and I'll discuss inequalities in the healthcare system. First of all, let me stress that there are 4 decisive factors: age, genes, different factors relevant to the environment, And of course, the climate change is an issue. And of course, the human attitudes, human habits, which is determined by the environment largely, and this is why we focus policies of preventions on different aspects, and possibly we neglect some others, and for this reason we come up with different results. The social factors that play the greatest role in terms of our health involves income, social insurance, the working conditions, the life style, and of course the healthcare services in place. All those social factors, unfortunately, are not equally distributed and allocated between different countries, but even inside the same country, and the non-equal allocation is the reason why we come up with social inequalities in the healthcare, which is a global enormous challenge, unfortunately, in our country as well. I'll try to discuss a study which shall be soon presented, conducted together with the MSD, thanks to the support of MSD, and focusing on social inequalities in our country. Well, of course, this is a study having more than 300 pages. Those are just indicative data to help you shape a picture. First of all, life expectancy. 2.5 years of difference depending on the educational level. Those reporting a very good health and good educational standard rate 27.3%. Those of a higher education 80.5%. Good health rate 53.2% for those having an income 500 euros, 93.8% to those having an income of above 3,000. In those groups, of course, cancer patients are included, and you can see that patients with chronic disease represent 43.1% having concluded primary educational level, and just 15.2% those having included the third educational level, which demonstrate again that there's a great difference between those that are better or less educated. This, as opposed to other countries, in our case, the most reliable factor is relevant to education and not to the financial status of people. Please let us move forward. Next slide. There again you can see significant differences relevant to other factors. Obese people 83.7%, with primary educational level and 63.6% third educational level. Exercise once per week 3.2%, 10.9% for those having completed higher educational levels. And again, 63.5% challenges due to financial reasons, 58.5% due to the waiting list. All those data are focusing on the healthcare services. 30% of lower financial status have problem in terms of payment, 18% of those having a higher financial status. Thus it is clear that there we have an enormous challenge. Those problems can't be resolved in the ways the state have been trying to do in the past, meaning by taking horizontal measures. To have a successful outcome, we need to have well-targeted policies for specific social groups without limiting our interventions on horizontal measures only. Thank you.
Pass the microphone to Danny.
Καλημέρα σε όλους.
Good morning. My presentation is somehow a continuation of what the previous speaker has mentioned, investigating the inequalities in lung cancer, because it is true that in the past years we have made a progress in dealing with lung cancer relevant to treatment, new innovative treatments, new strategies, innovative strategies, and early diagnosis by adopting asymptomatic programs. However, it appears that access to those innovative strategies is not delivered in equal way to all people. It is relevant to the social level as defined by the International World Organization, and it is strictly connected with the educational and financial status of the people living in the same country. Thus, the groups having a lower educational, financial, or social level are more vulnerable in lung cancer because they are more exposed to different risks. They smoke more, and they live possibly close to an industrial area. That is, the environment is not the suitable one. They are exposed to a professional environment which might involve carcinogenic substances, and in families where they may be having more problems of violence. And this is possibly why they are diagnosed when suffering from lung cancer at a later stage, losing, and they are not given the best treatment available. Those are not strictly connected with the social status of a person, but take into account the distance between a Greek island and the Athens, or other bureaucratic obstacles which may affect people of different ethnic groups. So they can't have access to pre-symptomatic diagnostic programs at an early age, and they are not well informed. They may have even difficulties in understanding the complex medical instructions, and of course this is our fault. All the above combined with the smoker's stigma. So vulnerable groups run twice or 3 times as high a risk of suffering from lung cancer, or even losing their life due to such cancer. For this reason, we have organized lately a campaign, Mind the Gap. We wanted to build a consensus statement. Mary Bassel helped us to fully reflect it, and it involved actions of information and engagement that we won't actually turn our back to social inequalities. And of course, we had on our side significant scientists from Greece and other countries, and the state, the Ministry of Health, and our sponsors. Unless they were, we wouldn't be able to put in place this endeavor. To conclude, we are all responsible, and we need to try to bridge this gap, eliminate social inequalities, and just let us keep in mind the 5 pillars of this consensus that we invited the people and the scientists to sign. And I'll give you the link to join it, because we are all responsible to promote anti-tobacco campaigns in a way that we all live in a better environment. We all need to support and adopt the pre-symptomatic diagnostic programs. We are all responsible, and we need to ensure equal access to all healthcare services and build synergies with all organizations and competent bodies to put in place all the above. And again, I remind you, let us not forget the stigma of those smoking. Thank you.
Ευχαριστώ πάρα πολύ. Μέχρι τεχνική.
Thank you very much. I'll try to outline, if possible, a city free of cancer. To answer such a question, we need to depict the wider landscape. In yellow, this circle becomes larger and larger. The cases of people suffering from cancer, and for this reason the state must be alert. This circle shall be becoming larger and larger up until 2030, whereas we know that we'll be having a larger pool of people receiving healthcare services, and for this reason we need to ensure an equal access to such services. The first criteria, speaking about the global picture, well, the first factor is the financial factor. In EU and the States, we have the same prevalence of cancer, whereas the number is twice as high in Asia. And in Africa, instead, the rate is far lower, possibly because in the States and in Europe, people age, whereas the life expectancy is far shorter in Africa. So it is very important to stress that scientists are fully convinced that 50% of the most frequent cancer can be prevented thanks to good diet, exercise, weight control, abstain from smoking, protection from sun, and again vaccination against viruses that may generate carcinogenesis. Thanks to prevention, we may even eliminate some cancer forms, cervical cancer, lung cancer, which is a significant cancer type, impacting significantly our society. Those rates could drop dramatically. Science today provides us with all those means that may allow us to analyze the possibilities of mutation in the human body that may lead to cancer. So we have a strong set of tools in our fight, whereas we have, of course, the enormous challenge of the climate change because our globe is highly polluted. Nanoparticles are introduced in the food we consume. The air is heavily polluted, and of course, we live in cities that do not essentially serve our needs. They do not allow us to live in a healthy, structured environment. Let me put forward the Astypalaia example, which is a very successful one, demonstrating the future that is what could be the case when great organizations cooperate between themselves, and how we may become fully free from fossil fuels. This was achieved thanks to the support of an automobile company. Astypalaia was chosen because it's a small island and measurements were easy to be conducted, but it could operate as a model for other fossil fuel-free cities. And if we could control the quality of the food of the people living in those countries, the quality of the structured environment, more open spaces for exercise, and other measures which would lift the anxiety of everyday activities, well, then we might be able to be speaking about a significant development. It is important that we have the EU roadmap in place, funding good practices, and to conclude, as all other speakers, I would like to stress myself as well the education, which is the backbone of our success. We need to educate our children. We need to start from a very early ages to ensure that they'll be respecting the planet. And of course, let us bear in mind that small cities, smaller cities than those we live currently, could be the ideal solution.
May I please ask you to look towards the screen for our recorded message.
Αξιότιμη κυρία Υπουργέ.
Your Excellencies, dear guests, dear Deputy Minister, dear members and supporters of Greek Patients Association. So it is a great with pleasure and sense of responsibility that I currently represent the Greek Patients Association as its president. It's the Pan-Hellenic Association and I'm addressing a very important conference on cancer in Greece. I apologize, but I'm not in Athens, so I couldn't attend. However, I'm pretty sure that the fertile ground for cooperation of the association with all stakeholders will bring us close together in the future. Truth be told, the European Action Plan Against Cancer is a need for all EU member states in order to treat cancer or to deal with cancer from the common starting point and using the same codes, if you like. It's a need, and according to the OECD profile of Greece, cancers represent the third reason of mortality following cardiovascular diseases. Breast cancer and lung cancer rank very high. That's why it is so important to emphasize on screening programs, and like Fofi Genimata are extremely critical for better health of Greek citizens and for the health of the Hellenic NHS, which can save valuable resources and use them for other cases. And I'm talking about the dual saving, because this way we're going to have the longed-for saving of money for Greek households, because Greece is still the champion of out-of-pocket spend with a percentage of 35% annually. Recent surveys presented by Professor Ioannis Sifadopoulos in the Pan-Hellenic Patients Conference last June showed that the spend of Greek households rose from 2009 to 2020 by 38%. The highest problem is the tripling of health spend of Greek households, and of course the non-met needs of the Greek population that amount to 6.7%. The EU average is 1%. Measurable objectives, follow-up mechanisms, and clear financing flows and channels are the pillars for a robust national action plan against cancer, which has also taken into account the need for cross-ministerial strategies in order to fight comorbidities and other humane issues such as palliative care, and of course the access and collection of data. This collection of data will allow for the Greek percentages to align with the European ones on health spend, and of course it will promote collaborations at a local and European level. This is the recipe for success against cancer, but this recipe has to take into account a properly informed recipient who will be actively involved in all health-related decision-making. So medical literacy of patients is, for our association, the foundation for a robust, reliable NHS, both against cancers and all other chronic diseases. As the established association in the debate on health, we claim to have an equitable role and we present well-documented positions on health issues that affect our members. So, feeling this sense of responsibility and investing in our training of our people, we believe that a well-informed patient can actively help in mapping the new strategies, and B, help train other recipients of health services so they can also play a role in building the medical agenda the right way. Also, an informed patient may be more compatible and more loyal to his therapy or her therapy or his treatment, and thus improving their daily lives. Having already an Academy of Patients launched according to European standards and a very innovative strengthening program and workshops for patients, thanks to the support by the Bodosakis Foundation, we have specific recommendations. Literacy, medical literacy has to start from elementary school. Access to early information by means of various channels of communication and languages in order to secure access to information to various population groups is important. Also, further training of health professionals so they can provide proper information to average and ordinary citizens. Digital literacy on medical issues, allowing patients to properly handle their own medical data. Also, information kiosks in all clinical studies, in all clinical and hospital structures in order to be able to properly assess their status. Use of KPIs in order to build a guide with specific ideas and proposals for patient-friendly policies. Also, involvement of the decision makers with all patient associations in order to have the best outcomes. So this is the kind of collaboration we need so that we can all open the door open the door to a new society of equal opportunities of the future, as it is the case in other European countries. Thank you very much for your attention, and I hope the best to this conference.
Thank you. Now may I please welcome the first of our commentators. Nicholas, would you please like to speak?
Καλή σας μέρα. Ζητώ συγγνώμη που δεν είμαι μαζί σας, διότι ταλαιπωρούμε από μία λίμωξη. Ευχαριστώ πολύ για την τιμητική πρόσκληση, τους διοργανωτές του συνεδρίου, την ΕΟΠΕ, την ΕΛΟΚ, την MSD και βέβαια το Economist, ένα πολύ σημαντικό συνέδριο. Όλοι γνωρίζουμε ότι ο καρκίνος αποτελεί ένα πολύ σημαντικό ιατρικό και κοινωνικό θέμα. Είναι ένα πολύ σημαντικό πρόβλημα και βεβαίως αποτελεί τη δεύτερη αιτία θανάτου στο γενικό πληθυσμό. Επίσης, όλοι γνωρίζουμε εδώ και πάρα πολλά χρόνια, αιώνες, ότι είναι καλύτερο να προλαμβάνουμε κάτι παρά να το θεραπεύουμε. Αναφέρθηκε χαρακτηριστικά ότι υπάρχει πρωτογενής πρόληψη. Και τι είναι αυτό? Η πρωτογενής πρόληψη για τον καρκίνο είναι να βελτιώσουμε τη διατροφή μας, να εντάξουμε την άσκηση στην καθημερινή μας ζωή, να αποφύγουμε το κάπνισμα και την ηλιακή ακτινοβολία και βεβαίως να υλοποιήσουμε τους εμβολιασμούς οι οποίοι έχουν αποδειχθεί ότι βοηθάνε στην πρόληψη του καρκίνου. Η δευτερογενή πρόληψη βοηθάει στην έγκαιρη διάγνωση κάποιου καρκίνου και βεβαίως είναι το να συμμετέχουμε σωστά στα προγράμματα έγκαιρης πρόληψης, στα προγράμματα screening για τον καρκίνο του μαστού, του τραχύλου της μήτρας, για την κολονοσκόπηση, που εδώ θα αναφέρω δυστυχώς τα δεδομένα για τη χώρα μας είναι πολύ χαμηλά. Υπάρχουν πρόσφατα δεδομένα που λένε ότι μόνο 13% του ελληνικού πληθυσμού συμμετέχει στα προγράμματα για την έγκαιρη διάγνωση του καρκίνου παχαίου εντέρου, σε σχέση με 41% από ανάλογα δεδομένα από τον ευρωπαϊκό πληθυσμό. Και βεβαίως την εφαρμογή της αξονικής τομογραφίας χαμηλής έντασης για τους καπνιστές. Τι κάνουμε λοιπόν εμείς σαν εταιρεία ογκολόγων παθολόγων Ελλάδος και σαν ευρύτερα ογκολογική κοινότητα, ή τι προσπαθούμε να κάνουμε για να υλοποιήσουμε αυτή την πρωτογενή και δευτερογενή πρόληψη για τον καρκίνο? Το πρώτο το οποίο προσπαθούμε εδώ και αρκετά χρόνια και με μια πρόσφατη συζήτηση που είχαμε με τον Υπουργό Υγείας είναι η εκπαίδευση και η ενημέρωση των μαθητών και του κοινού και προσπάθεια δημιουργίας κουλτούρας πρόληψης και έγκαιρης διάγνωσης του καρκίνου. Αποφασίσαμε και προσπαθούμε να υλοποιήσουμε προγράμματα σε συνεργασία Υπουργείου Υγείας και Υπουργείου Παιδείας για σχετική ενημέρωση και την ένταξη ανάλογων ενημερωτικών διαλέξεων και πιθανώς ενός μαθήματος αγωγής υγείας για τα παιδιά, κάτι το οποίο πιστεύουμε ότι θα έχει πολλαπλά θετικά ωφέλη, όχι μόνο στα παιδιά, τα οποία στην πορεία θα έχουν τη δυνατότητα να αναπτύξουν μια ανάλογη κουλτούρα πρόληψης και έγκαιρης διάγνωσης του καρκίνου, αλλά επιπλέον αυτά θα μπορέσουν να μεταφέρουν το μήνυμα και στις οικογένειές τους. Επιπλέον, η ΕΟΠΕ προσπαθεί να ενημερώσει το κοινό, ενήλικες και νεότερα παιδιά, για την σημασία της πρόληψης και της έγκαιρης διάγνωσης του καρκίνου. Το φετινό μας μήνυμα, το οποίο ουσιαστικά ήταν ένα ραδιοφωνικό μήνυμα, ήταν ότι ξέρεις να τα λες, μάθε και να τα ακούς, και είχε ως βασικό νόημα το να προσπαθούμε να εφαρμόζουμε τις οδηγίες που υπάρχουν για τη δευτερογενή πρόληψη. Τρίτον, η ΕΟΠΕ σε συνεργασία με την Αμερικανική Εταιρεία Κλινικής Ογκολογίας, και είχα τη χαρά να συνεργαστώ σε αυτό με τον προηγούμενο πρόεδρο της Εταιρείας Ογκολόγων Ελλάδος, τον κύριο Μπουκοβίνα, και τον καθηγητή Γενικής Ιατρικής, τον κύριο Λιονί. Σε συνεργασία λοιπόν η ΕΟΠΕ με την Αμερικανική Εταιρεία Κλινικής Ογκολογίας έκανε ένα διεθνές σεμινάριο πριν ένα μήνα για την σημασία και το σημαντικό ρόλο της πρωτοβάθμιας φροντίδας υγείας στην πρόληψη, έγκαιρη διάγνωση του καρκίνου, αλλά και στη βέλτιστη αντιμετώπιση των ασθενών με καρκίνο οπουδήποτε σε όλα τα μέρη της χώρας μας. Ήταν κάτι το οποίο ήταν ιδιαίτερα χρήσιμο, ενδιαφέρον. Συμμετείχαν οι γενικοί γιατροί από όλη την Ελλάδα και μας δόθηκε ευκαιρία σε 2 μέρες, σε συνεργασία με επιστήμονες υγείας από την Ευρώπη και από την Αμερική, να ανταλλάξουμε απόψεις και να προσπαθήσουμε να σχεδιάσουμε ένα ανάλογο πλάνο δράσεων, το οποίο στην πορεία θα συνεχιστεί πρώτον με κάποια συγκεκριμένα webinar σε συνεργασία με την ΆΣΚΟ και δεύτερον με ένα πρόγραμμα το οποίο η ΕΟΠΕ έχει αποφασίσει και θα το ξεκινήσει το επόμενο λίγο διάστημα, το οποίο ονομάζεται η ογκολογική και η ΕΟΠΕ στην περιφέρεια. Και τα δύο πρωτοβάθμιες φροντίδας υγείας σε όλα τα μέρη της Ελλάδος μας, τόσο στις πόλεις αλλά και στις περιφέρειες, στις μικρές πόλεις και στα χωριά, στο να έχουν τις βασικές γνώσεις για την πρόληψη και έγκαιρη διάγνωση του καρκίνου, αλλά επίσης να μπορούν να προσφέρουν φροντίδες υγείας και να βελτιώνουν τη ζωή των ασθενών με καρκίνο. Κλείνοντας, θα ήθελα να επισημάνω ότι θα πρέπει να προσπαθήσουμε να αντιμετωπίσουμε τον καρκίνο προλαμβάνοντάς τον και να ζούμε υπεύθυνα. Και ας προσπαθήσουμε όλοι μαζί να κρατήσουμε τον καρκίνο όσο γίνεται μακριά μας. Είναι ένα από τα στοιχεία της καμπάνιας που έτρεξε η ΟΠΕ, εφαρμόζοντας την πρωτογενή και δευτερογενή πρόληψη. Και το πιο σημαντικό, προσπαθήσουμε να βοηθήσουμε όλοι από τη μεριά μας να αναπτυχθεί και να εδραιωθεί μια κουλτούρα πρόληψης και έγκαιρης διάγνωσης όχι μόνο του καρκίνου αλλά και άλλων νοσημάτων στον ελληνικό πληθυσμό από τις μικρές ηλικίες, από το σχολείο μέχρι τις μεγαλύτερες ηλικίες. Ευχαριστώ πολύ.
Ευχαριστώ. Now may I please pass the microphone to Yannis.
Ευχαριστώ, Μέρη. Ήταν μεγάλη χαρά.
It was really great for me to have attended that meeting. I don't want to repeat the things that were said before. I think the fact that the previous speakers said these things meant even more. Allow me just to share a couple of ideas or proposals. A, cancer is a major social issue. It affects 1 out of 2 Greek households. So that's the survey of, according to the ELOC survey. We know that in the coming 6 years there will be a 20% rise, by 2030, of cancer cases. This will mean an additional burden to household budgets and to the state budget. Fourth point, given the data of the Hellenic Society of Intestinal Cancer, we know that no more than 50% of cancer cases may be diagnosed through colonoscopy. The other cases are diagnosed at a later stage. We have Mr. Stratigos here attending, and we know very well that there are very, very few cases of melanoma. Less than 5% are being detected at a very early stage. In Germany, they detect 50% of the cases of melanoma. So we do have the data available, so we can have targeted interventions, and taking into account the fact that there are social inequalities and geographical inequalities, and also inequalities in terms of access to health structures, and given that currently there is a global trend so that by 2040 we will move away from hospital-based care and move on to a new era in which people will stay healthy for more years than being sick for more years. So culture of early diagnosis and training and raising awareness is very, very important. So people have to be more sensitive about that. That's why the Ministry of Health has to prioritize the regional authorities taking initiatives. The region of Crete has no same problems with the region of Thrace. We have organized programs in one region and we have no programs in another region. So regions or major municipalities have to act. We have municipal medical practices, as we call them, that might be involved in these practices. So mobilizing local population is of huge importance. And like in the case of Astypalea, Mr. Nicolaou mentioned that we can have other pilot initiatives like in Africa, in South America, in former Soviet republics. We have cities or towns adopting specific measures, having their population aligned or joining forces so they can implement changes against cancer, HAP, diabetes, hypertension, and other common problems by prioritizing the way they want their city to develop. I think it's a universal request. No matter what the budget restraints across the world, and in Greece, of course, we have to join forces and organize our structures in such a way that raising awareness is promoted, inequalities are being detected and identified, interventions are being promoted, and at the same time, awareness is being raised amongst the general population. Thank you very, very much.
The really important points you've each raised and contributed to this panel. Inequity exists between countries and also within national borders. So improvements in prevention, screening, early detection can be made by improving access to innovation that is comprehensible for the wider population and for the individual communities within a nation. So how can we improve the partnerships to address these inequities and inequalities? to build health literacy, which can then improve the understanding about the health-affirming decisions that we can each make for ourselves and for our families. Within the Health Ministry, would you be able to address some of the steps that you see we can make?
Θα ξεκινήσω με ένα ερευνητικό.
I will start with some research findings. I think it was last winter, there was a survey in Europe. It has nothing to do with the Ministry of Health. There was a survey saying that if the average income is improved in the EU, we will be able to prevent 50% of chronic diseases. Unemployment or variables that affect household income affect more than the alleged access to health structures. I said alleged because we always, everything boils down to the health structures after the symptoms appear. So if we want to talk about equal opportunities, equal and equitable development, and the right starting point for all kids, then we have to go back to what Professor Tuda said. We have to discuss about educational levels. So this means interministerial decisions, interventions that have nothing to do with health, but they affect health. That's why we say that when it comes to public health, every ministry is the Ministry of Health. I think we stuck more to what we can do at an individual level, but we said nothing about the wider framework of other variables. Currently, we know that we have strong scientific data and evidence showing that we have increased lung cancer cases in non-smokers because of air pollution. That's something extremely dangerous and serious. Of course, when we have areas with high particles, high concentration of particles, it means a lot. And this has nothing to do with income. It has to do with the architecture of our cities. In our country, we have such issues. So in these cases, the rates are high. So we have to engage into a completely different approach to what public health is about, what inequalities are about. We have to check other parameters and not just stick to the individual level. From the viewpoint of the Ministry of Health, the reason we have not included first-line screening programs as something to be reimbursed, but we reimburse the entire set of tests, and we have this screening test pathway in our radar. We do that because it's not enough for a lady to do the Pap test, because if then she needs a biopsy, we don't know if she can afford it. If she has to move from one city to another, can she afford it? That's why we reimburse the entire set of tests so that our citizens can take the first step and the second and the third, because the first step is linked to the last step and there is cost in between. Another thing that affects our ministry has to do with a set of initiatives for medical literacy, and not just medical literacy. It also has to do with digital literacy. We are promoting a set of changes, and I will give an example. We won't have if you are 25 years old or 40 or 85 years, you need different tools. Depending on the age group. There is another set of digital skills for a 15-year-old, which are far better than mine. And people of my age, or elderly people, have different digital skills. So we have to have this approach in other issues as well. Let me close by saying the following. Many times, in order to change, to lift inequalities in Greece, there is always an obstacle: medical data. That's why in Greece we have the health monitoring program in the pipeline, which will allow us to have a holistic, analytical and systematic review of all medical data. Environmentally driven ones, individual ones, behavioral ones, or other medical data that have to do with the NHS. I think that this effort will bring us closer to the so-called evidence-based public health and policy making. I'm really glad to hear people working in the third level sector, like the Hellenic Oncological Society, etc., talking about primary and secondary prevention. This means that our persistence in the past 2-3 years in the Ministry of Health in investing are about to produce fruits, and please, I want to urge you to keep on insisting on that, because this is the only way to change the variables that drive cancer and stop talking just about therapies and treatments, etc., etc. Thank you very, very much.
May I? Thank you. May I ask any of the panelists if you'd like to add to what we've just heard?
Yeah, can I
Yes,
add,
please.
What the Deputy Minister rightly said, the need for a different approach and understanding, I have to comment on that because it's a very important point. Treatment and prevention are both focused on dealing with the disease, treating the disease, and that's the core component of the existing, the applicable medical social pattern. This is how medicine works globally. What we need in order to have a different approach is to build a different psychosocial model, if you like, that will include in its set of objectives all these factors of wider impact, to put it like that. Let me give you two examples. Recently, we experienced the COVID tragedy, right? And there have been some amazing achievements accomplished, the vaccines, the drugs. I think the development was quite positive, as it turned out. But on the other hand, there was no substantial global initiative taken in order to deal with the source of COVID, the reasons why we have had 30 epidemics in the past 40 years, animals. This has been the source. So unless we take into account wider parameters of wider impact, like environmental ones, for instance, in our approach, there will be no result. And the second example that relates to social parameters. We know very well that cancers might be stress generated, and autoimmune, self-immune diseases are also stress generated, and this stress might be the outcome of bad family environment, especially for children who do not live in a warm family environment. Globally, we are experiencing a wave of decomposing, of dismantling families. So this chronic stress generation, which derives from the early childhood, will have no result. So we need a completely different model in order to deal with diseases and their symptoms. Unless we build such a model, we won't have the efficiency we need.
Father Stowe, very true. And it's very important that we not forget that, okay, we have cancers that are predominantly in men, cancers that are predominantly in women, but science, medical innovation is showing us that there are unique genetic variables in non-sex-related cancers. So if I may just ask Danny if you'd like to comment, because women who have never smoked are at very high risk of cancer, and we're only just beginning to understand the issues there.
You're absolutely right, Mary. Absolutely right. It's quite alarming. The scientific community is alert because the number of female suffering from lung cancer, although they have never smoked a cigarette, is rising. And this is linked to environmental parameters, especially in Asian countries, the so-called developing countries. Lung cancer there, especially in women, appears in non-smoking individuals more than 70%. That's very, very important. In the case of non-smokers, lung cancer is related more to already known gene mutations. We have treatments for them, but we have to target at dealing with the reasons of this disease. It is very important to have what we try to do, we call it personalized treatment. So it is important in this context to emphasize also on personalized prevention. I showed you a slide, right? I tried to explain that personalizing or individualizing prevention is very important. There was a farmer spraying some fertilizers and there were no protection equipment used. That's a huge problem for the Southern European countries. It's a real source of cancer cases. We have to deal with it.
I know, yes, please.
Allow me to add something. I want to add that what Professor said before is very, very important. We have to see the big picture. What happens before somebody falls ill? Prevention, as the Minister said, has to be targeted not only in the areas where we have some results. For instance, we have gene analysis, which is very useful in order to build population groups who potentially might develop specific diseases. So, in these categories of healthy individuals, we can personalize prevention with respect to specific conditions. Let me use this opportunity and take the relay from the Minister. We have an amazing opportunity as a country, thanks to this wave of digitalization and AI-enabled technologies to put our country, let's say, at the spearhead of these initiatives. It's not a utopia. It seems that reflexes are here. The National Cancer Registry is established. We have applications being used successfully for the past years. For instance, e-prescription. So all these tools have to give this added value we need. To corroborate what was said before, we say that, for instance, there are women who do not smoke and have increased their breast cancer cases. It is very common that we have now. It's very common to say that now we have more colorectal cancer cases at younger ages, and research shows that this is not hereditary. There is no gene-related, let's say, reasoning for that. It has nothing to do with the microbiome or with the antibiotics used, obesity, a sedentary life, or the use of chocolate and the consumption of sugar. So prevention has to start from the school, let's say, but by means of specific data following sorting and classification per region. Sometimes I volunteer and I go to elementary schools giving seminars on health issues. It is a pure pleasure to discuss with pupils on health issues. I was so glad when I asked the teacher the day after, how did it go? What was the impact? And the teacher told me, a family called me and the mother told me, the child went back and took the cigarette out of the mouth of his grandparents. That's the change I'm talking about.
And I'm sure many of you will repeat that in our next presentations or discussions with patients. I know we have gone over time. We started a bit late. We've gone over time. I would just like to say that it is so important. Prevention is key. We have to support our neighbors, our family members, our patients, our communities to make health-affirming decisions. And we must also use scientific research to understand the variables that we cannot change, because it all comes down to prevention. Thank you. Efaristo. If we could take a picture. Yes, please. Thank you. I would like to...
Thank you, Mary. Thank you to our panel. Before we all go for coffee, we have a brief intervention from Emily Tiemann, who is the manager at the health practice at Economist Impact, who's going to give us, it's a recorded message, and we're going to hear about a global blueprint for cervical cancer elimination. And we have the case study of Sweden. So let's hear from Emily, please.
Hello everyone, my name is Emily Tiemann and I'm delighted to be speaking with you all today representing Economist Impact. So in this presentation, I'll be sharing the report we recently released, which outlines a global blueprint for cervical cancer elimination, incorporating learnings from Sweden's programs. So just to share some quick background and numbers first on cervical cancer, it's globally the fourth most common cancer in women, and the burden really has been increasing over the last few decades, with data showing that the incidence of cancer has increased by 68.5% and deaths by 52% since the 1990s. One of the unique things about cervical cancer is that it's highly preventable thanks to the development of the HPV vaccine that was first approved in 2006, and HPV infection is the leading cause of cervical cancer, causing more than 95% of cases. So many countries have already come a long way to limiting the growth of cervical cancer through vaccination, but also through other preventative measures like better health coverage and screening of women, which can lead to earlier diagnosis. But more needs to be done. Global vaccination coverage is still very low at 13% of eligible girls being vaccinated worldwide, and there are big disparities in the vaccination coverage. So without more intervention like better coverage and screening, the global incidence of cervical cancer is expected to grow by 700,000 in 2030, leading to 400,000 preventable deaths. So why is now a key time to be focusing on this? Well, in 2020, the WHO released the Global Strategy for Cervical Cancer Elimination, which set out some key targets that should be met by 2030 to help achieve cervical cancer elimination before the end of the century. So you can see here in the graphs, the pink is the status quo and the blue is if the elimination strategy is implemented and achieved. So there's quite a difference in both incidence and death. Countries have also begun developing their own national strategies, and there are also regional strategies. For instance, Europe's Beating Cancer Plan, which includes targets for the elimination of cervical cancer. So thanks to those clear targets and goals, several countries are close to meeting or even surpassing the targets. And these countries have a lot of lessons to offer the rest of the world. And that's what we wanted to show from this report. So the main objective was to share the best practice of Sweden's HPV elimination program as a preventative measure for cervical cancer, since Sweden is one of the countries that is on track to eliminate cervical cancer actually by 2030. So we did that by doing an analysis of best practices and preventative interventions to reach those elimination targets, looking at prevention through vaccination, but also screening and treatment. And we used Sweden as a primary case study, but also include examples where other countries have done well to get insights from different types of economies and environments. So for the Swedish case study, we built a timeline of progress on vaccination and screening program. So the vaccine was first approved in 2006, and it introduced pretty much straight away, first for 13 to 17-year-olds, then 10 to 12-year-olds, then 9 to 14-year-old girls, keeping up with global recommendations. So it was introduced in schools in 2012, as well as catch-up program for older girls, and it started being offered to boys in 2020. And there was another catch-up program in 2022. For screening, the national program was first rolled out in 1967, and HPV testing, which is the recommended test by the WHO, was introduced in 2015. Self-sampling, which is a way for women to screen for cervical cancer from home, was introduced in 2020 as an emergency measure during COVID, and it worked so well that it was introduced nationally in 2022. So with regards to the WHO targets, Sweden is on track. The incidence of cervical cancer in Sweden has decreased from 24 per 100,000 women in 1965 to 8 per 100,000 women today, which is getting really close to the 4 per 100,000 women elimination target. So what did Sweden do differently to reach those numbers? This was mostly thanks to the organization of the programs, really going out and inviting people to be screened and having vaccination at schools rather than relying on people to do it themselves. So the system of organized interventions was really pioneered in the 1960s by Scandinavian countries, and it gradually spread to other countries since then. Advocacy and political buy-in is very strong in Sweden. There are many advocacy groups and patient organizations which work with the government. Sweden also does a lot of evidence-based decision-making, partly because they have comprehensive registries of population healthcare data, and the National Screening Registry captures 100% of the cervical cancer screening data. Researchers conducting population-based studies don't have to ask for permission to use patient data, and researchers in Sweden use those studies to show evidence to policymakers for the introduction of specific interventions, as well as to analyze the impact of those policies. So I mentioned self-sampling for HPV testing, which became routine in 2022. Next one is catch-up vaccination. So Sweden really pioneered a catch-up campaign in 2012 to help make sure that girls aged 12 to 18 who were not too old to be eligible for the max vaccination programs in school didn't miss out. And finally, looking at barriers to vaccination and screening in Sweden, there has been a lot of dedicated research done to identify and understand these, and there are some specific campaigns which target non-attenders. So there are a lot of lessons here on what works well, and the hope is that other countries can learn from Sweden's experience and introduce programs similar to these. So in the report, we have a section on implementing a successful elimination strategy globally, and we describe a 10-point plan, which is based on published evidence, insights from experts we interviewed, and also lessons from countries that are leading the way to cervical cancer elimination. So the plan really is for policymakers and other stakeholders worldwide to consider when developing national strategies to eliminate cervical cancer. So going through these one by one, they should build political commitment and momentum, ensure multi-stakeholder collaboration, prioritize HPV within national cancer policies and vaccination schedules, generate data through the development of robust registries, include screening and vaccination under universal health coverage, understand the target population and design the rollout of organized and accessible immunization programs, ensure equitable vaccination and screening access for the entire population, address the barriers of vaccine hesitancy and misinformation, ensure equitable access to high-quality treatment and optimal care pathways, and finally learn lessons from the COVID-19 pandemic to build system resilience and scale screening and vaccination coverage. So in conclusion, we found that many countries have made significant gains in their efforts to eliminate cervical cancer. Sweden is set to achieve this by 2030. Australia is another example, which is set to achieve this by 2035. So countries really need to demonstrate that political commitment to achieve this goal, make sure it's built on evidence-based decision-making. The 10-point plan can form the baseline of actions for each country to consider when developing national strategies and implementing measures aimed at the elimination of cervical cancer. And yeah, eliminating cervical cancer is very cost-effective, so will help alleviate fiscal pressures, but it's also really important to ensure that women are protected from this highly preventable cervical cancer. Thank you very much.
Thank you. To Emily, some very striking lessons there, I think, for all countries around the world. It's time for coffee. Please enjoy your coffee and get to know each other a little better. I'll see you back here at about 20 to 12. Thank you.
Στη Nova χτίζουμε το μέλλον με αξίες, με κοινωνικές δράσεις που αφήνουν ένα θετικό αποτύπωμα στους ανθρώπους, στην κοινωνία και στο περιβάλλον. Εταιρική υπευθυνότητα και βιώσιμη ανάπτυξη. Μια στρατηγική επιλογή που εδραιώνει την παρουσία μας στην κοινωνία και μας κάνει μια πραγματικά μεγάλη εταιρεία. Συνεχίζουμε δυναμικά.
Check this out.
It hasn't been such a long time since people first started shopping online, and it was easy to keep up with the clicks. Little by little by little by more, the clicks added up to be more than the stores, and e-tailers worked harder than ever before because they had to keep up with the clicks. The clicks came from laptops, then tablets and phones, Monday through Sunday, office and home, 24 hours in every zone, and still they kept up with the clicks. Now shoppers ask more from the websites they're on, their language, their currency, their way, or they're gone, so you'd better keep up with the clicks. All of a sudden, there are so many must-dos if you want to keep selling, like delivery there, no there, or there.
And make it tomorrow, first thing.
No time for borders. Gotta stay in control, to stay in the flow and continue to grow. But we'll help you. Keep up with the clicks.
Τι είναι η ΕΟΠΕ? Είναι απλά τα αρχικά μιας ακόμα ιατρικής εταιρείας? Είναι τα 36 χρόνια συνεχούς παρουσίας? Τα 380 μέλη? Τα 26 πανελλήνια συνέδρια? Οι 122 υποτροφίες και τα 180 ερευνητικά προγράμματα? Οι 7 εκδόσεις θεραπευτικών πρωτοκόλων? Οι περισσότεροι από 3.600 ασθενείς που έχουν ελεγχθεί για μεταλλάξεις? Είναι μήπως οι ελληνικές και διεθνείς συνεργασίες? Οι πολυάριθμες ημερίδες και οι 480 εκχωρημένες αιγίδες? Η ΕΟΠΕ δεν είναι μόνο αυτά. Είναι πολλά περισσότερα. ΕΟΠΕ είναι το πάθος και η αφοσίωση. Είναι το όραμα και οι στόχοι. Είναι η αστήρευτη ενέργεια και η καινοτομία που μας καθοδηγεί απέναντι σε έναν κοινό εχθρό, τον καρκίνο. ΕΟΠΕ δεν σημαίνει απλά εταιρεία ογκολόγων παθολόγων Ελλάδας. Σημαίνει ελπίδα για καλύτερη ποιότητα ζωής. Σημαίνει πρόληψη και ίση πρόσβαση στη θεραπεία που αποτυπώνονται σε χαμόγελα και αγκαλιές συνανθρώπων μας. Και αυτό σημαίνει τα πάντα για εμάς. ΕΟΠΕ. Δίπλα στον συνάνθρωπο, απέναντι στον καρκίνο.
Από κανέναν δεν μπορεί να αφαιρείται το δικαίωμα στην ελπίδα. Γι' αυτό και εμείς στην Ελληνική Ομοσπονδία Καρκίνου συμπορευόμαστε με τους ανθρώπους που νοσούν από καρκίνο, γιατί συναισθανόμαστε τις ανάγκες, συνδημιουργούμε το πλαίσιο και συνεργαζόμαστε με όλους τους φορείς ώστε να έχουν άμεση πρόσβαση σε έγκαιρη διάγνωση, κατάλληλη θεραπεία, ψυχολογική υποστήριξη και ομαλή επανένταξη στην κοινωνία και την εργασία. Ελληνική Ομοσπονδία Καρκίνου. Ο άνθρωπος στο επίκεντρο. Μάθε περισσότερα στο elok.org.
How far must we go to find answers, to discover new medicines and vaccines, and foster a place where science, curiosity, invention, and humanity converge? This is where extraordinary breakthroughs happen. We've been preventing and treating life-threatening diseases for over a century. We've pioneered new antibiotics and led practice-changing research for childhood diseases, cancer, HIV, heart disease, and diabetes. And we're only just getting started. Every day, our scientists from all backgrounds and disciplines work together to use the power of leading-edge science to save and improve lives. Because we believe research is the will to conquer the impossible. And that science will lead the way.
Στη Νόβα χτίζουμε το μέλλον με αξίες, με κοινωνικές δράσεις που αφήνουν ένα θετικό αποτύπωμα στους ανθρώπους, στην κοινωνία και στο περιβάλλον. Εταιρική υπευθυνότητα και βιώσιμη ανάπτυξη. Μια στρατηγική επιλογή που εδραιώνει την παρουσία μας στην κοινωνία και μας κάνει μια πραγματικά μεγάλη εταιρεία. Συνεχίζουμε δυναμικά.
Check this out. It hasn't been such a long time since people first started shopping online, and it was easy to keep up with the clicks. Little by little by little by more, the clicks added up to be more than the stores, and e-tailers worked harder than ever before because they had to keep up with the clicks. The clicks came from laptops, then tablets and phones, Monday through Sunday, office and home, 24 hours in every zone, and still they kept up with the clicks. Now shoppers ask more from the websites they're on, their language, their currency, their way, or they're gone, so you'd better keep up with the clicks. All of a sudden, there are so many must-dos if you want to keep selling, like delivery there, no there, or there.
And make it tomorrow. First thing.
No time for borders. Gotta stay in control, to stay in the flow and continue to grow. But we'll help you. Keep up with the clicks.
Τι είναι η ΕΟΠΕ? Είναι απλά τα αρχικά μιας ακόμα ιατρικής εταιρείας? Είναι τα 36 χρόνια συνεχούς παρουσίας? Τα 380 μέλη? Τα 26 πανελλήνια συνέδρια? Οι 122 υποτροφίες και τα 180 ερευνητικά προγράμματα? Οι 7 εκδόσεις θεραπευτικών πρωτοκόλων? Οι περισσότεροι από 3.600 ασθενείς που έχουν ελεγχθεί για μεταλλάξεις? Είναι μήπως οι ελληνικές και διεθνείς συνεργασίες? Οι πολυάριθμες ημερίδες και οι 480 εκχωρημένες αιγίδες? Η ΕΟΠΕ δεν είναι μόνο αυτά. Είναι πολλά περισσότερα. ΕΟΠΕ είναι το πάθος και η αφοσίωση. Είναι το όραμα και οι στόχοι. Είναι η αστήρευτη ενέργεια και η καινοτομία που μας καθοδηγεί απέναντι σε έναν κοινό εχθρό, τον καρκίνο. ΕΟΠΕ δεν σημαίνει απλά εταιρεία ογκολόγων παθολόγων Ελλάδας. Σημαίνει ελπίδα για καλύτερη ποιότητα ζωής. Σημαίνει πρόληψη και ίση πρόσβαση στη θεραπεία που αποτυπώνονται σε χαμόγελα και αγκαλιές συνανθρώπων μας. Και αυτό σημαίνει τα πάντα για εμάς. ΕΟΠΕ, δίπλα στον συνάνθρωπο, απέναντι στον καρκίνο.
Από κανέναν δεν μπορεί να αφαιρείται το δικαίωμα στην ελπίδα. Γι' αυτό και εμείς στην Ελληνική Ομοσπονδία Καρκίνου συμπορευόμαστε με τους ανθρώπους που νοσούν από καρκίνο, γιατί συναισθανόμαστε τις ανάγκες, συνδημιουργούμε το πλαίσιο και συνεργαζόμαστε με όλους τους φορείς ώστε να έχουν άμεση πρόσβαση σε έγκαιρη διάγνωση, κατάλληλη θεραπεία, ψυχολογική υποστήριξη και ομαλή επανένταξη στην κοινωνία και την εργασία. Ελληνική Ομοσπονδία Καρκίνου. Ο άνθρωπος στο επίκεντρο. Μάθε περισσότερα στο elok.org.
How far must we go to find answers, to discover new medicines and vaccines, and foster a place where science, curiosity, invention, and humanity converge? This is where extraordinary breakthroughs happen. We've been preventing and treating life-threatening diseases for over a century. We've pioneered new antibiotics and led practice-changing research for childhood diseases, cancer, HIV, heart disease, and diabetes. And we're only just getting started. Every day, our scientists from all backgrounds and disciplines work together to use the power of leading-edge science to save and improve lives. Because we believe research is the will to conquer the impossible. And that science will lead the way.
Στη Nova χτίζουμε το μέλλον με αξίες, με κοινωνικές δράσεις που αφήνουν ένα θετικό αποτύπωμα στους ανθρώπους, στην κοινωνία και στο περιβάλλον. Εταιρική υπευθυνότητα και βιώσιμη ανάπτυξη. Μια στρατηγική επιλογή που εδραιώνει την παρουσία μας στην κοινωνία και μας κάνει μια πραγματικά μεγάλη εταιρεία. Συνεχίζουμε δυναμικά.
Check this out.
It hasn't been such a long time since people first started shopping online, and it was easy to keep up with the clicks. Little by little by little by more, the clicks added up to be more than the stores, and e-tailers worked harder than ever before because they had to keep up with the clicks. The clicks came from laptops, then tablets and phones, Monday through Sunday, office and home, 24 hours in every zone, and still they kept up with the clicks. Now shoppers ask more from the websites they're on, their language, their currency, their way, or they're gone, so you'd better keep up with the clicks. All of a sudden, there are so many must-dos if you want to keep selling, like delivery there, no there, or there.
And make it tomorrow, first thing.
No time for borders. Gotta stay in control, to stay in the flow and continue to grow. But we'll help you. Keep up with the clicks.
Τι είναι η ΕΟΠΕ? Είναι απλά τα αρχικά μιας ακόμα ιατρικής εταιρείας? Είναι τα 36 χρόνια συνεχούς παρουσίας? Τα 380 μέλη? Τα 26 πανελλήνια συνέδρια? Οι 122 υποτροφίες και τα 180 ερευνητικά προγράμματα? Οι 7 εκδόσεις θεραπευτικών πρωτοκόλων? Οι περισσότεροι από 3.600 ασθενείς που έχουν ελεγχθεί για μεταλλάξεις? Είναι μήπως οι ελληνικές και διεθνείς συνεργασίες? Οι πολυάριθμες ημερίδες και οι 480 εκχωρημένες αιγίδες? Η ΕΟΠΕ δεν είναι μόνο αυτά. Είναι πολλά περισσότερα. ΕΟΠΕ είναι το πάθος και η αφοσίωση. Είναι το όραμα και οι στόχοι. Είναι η αστήρευτη ενέργεια και η καινοτομία που μας καθοδηγεί απέναντι σε έναν κοινό εχθρό, τον καρκίνο. ΕΟΠΕ δεν σημαίνει απλά εταιρεία ογκολόγων παθολόγων Ελλάδας. Σημαίνει ελπίδα για καλύτερη ποιότητα ζωής. Σημαίνει πρόληψη και ίση πρόσβαση στη θεραπεία που αποτυπώνονται σε χαμόγελα και αγκαλιές συνανθρώπων μας. Και αυτό σημαίνει τα πάντα για εμάς. ΕΟΠΕ, δίπλα στον συνάνθρωπο, απέναντι στον καρκίνο.
Από κανέναν δεν μπορεί να αφαιρείται το δικαίωμα στην ελπίδα. Γι' αυτό και εμείς στην Ελληνική Ομοσπονδία Καρκίνου συμπορευόμαστε με τους ανθρώπους που νοσούν από καρκίνο, γιατί συναισθανόμαστε τις ανάγκες, συνδημιουργούμε το πλαίσιο και συνεργαζόμαστε με όλους τους φορείς ώστε να έχουν άμεση πρόσβαση σε έγκαιρη διάγνωση, κατάλληλη θεραπεία, ψυχολογική υποστήριξη και ομαλή επανένταξη στην κοινωνία και την εργασία. Ελληνική Ομοσπονδία Καρκίνου. Ο άνθρωπος στο επίκεντρο. Μάθε περισσότερα στο elok.org.
How far must we go to find answers? To discover new medicines and vaccines, and foster a place where science, curiosity, invention, and humanity converge. This is where extraordinary breakthroughs happen. We've been preventing and treating life-threatening diseases for over a century. We've pioneered new antibiotics and led practice-changing research for childhood diseases, cancer, HIV, heart disease, and diabetes. And we're only just getting started. Every day, our scientists from all backgrounds and disciplines work together to use the power of leading-edge science to save and improve lives. Because we believe research is the will to conquer the impossible. And that science will lead the way.
Στη Nova χτίζουμε το μέλλον με αξίες, με κοινωνικές δράσεις που αφήνουν ένα θετικό αποτύπωμα στους ανθρώπους, στην κοινωνία και στο περιβάλλον. Εταιρική υπευθυνότητα και βιώσιμη ανάπτυξη. Μια στρατηγική επιλογή που εδραιώνει την παρουσία μας στην κοινωνία και μας κάνει μια πραγματικά μεγάλη εταιρεία. Συνεχίζουμε δυναμικά.
Check this out. It hasn't been such a long time since people first started shopping online, and it was easy to keep up with the clicks. Little by little by little by more, the clicks added up to be more than the stores, and e-tailers worked harder than ever before because they had to keep up with the clicks. The clicks came from laptops, then tablets and phones, Monday through Sunday, office and home, 24 hours in every zone, and still they kept up with the clicks. Now shoppers ask more from the websites they're on, their language, their currency, their way, or they're gone, so you'd better keep up with the clicks. All of a sudden, there are so many must-dos if you want to keep selling, like delivery there, no there, or there.
And make it tomorrow. First thing.
No time for borders. Gotta stay in control to stay in the flow and continue to grow. But we'll...
Ladies and gentlemen, welcome back. I know better than to try and separate a Greek from their coffee. All the same, please take your seats. Rejoin us. We're about to get going again. Little by little, nearly there. Mary's on her way back. We've got to give her a chance to get to her seat. Not yet. Not yet. 1 second. Okay, here we go. Our next session, we talked previously in the last session a little bit about prevention. This time we're going to talk about early detection of cancer, such an important step in the whole process. It goes without saying, the earlier we can get to a cancer patient, the earlier we can get to diagnosis, the better the chances of survival, the better the chances of a good outcome. So I'm going to invite our panel up onto the stage to join me for this next session. First up we have Anastasios Boutis, who is the Consultant Medical Oncologist and Director of the 3rd Medical Oncology Department. I'm not going to give the full details because there are so many. He is such an accomplished gentleman. Please come in and join me. Christos Leonis, who is the Emeritus Professor, General Practice and Primary Healthcare at the School of Medicine at the University of Crete. Christos, please come and join us. Christos is joining us remotely.
I'm online.
You're welcome, Christos. Sofia Ayelaki, who is the Professor of Medical Oncology at the University of General Hospital of Heraklion. Other titles as well, Sofia. I'll leave you to introduce yourself to the extent required. And commentators on the presentations from our experts today are Dimitris Nikas, who is the Managing Director at Medtronic Hellas. Please come and join us, Dimitris. Stylianos Loukidis, who is the President of the Hellenic Thoracic Society and Professor of Respiratory Medicine at the National Kapodistrian University of Athens Medical School. In this sector, nobody's got just one job. Everybody's got multiple roles here. And we have Michalis Karamoussis, who is the Medical Oncologist Professor at the Medical School at the National and Kapodistrian University of Athens. Michalis, welcome. Okay, let's get going. What I'm going to do is ask each of you to give your introductory words on this area of the value of early detection of cancer. I am going to ask you to stick to time, because if you stick to time, then I don't have to be rude and hook you off early. So let's start off then. We'll go in order. We'll start off with Anastasios, please.
Μπορώ να έχω την παρουσίαση. Λοιπόν.
It is a great honor to be with you for a 4th consecutive year to this economist event where we join our forces and we contribute with our personal efforts in the fight against cancer. We have discussed a lot the importance of prevention and early diagnosis. I'll discuss a bit the pre-symptomatic monitoring and detection. So cancer prevention essentially is to avert the onset and the diagnosis of the disease at a later stage, where a more radical treatment is available. And of course, this impacts on the quality of life and life expectancy of the patient. On our part, as medical oncologists, practically, in terms of prevention and early detection, we are involved in many different ways. Even in our daily activities, we are called to give answers to many different questions relevant to the field. As mentioned earlier, this involves different gaps in the primary health care and the medical literacy field. The early detection programs may improve the rates of mortality, the need for hospitalization, and of course the need of making available resources when cancer is diagnosed at a later stage. Thus, we need to detect cancer before all those issues are present, which impact on the patient himself, herself, her family, and the system. The tools we use, you can see at the bottom of the slide that we want them to be cheap, fast, simple, without requiring strong resources, and we want them above all to be safe. Multiple long-term trials have demonstrating the value of those tests in the early detection of cancer, and thus the radical treatment of cancer. First of all, mammography, which was established by FOFI Genimatab program. The second one, PAP test and HPV testing. Together with the Oncology Society, we have joined this vaccination plan for early age groups, colonoscopy, and of course
τις μεθόδους, και είναι κάτι το οποίο επίσης αποτελεί αντικείμενο του καρκίνου.
PET scan, just PET scan, together with the Lung Society that try to establish it in our country as well. I do not wish to tire you longer because the topic of my presentation has already been developed earlier. It is clear that screening programs are valuable both for the individuals and the entire community. On our part, as Pathologist Oncologist Society, we try to help the state and promote the early detection programs. In that spirit, this year we have funded a broadcast campaign on cancer prevention, promoting the typical trials and measures that I have shown earlier. Thank you very much.
Fantastic. Keeping to time. I saw it click to zero just as you finished speaking. I'm full of admiration and gratitude. So let's move across to Christos Leonis. Christos, thanks for joining us remotely. It's good to see you. Please give us your thoughts on this topic, please.
Thank you very much. I feel very privileged. I hope that you've seen my my Q slides presentation. Is that okay?
Yes, we can see it.
Oh, thank you very much. Could you allow me in speaking into Greek? I feel very privileged having your coordination and your chairmanship. I think καταρχάς να ζητήσω συγγνώμη που δεν είμαι κοντά σας.
First of all, apologies for not being with you. Medical issue, personal medical issue obliged me to stay at home, and I missed the company of my colleagues during this event. So in my presentation, I'll focus on the role of the primary health care in the early detection of cancer. Just 2 slides, what we know and what we need to do. What we know, well, the literature is based on research articles supported by our university here in Crete. And, well, we've got knowledge, attitudes, and behaviors that differ between rural and urban areas in our countries. There are differences in terms of knowledge of the doctors themselves in the medical centers as opposed to those that are in specific selected departments in hospitals. And the clinical practice and attitude of professionals, either GPs or of other specialties in the primary health care, after having enjoyed an education which focuses on parameters that affect their health, smoking and so on and so forth. In Greece, in other words, we do have methods that may influence the clinical practice of professionals or employed in the in the healthcare system, primary healthcare system. There are several proposals as of the role that those professionals may put forward in terms of prevention and early detection. Moreover, in our university, we have developed a digital cancer file which appears that may help in monitoring specific cancer types and support early detection decision making. So this is our knowledge. In other words, we do have a strong piece of knowledge. It is clear. This is in place thanks to so many scientists having dedicated and invested lots of efforts. Now, what do we need in order to promote the importance of early detection based on our resources and our capacities and education? We need a new organizational operational model in the primary health care. Our proposal from the University of Crete and the social medicine sector is as follows. We have asked for contracts, agreements that shall engage upon educational terms and payment terms the doctors in line with indicators and the concept of pay for performance. There has been a long debate. There are several actions in place thanks to the International World Organization, Health Organization and our ministry. However, there's a long way ahead. Lots of consensus, cooperation and an efficient debate so that we move forward with a new operational organizational model in the primary health care. We need a continuing learning program in the primary health care on prevention and health promotion, focusing on methods and techniques that may allow patients, people, individuals by and large, to change their attitude by utilizing the good practices in our country, because we do have several good practices that may we may use them as a model. We may build proposals. We may use them as proposals to put in place a new health promotion program in cooperation with Pathology Oncology Society and together with all professionals involved in the fields, be them lung experts or other societies that have already undertaken excellent actions on early prevention, prevention and early detection. Of course, we need to change, overturn the entire, the overall attitude of people, and for this reason we need to invest on health education. And to conclude, we need to develop an holistic digital cancer file where all doctors may be having access and use the population control programs that are already in progress in our country, together with the patients and their families, to have an assessment of a priori probability, a symptom, something indicating or something which is for by the medicals in doctors in order to avoid to avert the condition to progress. I thank the economists for providing this opportunity to myself, my colleagues, to discuss this topic once again. Thank you.
Thank you, Christos. Let's move along straight to Sophia Yelaki. Will you give us your thoughts, please, here? Try and stick to time if you can.
I'll try. Μπορώ να έχω τις διαφάνειες, παρακαλώ.
So, I'd like to thank you for this honoring invitation to take part in this important congregation aiming at promoting the medical outcome of cancer patients. Of course, early detection is very, very important, because when we talk about improving the quality of life for cancers, when we talk about the survival rates, this means early detection. In our case, we're talking about early detection through screening tests and by means of early diagnosing cases of patients with specific symptoms. So, diagnosing and treating cancer is a top priority for the various NHSs, but most patients, as you already know, especially the ones in countries where the NHS is quite, the primary healthcare is robust, can have this early diagnosis, but it's quite complex because cancer is rarely diagnosed compared to benign cases which primary healthcare physicians have to deal with. Some cancers may come to the medical practice with specific symptoms, but there are some other cancers displaying some non-ordinary symptoms, so the clinical manifestation of this cancer may differ from one case to another without allowing for an early diagnosis. In any case, late diagnosis is related to increased stress, and of course means higher rates of mortality and increased costs. So, in an effort to identify these various specific time periods, let's say that the primary care interval is the time between a patient first presenting in primary care and secondary care referral. And the diagnostic interval is the time between the first presentation in primary until the final diagnosis of cancer. But it has been found that the pathway from the symptom to the diagnosis has many steps, and actually from screening to diagnosis involves various steps and variants. And these variants may occur at different or diverse stages during, before the diagnosis, and these variants or variations might be either systematic or random. They may be due to the patient himself or herself or the population group under test. This might have to do with practices of the physician or with the healthcare organization, secondary or primary healthcare in our case. In an effort to reduce, to mitigate these parameters that may affect the patient's pathway to diagnosis, various countries around the a specific referral system. Actually, it's a three-legged referral strategy. It's a roadmap from primary care teams for primary care teams to the final diagnosis. This might involve cases of patients with very high-risk symptoms or cases of patients with non-specific symptoms. The same applies to another pathway that has to do with patients presenting vague symptoms. So, all these predetermined pathways have allowed us to reduce the waiting time for patients. They have allowed us to have better collaboration between primary and secondary health care. These models have increased satisfaction and the quality of treatment, and of course the survival rates. There's such a system also in the context of NHS. They have a very quick diagnosis pathway for threatening symptoms, and there's another system for symptoms that are not that ordinary. But having a system is not enough. We have to make sure that the system is implemented. That's why NHS came up with specific guidelines so that this system is properly put in place, and as a result reduce the inequalities between population age groups or regions, as long as the system is properly implemented. In the case of Sweden, there is a way to assess the performance of the system, and it shows that the specific parameters in various levels or in various stages of the system that affect the implementation, and all these individual levels of the system have to coordinate so that the patient's referral to diagnosis and treatment is ameliorated, is improved. For instance, certain pathways have to be revised. For instance, the urological cancer pathway did not deliver. No more than 15% of 10,000 patients were diagnosed with bladder cancer, according to the procedures that the pathway provided for. There is an extremely complicated system that leads to better outcomes in the case of cancers. And this system involves all these parameters. In some cases, early diagnosis means the world. In some others, early diagnosis is not, or detection is not possible. So we have to improve the availability of specific treatments or the increase of our experience so we can have a better outcome. Let me close with this slide. This is the current state of health in Greece. We can discuss about that. So the pathway of a patient with cancer in Greece looks like this case. It's a pathway through the maze of procedures which are not specifically determined. And let me close with the Alma Alta's declaration, according to which, in order to have the highest state of health, the most important thing is to have a collaboration of the social and economic sector together with the health sector so that the final outcome is the best possible one. Thank you.
Admirable effort to condense an awful lot of information there into what I apologise for the brevity of the time we were able to offer, but that was superb. So an awful lot of complex material that we've seen, that we've been presented with. I'd love briefly to hear your comments on what you've heard and your thoughts on this area. Let's start with Dimitris from Medtronic.
Thank you. The presentation, please. You have it. Okay. Αλλάζω στα ελληνικά. Θέλω να...
I'd like to thank the organizers for this really honoring invitation, and because you enable me to discuss specific tools that might drive early detection and diagnosis of colorectal cancer. Medtronic is a top company in medical devices. It's a brand new sector for us, actually. And I'd like to thank you for allowing me to add my own bit, my own tool to cancer diagnosis, especially in the case of colorectal cancer. So, stats. 341,000 patients of colorectal cancer in Europe every year. But there is a percentage, approximately 10,000 patients, who are diagnosed with cancer following colonoscopy. It's a post-colonoscopy colorectal cancer case. This is the population we have to target. We have a specific solution for that. Of course, we have millions of colonoscopies performed every year in Europe. And thanks to these screening programs, and of course, thanks to the technological advancements and the skilled experts, we have some great results. But in order to minimize the PCCR incidence, so in other words, if we can have in order to have 89% of the PCCRs avoided, then we propose the GI Genius tool. It's a software and a hardware as well, which are AI enabled. So what we want to do is to help the doctor protect patients. GI Genius is loaded with 13 million colonoscopy images. So when the colonoscopy takes place, the camera used by the physician compares the image with the image bank, so we can identify adenomas that cannot be easily identified. In the first case, you see an adenoma that the doctor detects, and the GI Genius helps him. A second image. It's and another clip. The second one is a non-adenoma. The third one is an adenoma, because the software compares what the doctor sees with the data bank. So GI Genius is not here to replace the doctor. No, it brings a second. It gives us, let's say, a second pair of eyes, a second opinion to help the doctor, and enable him to have an assistant in his daily practice in order to proceed with the right decision making. Both these programs, which are based on machine learning, financially speaking, it has been found that in the US can help us have an 85 million euros worth of savings. So these tools are very important. Medtronic has already signed a contract with NVIDIA. NVIDIA is the top artificial intelligence company worldwide, in order to improve these applications and integrate other tools already in use by the doctors, in order to use other indicators before the colonoscopy. For instance, the duration of colonoscopy, the preparation period for the patient. So the future is driven by artificial intelligence and machine learning. So this will help a lot all health professionals and physicians to better diagnose cancer cases. Thank you very, very much.
Digital tools that we're beginning to get used to in every area of life are already coming into use in medical practice. So thank you very much for that. Let's move along to Stylianos Loukidis, please.
Okay, thank you very much for the invitation. I don't have any slides, but I will summarize my comments.
So, let me take you back in time. It's March 2021. In Greece and around the world, we've been talking about TOVIC and nothing else. So, it was the moment when a team coming from the pneumological department of Greece, of the Society of Lung Experts in Greece, in order to discuss the outcomes of our experience from COVID. What was the value we took out of that? Was it the implications of COVID or just the discovery of new conditions? And the reply was simple: the discovery of new conditions. So we used to find lung cancers, other diseases, preliminary symptoms of other conditions affecting the cardiovascular system. So we assessed the value of screening tests, which we already knew by means of studies. So the team of ours involved thoracic surgeons, pulmonologists. We have had representatives from HESMO, the Cancer Patient Association, Fairlife supporting us, and together we decided to do something about that. We entitled it Determining the Limits of Lung Cancer in Greece. It took a few months, and in July we submitted to Mrs. Kotanidou, the interim Minister of Health, an action plan. The action plan has two pathways. A, procedures. How is the patient referred? And we have the clinical part, which means what I see and what I do about each case. This action plan is definitely finalized. It's already published. A few hours ago, we finalized the work teams that will be involved in the pilot program of pre-screening controls tests. So the minister currently has all the details, everything they need in order to implement the program. I think that's something that will be beneficial to anyone. Let me close with a couple of things which are quite important. Last year, we presented a plan in a conference in the US, and two things were quite amazing. A, very low attendance. No more than 10% of the population. Actually, we have had less than 10% of the population who was eligible. The second finding was medical. Everybody was focusing on cancer and nobody had an eye for the other symptoms. So this action plan affects both cancers and other diseases. So by means of this well-determined action plan, as I said, we submitted that to the Ministry of Health already. It involves AI algorithms. I don't have to go granular on that. We're talking about very detailed stuff that relate to how the patient is referred, how the radiologist makes the diagnosis, how the primary healthcare GP is informed. Actually, we submitted an application to the General Practice Society to train the primary GPs on that. And then the interrelation between all specializations involved, because that's the thorny part, clinical assessment and evaluation. So should we apply that? Even at the pilot stage, initially, I think it will bring us nothing but great benefits, because we will be able to discuss about cancer cases, which for us, pulmonologists and the ones that come later on, is a very tricky issue, but currently we have a lot of tools to fight it. For instance, invasive pulmonology, imaging. So if we add all these tools in a preventive framework, we will have a lot of benefits to reap. Thank you.
Aldis, your thoughts, please.
Yes, thank you. I don't have any slides, δεν έχω slides.
I think all previous speakers identified the issue of early detection. Let us say that Hippocrates was the first who identified the importance of prevention. We're talking about primary prevention, which means eradicating the causes of a disease, and secondary prevention, which has to do with early diagnosis. Contrary to what Mr. Loukidis said, lung carcinomas, which are very, very important, especially when it comes to finding their reasons. When we talk about neoplasma and tumors in the intestinals, we have seen that hereditary reasons may play a very important role, 10-15% of the cases. If that is combined with environmental issues that relate to specific neoplasmas per region, geographical region, and that's something that has been found in the Greek territory as well. I think this makes quite necessary to collaborate, to have a collaboration between primary GPs who have to have this ongoing training framework provided by Oncological Society or the Pulmonology Society or the Ministry, because as the previous speaker said, now we do have the tools available in order to have early diagnosis. But perhaps we need to walk along a specific pathway, an algorithm-enabled one, so that this early detection will have some substantial value for the patient. And I agree, it's not just about malignancies. There are other things we might find along this pathway, and I believe that collaboration and the establishment of a very simplified algorithm will help us in the future in order to early diagnose cancers and other conditions in the Greek population. Thank you very much for the invitation.
We've got a very limited amount of time, so I'm really going to ask you to be rapid with your responses to my question at this point. What I'm interested in is you've spoken an awful lot about the technicalities, a lot of data that we've seen, machinery that's available. What I want to understand is what's required of the government today to ensure that we get to where we need to get to in this area. So we started out the day with the health minister here on stage with us. Imagine he's still here. You've got a few seconds to make a single point to the health minister where he should prioritise in terms of public policy over the coming couple of years. Start with you.
Well, I believe that the most important is what has been already mentioned by Mrs. Agapidaki, that in modern early detection systems, the old model is not enough, one test off. We need to take into account an algorithm, a path that needed to be in place after the initial test, leading us safely to a diagnosis and eventually treatment of the condition. Christo. Mrs. Agapidaki has a very integrated picture concerning the skills that must have a GP, a primary healthcare physician, the attitude that must be changed, the attitude of the patient himself in a way that may guarantee her health. In other words, investing in the education of healthcare professionals, specific proposals that we do have already prepared for consultation. Greece does possess tools, digital tools to contribute in this process, but it shall take some time. It takes time. We can't have dramatic changes of clinical practices overnight. However, the investments in education, taking into account the RRF availability, may help us in changing our culture.
Sophia, one area.
The organization of specific paths which may guarantee early detection for an effective treatment. So this is the area where the administration needs to focus, and beyond the institutionalization of infrastructures, of programs, of whatever, the state needs to guarantee access to this path so that all individuals, all citizens are given equal access. This requires investment not just in the field of finance, but in the social field, and of course cooperation between all those fields that may ensure a good outcome. Those services and the outcomes need to be assessed and taken into account accordingly. Thank you.
They want to applaud. Who am I to stop them from applauding if that's what they want to do? Dimitris, your thoughts. Medtronic, where would you like to see?
Sure.
About an approach based on patient pathway. This is very important for an holistic view of patient journey. Secondly, a more digitalized healthcare system, in order to have data, in order to have solutions, and being able to use all the data. And third thing is, of course, for us, is the reimbursement of digital solutions like what I presented before. Yeah. It's very important to have a reimbursement pathway for this type of solutions.
Okay, brilliant. Thank you. Stylianos.
Well, Mr. Agapidaki is knowledgeable of the topic. We have discussed it several times, so the administration needs to guarantee the education, the good implementation and the quality, because unless the program is implemented properly, it shall eventually lose its value.
Kallis.
Well, I fully agree with all previous speakers. The processes needs to be simple, certified, ensuring the best possible outcome, combined with the education of the overall population, so that the individuals know why it is there, the program, why it exists.
Much. Forgive me for the lag there. I think it's a satellite issue. Okay. Stay with me, please, while we move on to a brief presentation from Roberta Savli, who's the Executive Director of Public Affairs at the European Federation of Pharmaceutical Industries and Associations, who's going to join us remotely to talk about EU pharmaceutical legislation revision and the opportunities arising for innovative therapies. Roberta, the floor is yours.
Hi, good afternoon, everyone. I hope you can hear me properly, and I will try now to share my screen. I hope it works. It doesn't work, so I probably need to ask the organizer some help with the presentation.
Do we have Roberta's presentation available to put up on the screen? Perhaps not. Roberta, are you able to...
I can do without presentation, of course. So first of all, as I said, thank you very much, and it's a great opportunity to be here, and I'm very happy to present this specific point about the pharmaceutical legislation. So if we think back of what has happened over the past 5 years during this mandate, probably COVID-19 has revolutionized the way we look about health and the impact of health on our economies, as well as the value of innovation in health. We had the first COVID-19 vaccine not even a year after the World Health Organization had proclaimed the global pandemic. And of course, COVID-19 also put back the issue of open strategic autonomy of Europe on our agenda. So based on all of that, at the end of April last year, the European Commission published the complete revision of the pharmaceutical legislation. And we, as the innovative pharmaceutical industry, we believe and we welcomed that revision. We thought that it was an opportunity to modernize the regulatory framework and to attract back innovation to Europe. Just wanted to give you a couple of numbers. So at the end of last century, Europe was the pharmacy of the world. We were producing half of the innovative treatments worldwide. Now, not even 25 years after, this number has reduced to 1 in 5 new medicines being produced in Europe. So we have seen a worrisome erosion of the R&D base in Europe that has moved to other regions of the world. Thinking about clinical trials, and in particular clinical trials for advanced therapies, we know that the United States ran 2 times more clinical trials than Europe, and China 3 times more clinical trials on ATMPs. So of course, we need to do something. We need to make sure that this innovation is cut back and attracted back to Europe. Another thing is the regulatory framework. We know that the European Medicines Agency is unfortunately one of the slowest regulatory agencies. The citizens, patients in Europe have to wait almost double than patients in the United States to have the opportunity to have treatments and innovative treatments approved by the European Medicines Agency. And we also know that the use of expedited pathways in Europe is much lower compared to other regions of the world. It's only 9% of the cases. In the US, the FDA uses it in 71, so you could see there is a clear difference. So putting together all of that, we believe that the revision of the pharma legislation is needed, is a once-in-a-lifetime opportunity. The previous revision dated back 20 years ago, so we really need to do something. And we have seen in the Commission proposals some positive improvements, in particular thinking about streamlining the European Medicines Agency processes, cutting the approval timelines, introducing the concept of regulatory sandboxes to regulate all those innovations that are at the intersection between pharmaceuticals, medical devices, artificial intelligence. For the first time, Europe will be probably the first region that actually gets transferable exclusivity voucher to incentivize the development of novel antibiotics. We haven't had a new antibiotic since 1984. And we know that the antimicrobial resistance is being considered as probably the next pandemic. So we need to do something. We're happy to see that in the legislation there are some proposals to address that. So there are a lot of positive things. There are a few concerning things as well, and particularly the fact that the Commission is proposing to reduce the protection needed to develop certain products, both for rare diseases as well as for medicines in general. And we had done in FPA a report, we published a report at the end of last year and realized that if all of the proposals that the Commission put on the table would be implemented, the risk is that 50 out of the 225 new medicines that should be developed and would be developed in Europe over the next 15 years would be forgone. So just to conclude, I think that we need really to make sure that we get things right with the revision of the legislation. We are regulating the way we develop, the way we research, the way we approve, and the way we manufacture medicines in Europe for patients for the next 20 to 30 years. And this is important, and it matters for European patients, but it also matters for the systems, for the health systems and their sustainability, and for our economies. So I'll stop here and looking forward to the discussion. Thanks.
Thank you very much.
Sorry for the technical problems with the presentation.
Don't worry, we didn't really notice. You gave a fantastic presentation. Thank you very much, Roberta. We're going to move on to our next session, which Mary again is going to moderate. But before we do move on, please do join me now in thanking Roberta and the rest of our panel. Thank you very much, ladies and gentlemen.
Kalispera. There is and can be life after cancer. Please allow me to share a personal and treasured example. My mother, Susan Bussell, had breast cancer at the age of 39. Today, this day, she celebrates her 93rd birthday. Ευχαριστώ. 54 years after being treated for breast cancer, she is, and she's in our audience today. She is my inspiration, and she is an inspiration to so many. So happy birthday. As it has been said, if we have to wait for people to get sick to figure out where to target government outreach, it is too late. Early diagnosis is critically important to maximize the opportunities for success in cancer treatment. Challenges of obtaining early identification can result in delayed diagnosis or a diagnosis that is missed altogether. The European Cancer Organization has noted that the COVID-19 pandemic has resulted in 100 million cancer screening tests being missed. And they predict that the pandemic will be the cause of 1 million cancer diagnoses in Europe alone. We must address the lack of access to screening, early detection, diagnosis, and treatment. We need to improve policies to support systems that ensure sustainable and equitable access. The link to poor access to care and poor health outcomes is well established. We know this, and it can be due to geography, language, fear, distrust of healthcare providers, and difficulty getting through gatekeeper systems, in addition to the financial barriers. In 2020, the British Medical Journal reported that a 1-month delay in cancer treatment can increase a person's risk of mortality by 10%. Please, may I invite the panelists to the stage for our panel discussion on the value of early diagnosis and the management of cancer. I've been asked to ensure that we finish this panel by 1:20, so to enable everybody to have some lunch. So let's see, if we could please ask the panelists to come up. Michailidis Leonotos, medical oncologist, assistant professor and Department of Clinical Therapeutics at the Oncology Unit of the National and Cappadostrian University of Athens and member of the Board of Directors of HESMO. Eleni Korea, Professor of Pathology, the University of Patras, and the President of the Pathology Society. Flora Bakupoulou, Head of the HTA Committee, the Hellenic Ministry of Health, Associate Professor of Pediatrics and Adolescent Medicine at the National and Cappadostrian University of Athens. Nandia Gogonzoutou, Non-Executive President, EOPYY, the President of the Drug Price Negotiation Committee. Kostas Anathasakis, Assistant Professor of Health Economics and Health Technology Assessment at the Department of Public Health Policy at the University of West Attica. And our commentator, Ilias Anasidatis. He's the medical oncologist and director of the oncology clinic at Mitera Hospital. Thank you. Good afternoon. Yeah, Kalispera. May I please ask you to share your comments, please?
Yes, thank you. May I have my presentation, please? Ευχαριστώ πολύ. Να ευχαριστήσω για την ευγενική πρόσκληση.
Firstly, I would like to thank you for this kind invitation. I will discuss the issue of early treatment of cancer and the impact on clinical outcomes. Truth be told, most cancers have a common pathway. There is some exposure to cancer generating let's say agent or parameter, or some hereditary reason that will evolve into cancer, and this will then lead to some clinical symptoms which, if not treated, will lead to death. This is a common pathway for all neoplasmas. There are different times, let's say, periods with respect to when the the condition is diagnosed, when it is treated, etc. We may intervene along this pathway in order to improve survival or prevent the evolution of cancer. It was discussed before. It is of value to discuss about screening because preventing cancer is the best way to improve survival rates, but this is not always feasible. Using screening tests, we can have very often an early diagnosis of cancer at an early stage. We know that smoking is very important in that. If we can anticipate the condition early enough, then the years to live will be more. But screening is not enough. Population has to be aware of the common symptoms of this condition. Sometimes they are not easy to discern, but we have to urge the population asking for some medical advice and undergo specific medical procedures in order to be able and identify the disease early enough. But there is a trap here. We should not believe that cancer is a disease that becomes systematic after many years. No, it's a systematic disease early enough. So it's very important to identify the biology that leads to more aggressive cancer types, and as a result we have to become more aggressive with these types as well. Now, with respect to my contribution, once the condition is detected, how can we make an early intervention? We know that time is of essence. You know very well that cancer is not a medical emergency, and we have to share that to the general population. If you are diagnosed with cancer, you shouldn't start treated tomorrow morning. You shouldn't start treatment tomorrow morning, but there has to be a specific type plan for every case diagnosed. There are specific time intervals and periods that have to apply. This is a meta-analysis showing that every 4 weeks of delay in the onset of a cancer treatment, this means 10% less possibilities of survival. So early onset of the treatment is very important. There are several parameters that affect the early onset. The patient himself or herself, the fear towards the disease, the stress, or his or her ignorance about what this cancer is about. Some other parameters like COVID-19. That's something that shows in the slide that suddenly many screening tests were in delay and diagnoses were in delay. As a result of COVID, this might have an impact on the kind of stage in which the cancer will be diagnosed and the evolution of the condition. Of course, there are some systemic reasons. I have to analyze them because they relate to our daily life. As Mrs. Angelakis said before, a patient diagnosed has to have a specific pathway with specific milestones, etc. That's something that we lack in Greece. The patient themselves are responsible themselves in order to find their way through the pathway. And there are no specific milestones, or we have no centers of excellence on specific neoplasmas. The references the literature saying that the number of patients treated in a center is very important in order to have high survival rates. We have to understand that. There are specific centers to deal specific neoplasmas. We also have a lack of data. The agreement signed recently for a national cancer patient registry is very important. So we know how many patients there are, how many patients are to start treatment, and how the system should be configured so that the patients are treated per geographical area. Sometimes we are in lack of personnel, facilities, and sometimes we lack the cross-disciplinary, interdisciplinary teams needed. Last but not least, Greece is a particular country because of its geography. So imagine being yourself a patient in the island of Kassos and you have a gastrointestinal hemorrhage, which might mean there is a cancer case. Do you know the time needed in order to be treated compared to someone who lives in an urban city where we have to have the same facilities and the same, let's say, framework to cover for any socioeconomic disparities so that all people can have equitable access to the right treatment. So, some take-home messages. Cancer is not a medical emergency, but early management is of utmost importance, mainly for early disease. Delays in cancer management are associated with worse survival. So we have to improve cancer management, especially early cancer management, because this leads to better survival rates, and we need better data. And we have to emphasize on that so we can build strategies on public health. Thank you.
Ευχαριστώ. Ελένη.
Eleni.
Τις διαφάνειες, παρακαλώ.
I'd like to thank the organizers of this really interesting conference. I'd like to discuss on behalf of the Hellenic Pathology Society. The biomarkers I'm about to mention, like imaging biomarkers, but today we're going to talk about tissue-related ones that have to do with biomolecules that may be detected in tissues or in the blood or in tissue fluids, from which we may also identify the molecules that extracted from the tumor. So, biomarkers. We have three types. Diagnostic ones, very, very important, because as it turns out, even in the case of a neoplasma diagnosis, we need a biomarker. In order to treat specific cases, we have to know whether the IDHs are mutated or not. We have prognostic biomarkers. We have to know how the cancer will evolve regardless of the treatment. For instance, case 67 in the case of breast cancers, and we have the forecasting or foreseeing biomarkers, like in the case of breast cancers, like ER and HER2, which shows us what is the right treatment for this or that treatment. So this is the key for having the so-called precision medicine or precision oncology. This is what will increase the benefits to the patient and reduce toxicities for the patient, and of course at the same time avoid financial or fiscal toxicity for the NHS. In the past we used to have ERP2 for breast cancer. Now we have other biomarkers. They become more and more as knowledge becomes expanded in specific therapeutic settings. In the case of lung cancer, we see the EGFR, KRAS, MET, RET. This is a list that grows bigger and bigger. So biomarkers progressively are increased, and they are the ones who will provide us with the right information about what treatment is suitable for what patient. This is an article comes from 2022. Things have already changed. For instance, you see that in the non-micromolecular lung cancer, 30% of cancers have had a biomarker for biotreatment. Now have reached 40%. 20% of them represent cancers with biomarkers for treatment, the ones in black. In cancer, generally speaking, we know 25% of our cases, this is the black part of the pie, have a biomarker for treatment, and in blue these are the developing biomarkers which become more and more. The gray part covers the cancers with no biomarkers, and this will grow smaller and smaller. And 2019 we have had 70 drugs with biomarkers related, and every year we have 5 to 10 new approvals for biomarker based drugs. Apart from that, we have biomarkers which are specific for cancer. We have biomarkers that are tumor agnostic or histology agnostic or histology independent. Many of them have to do with immune therapies and etc. etc. Many of our patients have no access to biomarkers. You see how the funnel goes? We have micromolecular lung cancer at the beginning, at the top. Then it can be reduced to something more if we use biomarkers, so that some of them, we know that some of them might not have a treatment. Out of those that go through biopsy and tissue is extracted, part of them might have no neoplasmatic tissue available. So we have less and less patients eligible to access to this treatment. And even if we have neoplasmatic tissue, this might not be enough to give us enough information on the treatment. And even if you have this neoplasmatic tissue, access to biomarkers might not be the same for all patients. So the stages for developing biomarkers start from discovery of the biomarker, the analytical validation of it, its clinical validation, which means to make sure that this biomarker is truly linked to a cancer type. Then we have the stage of clinical utility. What are the patients who will be benefited out of this biomarker? And last, the clinical implementation. So, from studying a biomarker, now we have moved to the simultaneous study of multiple biomarkers, which means that we use tissues in many, many ways, and you know, tissues are valuable. And we still have some pending issues in terms of clinical validation and cost for value relations. You see how the biomarkers are developed. It's a very complicated procedure, clinical analysis, assessment of the findings, the review within a study, oncological councils that have to discuss about them. It's a very complicated process. I have to cast light on the issue of biomarker reimbursement. HER2 in breast cancer. You see that? 242 euros. And this data come from other countries. In our case, it's 40 euros. But this is the cost for the treatment. But the cost for the treatment is 44,000 euros. So the cost of the biomarker is 0.055% or something. So the cost of biomarkers is minimal compared to the treatments themselves, which shows the importance of biomarkers, because this study will help us reduce the costs of treatment. There is an effort being made currently from EOP, the Hellenic, the HESMO, and of course in collaboration with other health professionals and members of the academia, health finance experts, in order to update biomarkers. And very soon, I think, apart from this has to do with AI, omics, that's gene-based, okay? Following that, we're going to have some new characteristics like pathological anatomical one. These elements, this data will have to be used by AI as well in order to come up with useful findings about treating the patients. Thank you.
Flora. Καλησπέρα σας. Ευχαριστώ θερμά για την τιμητική πρόσκληση. Thank you very much for the honorable invitation. I'm going to give you a short talk about the impact of the EU HTA regulation in cancer innovation. I will start by saying that the European regulation was adopted in December 2021. From January 2022 up to now and up to January 2025 is in a period where adoptions will be made in several countries, and it's going to enter into application in January 2025. Shall I speak in Greek or in English? Okay. Ο Ευρωπαϊκός Κανονισμός θα ξεκινήσει.
The European regulation shall start with drugs, and then we'll have the assessment of medical equipment. Concerning the assessment itself, it shall be purely clinical, where drugs shall be assessed and the added value in relation with those already existing, together with the medical equipment in place. The non-clinical data shall remain at a national level. There is the financial assessment. The social and moral impact shall be in the hands of the member states. Concerning the regulation, well, this involves simultaneous actions relevant to assessment, and it shall improve the access of patients to innovative drugs. It shall alleviate the administration burden, shall provide benefits for the research community by providing data from clinical trials, and all stakeholders shall enjoy benefits via the establishment of an official debate through the assessment procedure. It shall increase predictability by utilizing the Horizon scan, and it is expected to enhance transnational cooperation in the framework of the European Union. Concerning the activities themselves, they involve the joint clinical assessment. For the first 3 years, they'll focus exclusively on cancer drugs and advanced treatments. As of January 28, we'll have more assessments for orphan drugs, and as of 2030 onwards, we'll have in the assessment all drugs and high-risk medical devices and in vitro medical devices via specific selection. Beyond the joint clinical assessment, in the European regulation, we'll have the joint scientific consultations which shall be taking place while identifying a joint and common procedure and practice at an EU level. There is a section focusing on volunteer cooperation between EU countries on specific selected topics. Concerning the Greek Assessment Committee for Human Use Drugs, as of January 20, the new committee has assessed 1,260 drugs, out of which 340 are original products, and just 8 of them are pending for assessment. On the slides, you can see that the cancer drugs represent almost 15% of the overall drugs, 183 in total, relevant to new active substances, innovative products 88, orphan medicines 24, generics 49, biosimilars 14, fixed dose combination 1, and hybrids 7. Meanwhile, the Greek HTA committee has improved in terms of productivity dramatically. In 2020, the overall products assessed were 125, in 2021 213, 2022 229, and 2023 116, not because the assessments dropped, but because the applications on the part of the industry was reduced. Meanwhile, the committee has succeeded in reducing the time required for assessment, with an average time of 160 days to 2021 123 days, 22 106 days, and now 2023 approximately a month for the assessment of a medical drug as of the time the file is submitted. Thank you. Nadia.
Invitation. I will speak in Greek now.
The negotiation committee is one of the strongest tools of the ministry and of the state itself in terms of savings relevant to the costs, so that the system remains sustainable. The goal, the ultimate goal, is that no patient, of course, be left without the suitable drug. However, to have this concept in place while all new innovative treatments, more expensive treatments are in place, well, we want to be the case and be beneficial for both parties. As a negotiation committee, we have increased, we accelerated our pace, to put it this way. We are becoming more familiar, and well, the legal changes and modifications have helped us in doing so. We have a far better cooperation with the assessment committee, which facilitates the way we receive referrals. And anyway, we are very well prepared to renegotiate agreements that expire. We aim at closed budgets, fixed budget starting from 100 million, which was the amount back in 2020. In 23 we are over 2 billion. Currently we are at 750 million euros, and I do believe that will go higher, up as high as 1.2 billion. And I'm referring always to fixed closed budget. Producing a saving while excluding the rebates. Well, the industry might put it differently, but anyway, this reduces clawback and the excess that we wish to drop further on, to reach the recovery fund goals, or at least improve the situation in terms of the rebates that the companies are required to give back. Thus, we're speaking about a saving starting from 85 million back in 2020 until 700 million, the initial estimate for 2023, and we are quite optimistic that this shall move forward in this way. The closed budget have helped a lot limiting the costs, and by defining development markets. This is an agreement between the Commission and the Ministry, including the responsibility and the risk when there is an excess of this expenditure. Last year, following a calculation of EOP, 343 savings, thanks to the negotiation committee, represented 20 million new investments on research. In other words, it works in favor of the patient and his or her access to new treatment. However, it cannot remain the only tool for limiting and delineating somehow the finance of the ministry. We need medical protocols. We need necessarily biomarkers. This shall show the treatments that are reimbursed, okay, but we need to know how they can be better used for those patients that need it desperately, without any delays that might be against the better possible outcome. And the earlier treatment starts, the earlier the prognosis and the better the medical outcome. All the above leading to the best use of such drugs. Hopefully next year, when we meet, we'll have better developments in place and the best possible news.
Thank you very much. It's always an honor and a pleasure to be in one of the Economist events. It's always a joy to be in a discussion moderated by you, Mary. Ευχαριστώ θερμά για την πρόσκληση.
Thank you very much, Mary. In the few next moments, I'll attempt to share with you some thoughts relevant to the topic I was asked to present by the organizing committee on the need of investment in early cancer care management. Well, the truth is that the term early in Greek for such use might be translated differently. Could be fast, the Greek word, the suitable Greek word, because we are referring to a condition, a disease that has a significant cause, which, according to my opinion, might be attributed different and levels of understanding. Speaking about risk factors, that is quite relevant to the comorbidity. I remind you that 40% of the total mortality involves behaviors and risk factors, all other relevant to hereditary reasons and the healthcare system themselves. So we're speaking about an exposure to risks and the attitude of people. So early actually means the way the system may deal with the exposure to such risks. Promotion, healthcare, or measures such as vaccination that may prevent cancer, or new ones intervening at a behavioral level. One way or another, irrespective to how good we may prove in that field, some segment of the population will develop sooner or later cancer. So the point is how fast we'll detect and the people suffering from cancer at that point. Large part is relevant to the early detection of the disease. Those practices need to be successful, well understood by the people, the population. They need to address all people without any discrimination whatsoever, and indeed most measures focus towards this direction, and of course to what extent we can convince the people to join this effort. Detecting disease, having a diagnosis, lead us to access to treatment, suitable treatment indeed. There again, we are speaking about the availability of a treatment, issues relevant to the sustainability of the healthcare system, and we might need to discuss this topic as well. Other issues relevant to biomarkers, which was earlier explained, we need the Greek healthcare system should not be resolving problems ad hoc. In terms of biomarkers, we need procedures. Unless Mrs. Bakopoulou committee was there, well, we would have an ad hoc assessment procedure which would produce chaos. So, and above all, we needed to maintain the system performant. So, early and fast, well, must prevail. We do have first-line, second-line treatment there again. The issue of early intervention must be studied in relation to clinical trials and, of course, in relation to financial outcomes as well. A financial approach is relevant to cost-effectiveness. Thus, the medical subjects need to consider the financial impact of its action. Recently, we have concluded a study which tried to demonstrate what would be the case if we had a 3 cancer diagnosis and if we had earlier access to P blockers earlier access, and it was measured in line with 2 different factors: early access, later access at the metastatic stage. And we consider the effectiveness and so on and so forth. This study wasn't a cost-effective study. It was a study assessing the cost and the impact on 10 years' time in 15,000 2,000 group of patients. So the early use of treatment would reduce by 25% the recurrence of the disease, by 22% the mortality in 10 years' time, 3% would increase the life expectancy, and 4% the quality of life. In average, in 10 years' time. So I believe that this bit may help us to have well-substantiated and justified decisions, well-informed decisions to allocate resources better, which is a social decision that needs to be sustained necessarily. Thank you.
Now, Ilyas, please provide us some insights and comments.
Mary, χαίρομαι να είμαστε μαζί πάλι και ευχαριστώ.
I'm pleased to be with you, Mary, again on this subject on cancer. The presentations were very well informed, starting from the first one. I would like to say that a patient, the earliest is diagnosed, the better the prognosis, the outcome. Practically, the course of a disease is determined before the diagnosis. Having a good health, overall good health, determines the way cancer may progress at a later stage. You need a strategic plan. For everything else, well, you need to invest on people, on pool of scientists so that we have it in place. Biomarkers is a very important piece of information. In a diagnosis, we include several conditions. The biomarkers somehow read the ID of a tumor, and only thus we can differentiate conditions and diseases. In the course of a disease, you can tell the path, the resilience, the resistance. Thus, I repeat, biomarkers are necessary to have the full ID of a disease, the specific disease with the specific biological features. So we do need biomarkers, and of all people assisting all specialties one another, because one may multiply the mistakes of another or the other way around. This is not an inspiration. Doctors are not inspired overnight and they perform accordingly. Our job is well delineated scientifically upon specific guidelines. We've got the rules, and the biomarkers are well determined themselves. The way to come up with good results is to keep them all at a high level in a way that the quality assurance is fully guaranteed. Speaking about investments in the healthcare sector, well, this means infrastructures. Once you have them, you are prepared to deal with problems. The second one, the great lack in place, is relevant to human resources. It's not just money. In all countries, in Greece included, who haven't got determined oncologists prepared to deal with the disease. So we need somehow to develop them. Certain specialties lag far behind. This is an enormous subject, and on the basis of the last presentations, well, they confirm somehow my saying. And I repeat, we need to ensure the best outcome for each and separate investment. Practically, if we want to have a good care, well, this won't be connected with the inspiration of a doctor. It is connected with new drugs, investments on different treatments, biomarkers, and then you are prepared together with infrastructure and human resources to deal effectively with all different options. You mobilize patients, you mobilize the professionals, you build a momentum for all stakeholders to be well determined to fight cancer. Thank you very much for your presentation.
Everyone today talks about a sustainable financing, and yet there are countries that don't pay for biomarker testing, which is often very inexpensive, as we've heard today on the panel. And they hold enormous opportunity for ensuring that the right, expensive therapies are chosen so that can reduce the costs to the system because you get right to the right treatment. It also reduces the suffering for the patient while they try to figure out from one test to another, from one treatment to another, what's going to really work for their cancer. So biomarker testing is very important. In Belgium, they have an interesting approach to biomarker testing because prior to approving some lung cancer therapies, a patient must have the range of biomarker testing done. Is this sort of strategy workable here in Greece?
It should be.
Yeah?
It's an open
It
question?
should be.
Sorry?
It's an open question for all of us?
Yes, please.
Yes, of course it is. In Greece, you are not allowed to receive specific treatment biomarker guided unless you have the specific biomarker. So a similar policy is followed here for lung cancer, but this is not generalized in all neoplans. I mean, for ovarian cancer, there are tests that may guide treatment, but they are not reimbursed by the state at the time. So we have to have specific protocols and algorithms for the biomarkers that should be reimbursed by the state so as to give the specific treatment to our patient. And should be developed. I mean, new drugs are introduced very often, so we should really adjust our biomarker testing according to the new drugs that are approved.
Because it saves money, it saves time, and it saves the patient suffering, right?
May I add?
Please.
Interestingly, biomarkers are not in the scope of the EU regulation.
So what can we do about that?
Maybe they can fall in the scope of the voluntary cooperation.
Okay, there's something for us to all think about and try to develop the pathway to finding the right route. And let's re-examine that question next year.
Yes.
Okay.
Actually, biomarkers is information. Information is valuable and expensive. So actually, if in our country we collect all the information, if this is an investment from the state or from the universities to collect all the information, this is what is going to develop the next knowledge. Actually, artificial intelligence is working on structured data. So I believe in our country we can invest in this and develop our own knowledge and our own data and have, actually, this is going to be valuable for everybody.
Yes, then Greece really leading the way in oncological care for the future. That would be fantastic. I'm cognizant of the time. Is there anyone with a question, really a direct question that they would like to ask the panel? Stand up if you wish. No? Yes, there's one gentleman there. Please, very, very quick, very, very brief, very, very direct.
Okay. Thank you. My question is, because cancer είναι κυταρικά ετερογενής νόσος.
Is a heterogeneous disease at a molecular level. So, if the histoimmune state of biomarkers is stable or not, because everything depends, as we heard, depends on these biomarkers. So, to what extent is this immunohistological profile of the biomarker stable, especially given that this goes before chemotherapy that might affect the neoplasma? So, do we have codified principles in order to update this profile based on the treatments?
Θα το πω στα ελληνικά.
I will reply in Greek. Cancer indeed is a multiclonal condition. Cancer generates clones, produces clones, and the one that will give us the metastasis might be different to the original one. So what it is recommended is that during the metastasis, we have to review the biomarkers in order to see what we're dealing with. So the profile you mentioned at the beginning might be the same or might be changed. So indeed, in the metastasis case, we have to recheck the biomarkers. This doesn't apply to only a handful of biomarkers. It applies to many. PD-L1, HER2 for breast cancer, etc., etc. So indeed, this is something that has to change. And this has also to be included in our algorithms.
That we stop delays in getting a person to the right treatment as quickly as possible. It saves their suffering, it can save the health system money, and everyone benefits in the end because there can be life after cancer. Time is of the essence, cancer won't wait, and nor will our need for lunch. So thank you everyone. Ευχαριστώ.
Check this out. It hasn't been such a long time since people first started shopping online, and it was easy to keep up with the clicks. Little by little by little by more, the clicks added up to be more than the stores, and e-tailers worked harder than ever before because they had to keep up with the clicks. The clicks came from laptops, then tablets and phones, Monday through Sunday, office and home, 24 hours in every zone, and still they kept up with the clicks. Now shoppers ask more from the websites they're on, their language, their currency, their way, or they're gone, so you'd better keep up with the clicks. All of a sudden, there are so many must-dos if you want to keep selling, like delivery there, no there, or there.
And make it tomorrow, first thing.
No time for borders. Gotta stay in control, to stay in the flow and continue to grow. But we'll help you. Keep up with the clicks.
Τι είναι η ΕΟΠΕ? Είναι απλά τα αρχικά μιας ακόμα ιατρικής εταιρείας? Είναι τα 36 χρόνια συνεχούς παρουσίας? Τα 380 μέλη? Τα 26 πανελλήνια συνέδρια? Οι 122 υποτροφίες και τα 180 ερευνητικά προγράμματα? Οι 7 εκδόσεις θεραπευτικών πρωτοκόλων? Οι περισσότεροι από 3.600 ασθενείς που έχουν ελεγχθεί για μεταλλάξεις? Είναι μήπως οι ελληνικές και διεθνείς συνεργασίες? Οι πολυάριθμες ημερίδες και οι 480 εκχωρημένες αιγίδες? Η ΕΟΠΕ δεν είναι μόνο αυτά. Είναι πολλά περισσότερα. ΕΟΠΕ είναι το πάθος και η αφοσίωση. Είναι το όραμα και οι στόχοι. Είναι η αστήρευτη ενέργεια και η καινοτομία που μας καθοδηγεί απέναντι σε έναν κοινό εχθρό, τον καρκίνο. ΕΟΠΕ δεν σημαίνει απλά εταιρεία ογκολόγων παθολόγων Ελλάδας. Σημαίνει ελπίδα για καλύτερη ποιότητα ζωής. Σημαίνει πρόληψη και ίση πρόσβαση στη θεραπεία που αποτυπώνονται σε χαμόγελα και αγκαλιές συνανθρώπων μας. Και αυτό σημαίνει τα πάντα για εμάς. ΕΟΠΕ, δίπλα στον συνάνθρωπο, απέναντι στον καρκίνο.
Από κανέναν δεν μπορεί να αφαιρείται το δικαίωμα στην ελπίδα. Γι' αυτό και εμείς στην Ελληνική Ομοσπονδία Καρκίνου συμπορευόμαστε με τους ανθρώπους που νοσούν από καρκίνο, γιατί συναισθανόμαστε τις ανάγκες, συνδημιουργούμε το πλαίσιο και συνεργαζόμαστε με όλους τους φορείς ώστε να έχουν άμεση πρόσβαση σε έγκαιρη διάγνωση, κατάλληλη θεραπεία, ψυχολογική υποστήριξη και ομαλή επανένταξη στην κοινωνία και την εργασία. Ελληνική Ομοσπονδία Καρκίνου. Ο άνθρωπος στο επίκεντρο. Μάθε περισσότερα στο elok.org.
How far must we go to find answers, to discover new medicines and vaccines, and foster a place where science, curiosity, invention, and humanity converge? This is where extraordinary breakthroughs happen. We've been preventing and treating life-threatening diseases for over a century. We've pioneered new antibiotics and led practice-changing research for childhood diseases, cancer, HIV, heart disease, and diabetes. And we're only just getting started. Every day, our scientists from all backgrounds and disciplines work together to use the power of leading-edge science to save and improve lives. Because we believe research is the will to conquer the impossible. And that science will lead the way.
Στη Nova χτίζουμε το μέλλον με αξίες, με κοινωνικές δράσεις που αφήνουν ένα θετικό αποτύπωμα στους ανθρώπους, στην κοινωνία και στο περιβάλλον. Εταιρική υπευθυνότητα και βιώσιμη ανάπτυξη. Μια στρατηγική επιλογή που εδραιώνει την παρουσία μας στην κοινωνία και μας κάνει μια πραγματικά μεγάλη εταιρεία. Συνεχίζουμε δυναμικά.
Check this out. It hasn't been such a long time since people first started shopping online, and it was easy to keep up with the clicks. Little by little by little by more, the clicks added up to be more than the stores, and e-tailers worked harder than ever before because they had to keep up with the clicks. The clicks came from laptops, then tablets and phones, Monday through Sunday, office and home, 24 hours in every zone, and still they kept up with the clicks. Now shoppers ask more from the websites they're on, their language, their currency, their way, or they're gone, so you'd better keep up with the clicks. All of a sudden, there are so many must-dos if you want to keep selling, like delivery there, no there, or there.
And make it tomorrow, first thing.
No time for borders. Gotta stay in control to stay in the flow and continue to grow. But we'll help you. Keep up with the clicks.
Τι είναι η ΕΟΠΕ? Είναι απλά τα αρχικά μιας ακόμα ιατρικής εταιρείας? Είναι τα 36 χρόνια συνεχούς παρουσίας? Τα 380 μέλη? Τα 26 πανελλήνια συνέδρια? Οι 122 υποτροφίες και τα 180 ερευνητικά προγράμματα? Οι 7 εκδόσεις θεραπευτικών πρωτοκόλων? Οι περισσότεροι από 3.600 ασθενείς που έχουν ελεγχθεί για μεταλλάξεις? Είναι μήπως οι ελληνικές και διεθνείς συνεργασίες? Οι πολυάριθμες ημερίδες και οι 480 εκχωρημένες αιγίδες? Η ΕΟΠΕ δεν είναι μόνο αυτά. Είναι πολλά περισσότερα. ΕΟΠΕ είναι το πάθος και η αφοσίωση. Είναι το όραμα και οι στόχοι. Είναι η αστήρευτη ενέργεια και η καινοτομία που μας καθοδηγεί απέναντι σε έναν κοινό εχθρό, τον καρκίνο. ΕΟΠΕ δεν σημαίνει απλά εταιρεία ογκολόγων παθολόγων Ελλάδας. Σημαίνει ελπίδα για καλύτερη ποιότητα ζωής. Σημαίνει πρόληψη και ίση πρόσβαση στη θεραπεία που αποτυπώνονται σε χαμόγελα και αγκαλιές συνανθρώπων μας. Και αυτό σημαίνει τα πάντα για εμάς. ΕΟΠΕ. Δίπλα στον συνάνθρωπο, απέναντι στον καρκίνο.
Από κανέναν δεν μπορεί να αφαιρείται το δικαίωμα στην ελπίδα. Γι' αυτό και εμείς στην Ελληνική Ομοσπονδία Καρκίνου συμπορευόμαστε με τους ανθρώπους που νοσούν από καρκίνο, γιατί συναισθανόμαστε τις ανάγκες, συνδημιουργούμε το πλαίσιο και συνεργαζόμαστε με όλους τους φορείς ώστε να έχουν άμεση πρόσβαση σε έγκαιρη διάγνωση, κατάλληλη θεραπεία, ψυχολογική υποστήριξη και ομαλή επανένταξη στην κοινωνία και την εργασία. Ελληνική Ομοσπονδία Καρκίνου. Ο άνθρωπος στο επίκεντρο. Μάθε περισσότερα στο elok.org.
How far must we go to find answers, to discover new medicines and vaccines, and foster a place where science, curiosity, invention, and humanity converge? This is where extraordinary breakthroughs happen. We've been preventing and treating life-threatening diseases for over a century. We've pioneered new antibiotics and led practice-changing research for childhood diseases, cancer, HIV, heart disease, and diabetes. And we're only just getting started. Every day, our scientists from all backgrounds and disciplines work together to use the power of leading-edge science to save and improve lives. Because we believe research is the will to conquer the impossible. And that science will lead the way.
Στη Νόβα χτίζουμε το μέλλον με αξίες, με κοινωνικές δράσεις που αφήνουν ένα θετικό αποτύπωμα στους ανθρώπους, στην κοινωνία και στο περιβάλλον. Εταιρική υπευθυνότητα και βιώσιμη ανάπτυξη. Μια στρατηγική επιλογή που εδραιώνει την παρουσία μας στην κοινωνία και μας κάνει μια πραγματικά μεγάλη εταιρεία. Συνεχίζουμε δυναμικά.
Check this out. It hasn't been such a long time since people first started shopping online, and it was easy to keep up with the clicks. Little by little by little by more, the clicks added up to be more than the stores, and e-tailers worked harder than ever before because they had to keep up with the clicks. The clicks came from laptops, then tablets and phones, Monday through Sunday, office and home, 24 hours in every zone, and still they kept up with the clicks. Now shoppers ask more from the websites they're on, their language, their currency, their way, or they're gone, so you'd better keep up with the clicks. All of a sudden, there are so many must-dos if you want to keep selling, like delivery there, no there, or there.
And make it tomorrow, first thing.
No time for borders. Gotta stay in control, to stay in the flow and continue to grow. But we'll help you. Keep up with the clicks.
Τι είναι η ΕΟΠΕ? Είναι απλά τα αρχικά μιας ακόμα ιατρικής εταιρείας? Είναι τα 36 χρόνια συνεχούς παρουσίας? Τα 380 μέλη? Τα 26 πανελλήνια συνέδρια? Οι 122 υποτροφίες και τα 180 ερευνητικά προγράμματα? Οι 7 εκδόσεις θεραπευτικών πρωτοκόλων? Οι περισσότεροι από 3.600 ασθενείς που έχουν ελεγχθεί για μεταλλάξεις? Είναι μήπως οι ελληνικές και διεθνείς συνεργασίες? Οι πολυάριθμες ημερίδες και οι 480 εκχωρημένες αιγίδες? Η ΕΟΠΕ δεν είναι μόνο αυτά, είναι πολλά περισσότερα. ΕΟΠΕ είναι το πάθος και η αφοσίωση. Είναι το όραμα και οι στόχοι. Είναι η αστήρευτη ενέργεια και η καινοτομία που μας καθοδηγεί απέναντι σε έναν κοινό εχθρό, τον καρκίνο. ΕΟΠΕ δεν σημαίνει απλά εταιρεία ογκολόγων παθολόγων Ελλάδας. Σημαίνει ελπίδα για καλύτερη ποιότητα ζωής. Σημαίνει πρόληψη και ίση πρόσβαση στη θεραπεία που αποτυπώνονται σε χαμόγελα και αγκαλιές συνανθρώπων μας. Και αυτό σημαίνει τα πάντα για εμάς. ΕΟΠΕ, δίπλα στον συνάνθρωπο, απέναντι στον καρκίνο.
Από κανέναν δεν μπορεί να αφαιρείται το δικαίωμα στην ελπίδα. Γι' αυτό και εμείς στην Ελληνική Ομοσπονδία Καρκίνου συμπορευόμαστε με τους ανθρώπους που νοσούν από καρκίνο, γιατί συναισθανόμαστε τις ανάγκες, συνδημιουργούμε το πλαίσιο και συνεργαζόμαστε με όλους τους φορείς ώστε να έχουν άμεση πρόσβαση σε έγκαιρη διάγνωση, κατάλληλη θεραπεία, ψυχολογική υποστήριξη και ομαλή επανένταξη στην κοινωνία και την εργασία. Ελληνική Ομοσπονδία Καρκίνου. Ο άνθρωπος στο επίκεντρο. Μάθε περισσότερα στο elok.org.
How far must we go to find answers? To discover new medicines and vaccines, and foster a place where science, curiosity, invention, and humanity converge. This is where extraordinary breakthroughs happen. We've been preventing and treating life-threatening diseases for over a century. We've pioneered new antibiotics and led practice-changing research for childhood diseases, cancer, HIV, heart disease, and diabetes. And we're only just getting started. Every day, our scientists from all backgrounds and disciplines work together to use the power of leading-edge science to save and improve lives. Because we believe research is the will to conquer the impossible. And that science will lead the way.
Στη Nova χτίζουμε το μέλλον με αξίες, με κοινωνικές δράσεις που αφήνουν ένα θετικό αποτύπωμα στους ανθρώπους, στην κοινωνία και στο περιβάλλον. Εταιρική υπευθυνότητα και βιώσιμη ανάπτυξη. Μια στρατηγική επιλογή που εδραιώνει την παρουσία μας στην κοινωνία και μας κάνει μια πραγματικά μεγάλη εταιρεία. Συνεχίζουμε δυναμικά.
Check this out. It hasn't been such a long time since people first started shopping online, and it was easy to keep up with the clicks. Little by little by little by more, the clicks added up to be more than the stores, and e-tailers worked harder than ever before because they had to keep up with the clicks. The clicks came from laptops, then tablets and phones, Monday through Sunday, office and home, 24 hours in every zone, and still they kept up with the clicks. Now shoppers ask more from the websites they're on, their language, their currency, their way, or they're gone, so you'd better keep up with the clicks. All of a sudden, there are so many must-dos if you want to keep selling, like delivery there, no there, or there.
And make it tomorrow, first thing.
No time for borders. Gotta stay in control to stay in the flow and continue to grow. But we'll help you. Keep up with the clicks.
Τι είναι η ΕΟΠΕ? Είναι απλά τα αρχικά μιας ακόμα ιατρικής εταιρείας? Είναι τα 36 χρόνια συνεχούς παρουσίας? Τα 380 μέλη? Τα 26 πανελλήνια συνέδρια? Οι 122 υποτροφίες και τα 180 ερευνητικά προγράμματα? Οι 7 εκδόσεις θεραπευτικών πρωτοκόλων? Οι περισσότεροι από 3.600 ασθενείς που έχουν ελεγχθεί για μεταλλάξεις? Είναι μήπως οι ελληνικές και διεθνείς συνεργασίες? Οι πολυάριθμες ημερίδες και οι 480 εκχωρημένες αιγίδες? Η ΕΟΠΕ δεν είναι μόνο αυτά. Είναι πολλά περισσότερα. ΕΟΠΕ είναι το πάθος και η αφοσίωση. Είναι το όραμα και οι στόχοι. Είναι η αστήρευτη ενέργεια και η καινοτομία που μας καθοδηγεί απέναντι σε έναν κοινό εχθρό, τον καρκίνο. ΕΟΠΕ δεν σημαίνει απλά εταιρεία ογκολόγων παθολόγων Ελλάδας. Σημαίνει ελπίδα για καλύτερη ποιότητα ζωής. Σημαίνει πρόληψη και ίση πρόσβαση στη θεραπεία που αποτυπώνονται σε χαμόγελα και αγκαλιές συνανθρώπων μας. Και αυτό σημαίνει τα πάντα για εμάς. ΕΟΠΕ, δίπλα στον συνάνθρωπο, απέναντι στον καρκίνο.
Από κανέναν δεν μπορεί να αφαιρείται το δικαίωμα στην ελπίδα. Γι' αυτό και εμείς στην Ελληνική Ομοσπονδία Καρκίνου συμπορευόμαστε με τους ανθρώπους που νοσούν από καρκίνο, γιατί συναισθανόμαστε τις ανάγκες, συνδημιουργούμε το πλαίσιο και συνεργαζόμαστε με όλους τους φορείς ώστε να έχουν άμεση πρόσβαση σε έγκαιρη διάγνωση, κατάλληλη θεραπεία, ψυχολογική υποστήριξη και ομαλή επανένταξη στην κοινωνία και την εργασία. Ελληνική Ομοσπονδία Καρκίνου. Ο άνθρωπος στο επίκεντρο. Μάθε περισσότερα στο elok.org.
How far must we go to find answers, to discover new medicines and vaccines, and foster a place where science, curiosity, invention, and humanity converge? This is where extraordinary breakthroughs happen. We've been preventing and treating life-threatening diseases for over a century. We've pioneered new antibiotics and led practice-changing research for childhood diseases, cancer, HIV, heart disease, and diabetes. And we're only just getting started. Every day, our scientists from all backgrounds and disciplines work together to use the power of leading-edge science to save and improve lives. Because we believe research is the will to conquer the impossible. And that science will lead the way.
Στη Nova χτίζουμε το μέλλον με αξίες, με κοινωνικές δράσεις που αφήνουν ένα θετικό αποτύπωμα στους ανθρώπους, στην κοινωνία και στο περιβάλλον. Εταιρική υπευθυνότητα και βιώσιμη ανάπτυξη. Μια στρατηγική επιλογή που εδραιώνει την παρουσία μας στην κοινωνία και μας κάνει μια πραγματικά μεγάλη εταιρεία. Συνεχίζουμε δυναμικά.
Check this out. It hasn't been such a long time since people first started shopping online, and it was easy to keep up with the clicks. Little by little by little by more, the clicks added up to be more than the stores, and e-tailers worked harder than ever before because they had to keep up with the clicks. The clicks came from laptops, then tablets and phones, Monday through Sunday, office and home, 24 hours in every zone, and still they kept up with the clicks. Now shoppers ask more from the websites they're on, their language, their currency, their way, or they're gone, so you'd better keep up with the clicks. All of a sudden, there are so many must-dos if you want to keep selling, like delivery there, no there, or there.
And And make it tomorrow, first thing.
No time for borders. Gotta stay in control to stay in the flow and continue to grow. But we'll help you. Keep up with the clicks.
Τι είναι η ΕΟΠΕ? Είναι απλά τα αρχικά μιας ακόμα ιατρικής εταιρείας? Είναι τα 36 χρόνια συνεχούς παρουσίας? Τα 380 μέλη? Τα 26 πανελλήνια συνέδρια? Οι 122 υποτροφίες και τα 180 ερευνητικά προγράμματα? Οι 7 εκδόσεις θεραπευτικών πρωτοκόλων? Οι περισσότεροι από 3.600 ασθενείς που έχουν ελεγχθεί για μεταλλάξεις? Είναι μήπως οι ελληνικές και διεθνείς συνεργασίες? Οι πολυάριθμες ημερίδες και οι 480 εκχωρημένες αιγίδες? Η ΕΟΠΕ δεν είναι μόνο αυτά, είναι πολλά περισσότερα. ΕΟΠΕ είναι το πάθος και η αφοσίωση. Είναι το όραμα και οι στόχοι. Είναι η αστήρευτη ενέργεια και η καινοτομία που μας καθοδηγεί απέναντι σε έναν κοινό εχθρό, τον καρκίνο. ΕΟΠΕ δεν σημαίνει απλά εταιρεία ογκολόγων παθολόγων Ελλάδας. Σημαίνει ελπίδα για καλύτερη ποιότητα ζωής. Σημαίνει πρόληψη και ίση πρόσβαση στη θεραπεία που αποτυπώνονται σε χαμόγελα και αγκαλιές συνανθρώπων μας. Και αυτό σημαίνει τα πάντα για εμάς. ΕΟΠΕ, δίπλα στον συνάνθρωπο, απέναντι στον καρκίνο.
Από κανέναν δεν μπορεί να αφαιρείται το δικαίωμα στην ελπίδα. Γι' αυτό και εμείς στην Ελληνική Ομοσπονδία Καρκίνου συμπορευόμαστε με τους ανθρώπους που νοσούν από καρκίνο, γιατί συναισθανόμαστε τις ανάγκες, συνδημιουργούμε το πλαίσιο και συνεργαζόμαστε με όλους τους φορείς ώστε να έχουν άμεση πρόσβαση σε έγκαιρη διάγνωση, κατάλληλη θεραπεία, ψυχολογική υποστήριξη και ομαλή επανένταξη στην κοινωνία και την εργασία. Ελληνική Ομοσπονδία Καρκίνου. Ο άνθρωπος στο επίκεντρο. Μάθε περισσότερα στο elok.org.
How far must we go to find answers? To discover new medicines and vaccines, and foster a place where science, curiosity, invention, and humanity converge. This is where extraordinary breakthroughs happen. We've been preventing and treating life-threatening diseases for over a century. We've pioneered new antibiotics and led practice-changing research for childhood diseases, cancer, HIV, heart disease, and diabetes. And we're only just getting started. Every day, our scientists from all backgrounds and disciplines work together to use the power of leading-edge science to save and improve lives. Because we believe research is the will to conquer the impossible. And that science will lead the way.
Στη Nova χτίζουμε το μέλλον με αξίες, με κοινωνικές δράσεις που αφήνουν ένα θετικό αποτύπωμα στους ανθρώπους, στην κοινωνία και στο περιβάλλον. Εταιρική υπευθυνότητα και βιώσιμη ανάπτυξη. Μια στρατηγική επιλογή που εδραιώνει την παρουσία μας στην κοινωνία και μας κάνει μια πραγματικά μεγάλη εταιρεία. Συνεχίζουμε δυναμικά.
Check this out. It hasn't been such a long time since people first started shopping online, and it was easy to keep up with the clicks. Little by little by little by more, the clicks added up to be more than the stores, and e-tailers worked harder than ever before because they had to keep up with the clicks. The clicks came from laptops, then tablets and phones, Monday through Sunday, office and home, 24 hours in every zone, and still they kept up with the clicks. Now shoppers ask more from the websites they're on, their language, their currency, their way, or they're gone, so you'd better keep up with the clicks. All of a sudden, there are so many must-dos if you want to keep selling, like delivery there, no there, or there.
And make it tomorrow, first thing.
No time for borders. Gotta stay in control to stay in the flow and continue to grow. But we'll help you. Keep up with the clicks.
Τι είναι η ΕΟΠΕ? Είναι απλά τα αρχικά μιας ακόμα ιατρικής εταιρείας? Είναι τα 36 χρόνια συνεχούς παρουσίας? Τα 380 μέλη? Τα 26 πανελλήνια συνέδρια? Οι 122 υποτροφίες και τα 180 ερευνητικά προγράμματα? Οι 7 εκδόσεις θεραπευτικών πρωτοκόλων? Οι περισσότεροι από 3.600 ασθενείς που έχουν ελεγχθεί για μεταλλάξεις? Είναι μήπως οι ελληνικές και διεθνείς συνεργασίες? Οι πολυάριθμες ημερίδες και οι 480 εκχωρημένες αιγίδες? Η ΕΟΠΕ δεν είναι μόνο αυτά. Είναι πολλά περισσότερα. ΕΟΠΕ είναι το πάθος και η αφοσίωση. Είναι το όραμα και οι στόχοι. Είναι η αστήρευτη ενέργεια και η καινοτομία που μας καθοδηγεί απέναντι σε έναν κοινό εχθρό, τον καρκίνο. ΕΟΠΕ δεν σημαίνει απλά εταιρεία ογκολόγων παθολόγων Ελλάδας. Σημαίνει ελπίδα για καλύτερη ποιότητα ζωής. Σημαίνει πρόληψη και ίση πρόσβαση στη θεραπεία που αποτυπώνονται σε χαμόγελα και αγκαλιές συνανθρώπων μας. Και αυτό σημαίνει τα πάντα για εμάς. ΕΟΠΕ, δίπλα στον συνάνθρωπο, απέναντι στον καρκίνο.
Από κανέναν δεν μπορεί να αφαιρείται το δικαίωμα στην ελπίδα. Γι' αυτό και εμείς στην Ελληνική Ομοσπονδία Καρκίνου συμπορευόμαστε με τους ανθρώπους που νοσούν από καρκίνο, γιατί συναισθανόμαστε τις ανάγκες, συνδημιουργούμε το πλαίσιο και συνεργαζόμαστε με όλους τους φορείς ώστε να έχουν άμεση πρόσβαση σε έγκαιρη διάγνωση, κατάλληλη θεραπεία, ψυχολογική υποστήριξη και ομαλή επανένταξη στην κοινωνία και την εργασία. Ελληνική Ομοσπονδία Καρκίνου. Ο άνθρωπος στο επίκεντρο. Μάθε περισσότερα στο elok.org.
How far must we go to find answers, to discover new medicines and vaccines, and foster a place where science, curiosity, invention, and humanity converge? This is where extraordinary breakthroughs happen. We've been preventing and treating life-threatening diseases for over a century. We've pioneered new antibiotics and led practice-changing research for childhood diseases, cancer, HIV, heart disease, and diabetes. And we're only just getting started. Every day, our scientists from all backgrounds and disciplines work together to use the power of leading-edge science to save and improve lives. Because we believe research is the will to conquer the impossible. And that science will lead the way.
Στη Νόβα χτίζουμε το μέλλον με αξίες, με κοινωνικές δράσεις που αφήνουν ένα θετικό αποτύπωμα στους ανθρώπους, στην κοινωνία και στο περιβάλλον. Εταιρική υπευθυνότητα και βιώσιμη ανάπτυξη. Μια στρατηγική επιλογή που εδραιώνει την παρουσία μας στην κοινωνία και μας κάνει μια πραγματικά μεγάλη εταιρεία. Συνεχίζουμε δυναμικά.
Check this out. It hasn't been such a long time since people first started shopping online, and it was easy to keep up with the clicks. Little by little by little by more, the clicks added up to be more than the stores, and e-tailers worked harder than ever before because they had to keep up with the clicks. The clicks came from laptops, then tablets and phones, Monday through Sunday, office and home, 24 hours in every zone, and still they kept up with the clicks. Now shoppers ask more from the websites they're on, their language, their currency, their way, or they're gone, so you'd better keep up with the clicks. All of a sudden, there are so many must-dos if you want to keep selling, like delivery there, no there, or there.
And make it tomorrow, first thing.
No time for borders. Gotta stay in control to stay in the flow and continue to grow. But we'll help you. Keep up with the clicks.
Τι είναι η ΕΟΠΕ? Είναι απλά τα αρχικά μιας ακόμα ιατρικής εταιρείας? Είναι τα 36 χρόνια συνεχούς παρουσίας? Τα 380 μέλη? Τα 26 πανελλήνια συνέδρια? Οι 122 υποτροφίες και τα 180 ερευνητικά προγράμματα? Οι 7 εκδόσεις θεραπευτικών πρωτοκόλων? Οι περισσότεροι από 3.600 ασθενείς που έχουν ελεγχθεί για μεταλλάξεις? Είναι μήπως οι ελληνικές και διεθνείς συνεργασίες? Οι πολυάριθμες ημερίδες και οι 480 εκχωρημένες αιγίδες? Η ΕΟΠΕ δεν είναι μόνο αυτά, είναι πολλά περισσότερα. ΕΟΠΕ είναι το πάθος και η αφοσίωση. Είναι το όραμα και οι στόχοι. Είναι η αστήρευτη ενέργεια και η καινοτομία που μας καθοδηγεί απέναντι σε έναν κοινό εχθρό, τον καρκίνο. ΕΟΠΕ δεν σημαίνει απλά εταιρεία ογκολόγων παθολόγων Ελλάδας. Σημαίνει ελπίδα για καλύτερη ποιότητα ζωής. Σημαίνει πρόληψη και ίση πρόσβαση στη θεραπεία που αποτυπώνονται σε χαμόγελα και αγκαλιές συνανθρώπων μας. Και αυτό σημαίνει τα πάντα για εμάς. ΕΟΠΕ, δίπλα στον συνάνθρωπο, απέναντι στον καρκίνο.
Από κανέναν δεν μπορεί να αφαιρείται το δικαίωμα στην ελπίδα. Γι' αυτό και εμείς στην Ελληνική Ομοσπονδία Καρκίνου συμπορευόμαστε με τους ανθρώπους που νοσούν από καρκίνο, γιατί συναισθανόμαστε τις ανάγκες, συνδημιουργούμε το πλαίσιο και συνεργαζόμαστε με όλους τους φορείς ώστε να έχουν άμεση πρόσβαση σε έγκαιρη διάγνωση, κατάλληλη θεραπεία, ψυχολογική υποστήριξη και ομαλή επανένταξη στην κοινωνία και την εργασία. Ελληνική Ομοσπονδία Καρκίνου. Ο άνθρωπος στο επίκεντρο. Μάθε περισσότερα στο elok.org.
How far must we go to find answers, to discover new medicines and vaccines, and foster a place where science, curiosity, invention, and humanity converge? This is where extraordinary breakthroughs happen. We've been preventing and treating life-threatening diseases for over a century. We've pioneered new antibiotics and led practice-changing research for childhood diseases, cancer, HIV, heart disease, and diabetes. And we're only just getting started. Every day, our scientists from all backgrounds and disciplines work together to use the power of leading-edge science to save and improve lives. Because we believe research is the will to conquer the impossible. And that science will lead the way.
Στη Nova χτίζουμε το μέλλον με αξίες, με κοινωνικές δράσεις που αφήνουν ένα θετικό αποτύπωμα στους ανθρώπους, στην κοινωνία και στο περιβάλλον. Εταιρική υπευθυνότητα και βιώσιμη ανάπτυξη. Μια στρατηγική επιλογή που εδραιώνει την παρουσία μας στην κοινωνία και μας κάνει μια πραγματικά μεγάλη εταιρεία. Συνεχίζουμε δυναμικά.
Check this out. It hasn't been such a long time since people first started shopping online, and it was easy to keep up with the clicks. Little by little by little by more, the clicks added up to be more than the stores, and e-tailers worked harder than ever before because they had to keep up with the clicks. The clicks came from laptops, then tablets and phones, Monday through Sunday, office and home, 24 hours in every zone, and still they kept up with the clicks. Now shoppers ask more from the websites they're on, their language, their currency, their way, or they're gone, so you'd better keep up with the clicks. All of a sudden, there are so many must-dos if you want to keep selling, like delivery there, no there, or there.
And make it tomorrow, first thing.
No time for borders. Gotta stay in control, to stay in the flow and continue to grow. But we'll help you. Keep up with the clicks.
Τι είναι η ΕΟΠΕ? Είναι απλά τα αρχικά μιας ακόμα ιατρικής εταιρείας? Είναι τα 36 χρόνια συνεχούς παρουσίας? Τα 380 μέλη? Τα 26 πανελλήνια συνέδρια? Οι 122 υποτροφίες και τα 180 ερευνητικά προγράμματα? Οι 7 εκδόσεις θεραπευτικών πρωτοκόλων? Οι περισσότεροι από 3.600 ασθενείς που έχουν ελεγχθεί για μεταλλάξεις? Είναι μήπως οι ελληνικές και διεθνείς συνεργασίες? Οι πολυάριθμες ημερίδες και οι 480 εκχωρημένες αιγίδες? Η ΕΟΠΕ δεν είναι μόνο αυτά. Είναι πολλά περισσότερα. ΕΟΠΕ είναι το πάθος και η αφοσίωση. Είναι το όραμα και οι στόχοι. Είναι η αστήρευτη ενέργεια και η καινοτομία που μας καθοδηγεί απέναντι σε έναν κοινό εχθρό, τον καρκίνο. ΕΟΠΕ δεν σημαίνει απλά εταιρεία ογκολόγων παθολόγων Ελλάδας. Σημαίνει ελπίδα για καλύτερη ποιότητα ζωής. Σημαίνει πρόληψη και ίση πρόσβαση στη θεραπεία που αποτυπώνονται σε χαμόγελα και αγκαλιές συνανθρώπων μας. Και αυτό σημαίνει τα πάντα για εμάς. ΕΟΠΕ, δίπλα στον συνάνθρωπο, απέναντι στον καρκίνο.
Από κανέναν δεν μπορεί να αφαιρείται το δικαίωμα στην ελπίδα. Γι' αυτό και εμείς στην Ελληνική Ομοσπονδία Καρκίνου συμπορευόμαστε με τους ανθρώπους που νοσούν από καρκίνο, γιατί συναισθανόμαστε τις ανάγκες, συνδημιουργούμε το πλαίσιο και συνεργαζόμαστε με όλους τους φορείς ώστε να έχουν άμεση πρόσβαση σε έγκαιρη διάγνωση, κατάλληλη θεραπεία, ψυχολογική υποστήριξη και ομαλή επανένταξη στην κοινωνία και την εργασία. Ελληνική Ομοσπονδία Καρκίνου. Ο άνθρωπος στο επίκεντρο. Μάθε περισσότερα στο elok.org.
How far must we go to find answers, to discover new medicines and vaccines, and foster a place where science, curiosity, invention, and humanity converge? This is where extraordinary breakthroughs happen. We've been preventing and treating life-threatening diseases for over a century. We've pioneered new antibiotics and led practice-changing research for childhood diseases, cancer, HIV, heart disease, and diabetes. And we're only just getting started. Every day, our scientists from all backgrounds and disciplines work together to use the power of leading-edge science to save and improve lives. Because we believe research is the will to conquer the impossible. And that science will lead the way.
Στη Νόβα χτίζουμε το μέλλον με αξίες, με κοινωνικές δράσεις που αφήνουν ένα θετικό αποτύπωμα στους ανθρώπους, στην κοινωνία και στο περιβάλλον. Εταιρική υπευθυνότητα και βιώσιμη ανάπτυξη. Μια στρατηγική επιλογή που εδραιώνει την παρουσία μας στην κοινωνία και μας κάνει μια πραγματικά μεγάλη εταιρεία. Συνεχίζουμε δυναμικά.
Check this out. It hasn't been such a long time since people first started shopping online, and it was easy to keep up with the clicks. Little by little by little by more, the clicks added up to be more than the stores, and e-tailers worked harder than ever before because they had to keep up with the clicks. The clicks came from laptops, then tablets and phones, Monday through Sunday, office and home, 24 hours in every zone, and still they kept up with the clicks. Now shoppers ask more from the websites they're on, their language, their currency, their way, or they're gone, so you'd better keep up with the clicks. All of a sudden, there are so many must-dos if you want to keep selling, like delivery there, no there, or there.
And make it tomorrow, first thing.
No time for borders. Gotta stay in control, to stay in the flow and continue to grow. But we'll help you. Keep up with the clicks.
Τι είναι η ΕΟΠΕ? Είναι απλά τα αρχικά μιας ακόμα ιατρικής εταιρείας? Είναι τα 36 χρόνια συνεχούς παρουσίας? Τα 380 μέλη? Τα 26 πανελλήνια συνέδρια? Οι 122 υποτροφίες και τα 180 ερευνητικά προγράμματα? Οι 7 εκδόσεις θεραπευτικών πρωτοκόλων? Οι περισσότεροι από 3.600 ασθενείς που έχουν ελεγχθεί για μεταλλάξεις? Είναι μήπως οι ελληνικές και διεθνείς συνεργασίες? Οι πολυάριθμες ημερίδες και οι 480 εκχωρημένες αιγίδες? Η ΕΟΠΕ δεν είναι μόνο αυτά. Είναι πολλά περισσότερα. ΕΟΠΕ είναι το πάθος και η αφοσίωση. Είναι το όραμα και οι στόχοι. Είναι η αστήρευτη ενέργεια και η καινοτομία που μας καθοδηγεί απέναντι σε έναν κοινό εχθρό, τον καρκίνο. ΕΟΠΕ δεν σημαίνει απλά εταιρεία ογκολόγων παθολόγων Ελλάδας. Σημαίνει ελπίδα για καλύτερη ποιότητα ζωής. Σημαίνει πρόληψη και ίση πρόσβαση στη θεραπεία που αποτυπώνονται σε χαμόγελα και αγκαλιές συνανθρώπων μας. Και αυτό σημαίνει τα πάντα για εμάς. ΕΟΠΕ, δίπλα στον συνάνθρωπο, απέναντι στον καρκίνο.
Από κανέναν δεν μπορεί να αφαιρείται το δικαίωμα στην ελπίδα. Γι' αυτό και εμείς στην Ελληνική Ομοσπονδία Καρκίνου συμπορευόμαστε με τους ανθρώπους που νοσούν από καρκίνο, γιατί συναισθανόμαστε τις ανάγκες, συνδημιουργούμε το πλαίσιο και συνεργαζόμαστε με όλους τους φορείς ώστε να έχουν άμεση πρόσβαση σε έγκαιρη διάγνωση, κατάλληλη θεραπεία, ψυχολογική υποστήριξη και ομαλή επανένταξη στην κοινωνία και την εργασία. Ελληνική Ομοσπονδία Καρκίνου. Ο άνθρωπος στο επίκεντρο. Μάθε περισσότερα στο elok.org.
How far must we go to find answers, to discover new medicines and vaccines, and foster a place where science, curiosity, invention, and humanity converge? This is where extraordinary breakthroughs happen. We've been preventing and treating life-threatening diseases for over a century. We've pioneered new antibiotics and led practice-changing research for childhood diseases, cancer, HIV, heart disease, and diabetes. And we're only just getting started. Every day, our scientists from all backgrounds and disciplines work together to use the power of leading-edge science to save and improve lives.
Welcome back, ladies and gentlemen. I hope some of you at least were more successful than I was in resisting the desserts.
How far must we go to find answers?
I did manage to stop at 2, but it was a struggle.
And foster a place where science,
okay, we're going to move on with our first session at lunch, and it is a good one, an important one. The title of our session now is The Paradigm Shift in the Cancer Care Delivery Model. We've already heard quite a lot about this so far in the day, but we have a very busy panel ahead of us. So without any delay, I'm going to invite them to join me here on the stage. First up is Marios Themistokouleos. Hope I got that fairly close. Deputy Minister of Health for Greece, who's joining us remotely. Vasiliki Gioka, who is the Quality Manager at General Anti-Cancer Oncology Hospital of Athens. Please come and join us. Athena Christopoulou, who is the Medical Oncologist, Head at Department of Internal Medicine, Division of Clinical Oncology at St Andrew's General Hospital of Patra. Dimitrios Papageorgiou, who is the Assistant Professor, University of Peloponnese, President of the Hellenic Oncology Nursing Society. Paraskevi Michalopoulou, who is the President of the Hellenic Association of Women with Breast Cancer, Alma Zois, Vice President, Hellenic Cancer Federation, and Thanasis Lopatatsidis. God, I'm struggling with these names. It's too much dessert. Welcome up, Commercial Executive Director at Affidea Group. And we have two commentators to help us make sense of everything we hear, and they are Eleni Galani, who is the Director of the Second Oncology Clinic at the Metropolitan Hospital, and Vasilis Balanis, who is the Chief Executive Officer at the National Agency for Quality Assurance in Health to keep us all at a very high quality that we've been used to through the day. Thank you. Please join us. Okay, well, let's jump straight in with you, Deputy Minister. Would you like to, do you want to speak from here? Or do you want to take... Forgive me, you were sitting so close. Deputy Minister, you please. Go ahead.
Good afternoon. Shall I speak in Greek, in English? As you wish. Okay. I'll have a rather general introduction and I'll leave the floor to other participants. Apologies, first of all, that I can't be with you because I'm in Thessaloniki. Together with Mr. Georgiadis, we'll be shortly visiting Papageorgiou Hospital and Achepa Hospital, where we'll be having the first hospitals delivering afternoon surgeries. So this is the first step of an enormous reform in the healthcare system, which was debated for many years. So hopefully with this new system we'll be increasing the hospital's services quality, reducing the waiting list and connecting the doctors' payment with performance and productivity in a way that somehow the remuneration of doctors be increased. We'll attempt to have a robust healthcare system in the way it used to be, as we are having the best brains in our system. And we've managed to deal with all challenges. However, this is high time we moved into the next stage, becoming more practical, resolving issues and challenges that have been standing for years. Now, getting back to the onco patient management, which is a priority for my administration, and we do have an action plan in place, already discussed earlier together with the minister's intervention and Mrs. Rapidakis. However, starting from the diagnosis stage throughout treatment, well, this process is a very critical stage where we need to have more changes in place. So first of all, we need to guide the patient. Currently, all citizens following diagnosis, most of them do have problems, namely, let us assume that a patient is operated in a hospital and he doesn't know how he'll move forward to the next step, chemotherapy and so on and so forth. So we need to have in place a mechanism to guide our patients through, facilitating the entire procedure by focusing on the medical services by ensuring high quality of services. So they'll be guided in how they book and arrange an appointment for chemotherapy and so on and so forth. And a second point that I assume it shall be discussed later on in this panel is relevant to the holistic approach of onco patients. Diagnosis, treatment, but Globally, there's an issue with those with survivors. We need to help them as well, inside and outside hospitals, to deal with their daily activities during their treatment or onwards into their lives. First steps are already in place. We do have a program for children survivors. We have a dedicated onco department, and we'll be shortly having more centers for adults. All the above shall be supported by renovated infrastructure and the digital upgrading of servicing. The large project which is already in place in hospitals and will be shortly having, together with the hospital staff, will be having the digital tools ready to provide quality services to all patients. And I'll conclude so that we move forward with the debate. This is an excellent panel, fully knowledgeable of this topic, so I'll conclude with the following. Let us take small steps, building thus a robust path ahead, having well-organized hospitals in a way to provide services to the highest possible number of onco patients. Thank you very much for allowing me this first initial introduction and presentation. Thank you.
Mr. Minister, very much appreciated. Let's move straight along then. Vasiliki Gioka.
Ναι, Βασιλική Γκιόκα είναι λίγο.
Gioka. I'll get there in the end. From the General Anti-Cancer Oncology Hospital.
St. Savas, yes.
Yeah.
Στα ελληνικά θα είναι η παρουσίασή μου.
I will speak in Greek, if you don't mind. So, we have many speakers, so let me be quick. Firstly, I'd like to say that the Oncological Hospital Agios Savas is the first hospital which gets funded by the Ministry of Health in order to be upgraded into a comprehensive cancer center, making sure that our patients are in safe hands. This project is entitled in developing, she has to speak not that fast, she's just reading, she has to take it down a bit. Yeah. Yes, I'm in a hurry, she says, but you understand that it won't be able to interpret. Thank you very much, Mr. Ross. So the budget of this project is 1.2 million euros, and the aim is to cover the needs to install standardized procedures that will make sure that quality services are provided to the oncological patients. The project has a 30-month duration and is split in two sub-projects. Thanks to this project, the hospital will be able to have a human-centric approach to oncological patients, emphasizing not only on the therapeutic protocols and the follow-up, but also on personalized care for physical, mental, psychological requirements of the patient. Thanks to this comprehensive approach, our hospital will be able to get the excellent certification by OECI, and our hospital is a founding member since 1922. The ambitious target of OECI is to accredit all European cancer centers, developing a common methodology for cancer treatment, securing high levels of treatment, upgrading research, and ensuring good quality clinical trials in the context of cross-country collaboration. The need to have this kind of comprehensive cancer infrastructure in Europe was the outcome of the fact that treatment and methodologies between member states may vary because of the funds available, the specific infrastructure, the relationships between research and clinical practice, and the screening processes. For instance, survival rates in the post-treatment breast cancer survival rates differ amongst the EU member states, and in the case of colorectal cancer, we are from 46 to 69%. This cross-country collaboration of cancer centers will improve therapeutic pathways, which are the integral part for designing and coordinating healthcare services, the provision of healthcare services, and of course the monitoring of all the processes involved. So, in order to decrease this diversity in the methodologies, the European Commission and the 7th multi-annual framework plan funded this Euroscan platform project. So in the context of OECI, we have 345 standards applied, and following this project, we're going to have we had 9 oncological hospitals accredited by that tool. We have a self-assessment qualitative questionnaire and a quantitative questionnaire linked to this project. Our hospital has already fulfilled the quantitative questionnaire. The criteria characterizing an organization as a comprehensive cancer center are both quantitative and qualitative. The very important criterion has to do with the scientific knowledge produced. For instance, a quantitative criterion has to do with the number of clinical trials active every year. There have to be more than 75. Our hospital in 2022 has had 54 clinical trials launched. Also, we have to have invasive treatments that go well beyond 10% of the patients. We have had 4,826 patients, and we included 242 patients in the clinical trials, which is less than 10%. The standard was we had to have 10% of our hospitalized patients in clinical trials. That's why we took specific measures, like the Clinical Trial Management Unit and the Biobank. Both structures are quite complicated, multidimensional. They help produce innovation and knowledge, and they are necessary if we are to be able to interpret this research towards oncology, precision oncology, and targeted and personalized medicine, driven by our true desire to improve the healthcare of our fellow citizens. The management unit has specific core standards we have to apply by. We have to have an annual action plan. The management unit has to have policies of promoting clinical trials, including data exchange, data with respect to availability of clinical trials underway. Also, we have to have a clinical trials registry and an annual report that has to be published in the official website of our hospital. So, Savas, the hospital, pursuant to Law 4051, it was the management of our hospital that decided to establish this management unit, this clinical trial management unit. This unit reports to the quality department in order to have the necessary SOPs developed. What are the benefits? The benefits are that now we have a fertile research environment for better research, for improving the healthcare offered to our patients. That's why in the new regulations drafted, we will reinvent the Georgios Papanikolaou Research Center. This is a center of oncological research aiming at having an upgraded cross-disciplinary research platform on drugs, healthcare, biotechnology, and this center will become a pole of attraction of innovation and clinical trials. I don't want to tire you more with the Biobank. The underlying objective is to discover prognostic and diagnosis biomarkers that will be the basis for improving therapeutic protocols in the context of precision oncology based on personalized treatments. So the organization of the hospital's biobank is something that has been published in September 2023 in the magazine Onco. Currently, we have cancer patients in delay for diagnosis, and they have limited access to health experts and treatments. So, given that our hospital is part of the OECI, this means that we have a very fruitful collaboration with other centers with the final stage of being accredited. And of course, this means better infrastructure, better healthcare services to the patients, operational retrofitting of our hospital, and better use of our hospital staff so that all the patients can get the best results they can get. Thank you very much. I hope I wasn't too tiring, she said. She was, if I may say.
Well, in the process to replace our scheduled speaker, we really appreciate that. Let's move straight along to Athina Christopoulou. Your words, please.
Thank you very much. Thank you very much for this really honoring invitation to take part in this conference and find myself amongst these esteemed guests in this annual meeting, which means that we are all here to exchange, to discuss openly in order to discuss about how this innovation should be introduced and how this innovation will reach our patients, the recipients. My topic will be the holistic approach, holistic healthcare. Let's remind ourselves of the definition of health according to WHO. Health is not the absence of any disease or condition, but full physical, mental, and social wellness. So, currently, we find ourselves in a crossroads, health or disease. Let's remind ourselves what Aristotle used to say. The total is more than the addition of its components. So this holistic approach approaches individuals are single units, comprehensive ones that cannot be split in various components. So holistic healthcare takes care of all aspects: social, physical, mental, pathological, and spiritual aspects in the life of an individual in a single context. We, the health professionals, should not approach conditions and diseases as individual disorders of a person's organs. We have to treat them through a different prism, if you like. I was trying to find the best possible definition of holistic healthcare, and this is what I came up with. Nothing can be done fully, nothing can be made fully understood unless we perceive the entire system, and of course the total of these the total is more than the addition of its parts. So we need harmony, we need balance with respect to the body, the soul, and the spirit. So this B-pole, health or disease, are interconnected. It's like a highway of two directions. We have biological parameters, counter-healthy or unhealthy practices, environmental parameters, psychological parameters, etc. The aim of a holistic approach is to optimize the results and improve the quality of the healthcare provided by means of combination, coordination, and use of various skills. In order to find synonyms of holistic approach, one could say we have the whole person care concept or integrative care. So we're talking about a multidimensional approach, including other concepts, and this holistic care allows us to deep dive in the needs of the patients, and this is something that affects greatly the healthcare systems. So holistic care is the total or full care provided to a patient, taking into account his or her physical, emotional, social, financial, and spiritual requirements, his or her response to the condition, and the impact of this disease to the person's capability to sustain themselves. It is well found that cancer patients have a set of mental, physical, financial, and social issues to deal with. Cancer treatment, cancer care actually, has to be seen not on the basis of treatment, but from a holistic viewpoint, aiming also at psychosocial aspects, quality of life, patient rights, empowerment, and survival. So, having a holistic approach when it comes to cancer care will lead to better results for their health and wellness and prosperity. Apologies. So we're talking about an emerging healthcare approach, shifting the focus from cure to health. Of course, conventional oncological services are provided together with raising awareness and training programs. And this covers also the social, mental or spiritual requirements of or existential requirements of the person. So if we are to identify what holistic approach is about, this has to include prevention, driven by the promotion of healthy daily habits. It also includes personalized treatment, but of course this is not enough, because today we do not cure cancer, we cure the gene that leads to cancer. It has also to emphasize on treating the symptoms and also treating the side effects that are sometimes linked to conventional treatments, and this will surely help improve the total life quality of a patient. It also relates to the total evaluation or assessment of the physical and spiritual and mental symptoms of an individual, which will allow healthcare professionals and providers to understand what are the underlying factors affecting or impacting a person's wellness and prosperity. And last but not least, we need this cross-disciplinary collaboration, what we're actually doing right now, because this cross-disciplinary approach will allow a holistic understanding of a patient's health status and the implementation of holistic treatment regimes. Of course, we have also to include some ancillary treatments such as music, meditation, enhancement of a person's physical balance, etc. It also has to include trainings on self-awareness. We have to encourage our patients to be actively involved with the therapeutic process. It also includes improvement of their mental wellness and, of course, a support to their level of satisfaction. So having such a patient-centric approach and taking into account their requirements and desires, we will be able to talk about the so-called holistic care. 10 years ago, the NHS of England, together with other national stakeholders, signed a set of commitments for the support of the holistic care concept. The scope included improving results in the health care of the population, dealing with inequalities in the results obtained and the service offered, and of course empowerment or the increase of the productivity and the value, the cost-value relation. Also, interventions that have to do with the conscience of the patients and the interpersonal relationships will improve their understanding of pain, their resilience to pain, etc., etc. There are other research, surveys and research papers showing that this kind of holistic approach lead to better wellness, to better prosperity and increased life expectancy. However, we health professionals should not treat our patients as if they are biological machines. And this is very, very important. We have to stress that hospital training or in-hospital training and building relationships of trust are of major importance. So prevention, rehabilitation, rehabilitation, they are very, very important, because a cancer patient from day one of its diagnosis has to be treated as a survivor. That's another survey supporting the holistic care concept, and we can find many other surveys online. We're talking about a huge number of patients considered, and apart from personalized medicine, we have to link that with personalized care, and that's really important to say. That it's really important to say that we have PROS. These are the outcomes reported by the patients, and this is a very, very important dimension, an innovation that is enabled through new technology. Last but not least, the conclusion is the following. Total holistic care allows us to have better quality of life, better response to treatment, and of course increase of life expectancy. So solutions may come up just by turning our eyes from the cure only to the real needs of a patient, which means treatment. Thank you.
Life goes on, and so must we. On to Dimitrios. Your introductory words, please.
Thank you very much, Economist, for the invitation. I'm a bit moved because my postgraduate thesis was on care, and which, well, brings me memories, different memories. And of course, I do understand now this interdisciplinary dimension. The previous speaker referred to the Onco Committee, so I'll discuss precisely the way that we can all together serve this purpose, discussing all together around the table. In 5 minutes, I'll try to elaborate this interdisciplinary function of a system which operates differently. A number of people, as the way we are today, in a team spirit, trying to put forward something different. A team has a common goal, and I assume that if an onco had a head of an onco department, that would be the way he would introduce newcomers in a department. Well, you are welcome to join the team. And this is how best quality, best services are produced and best outcomes. So let us assume that we are in the area of Peloponnese, in the city of Tripolis, and we are having common values, a very well organized team, well allocated and distributed responsibilities. If I miss something, well, somebody else can replace or supplement my work. In a spirit of supplementarity, complementarity. Why I say so? We need to differentiate interdisciplinary versus multidisciplinary levels. We need to work all together in an interdisciplinary spirit. However, in a multidisciplinary, each one maintains her own attitude. Thus, patients get confused. One thing proposed by a dermatologist speaking about melanoma and something different from the onco doctor, because each one has a different approach, and the patient is in the middle and doesn't know whom to obey. And this is what we come across on a daily basis while practicing our job. But of course, everything needs to be measured. Even though we do know that the correct approach involves 3 benefits. In a way, to deliver holistic service with reduced side effects, better and lower hospitalization levels, reduced infections, reduced mortality and comorbidities. And it is good for us as well to be working as a team, not as an isolated individuals. When we work all together, well, it is always better than working alone. We feel less tired because the load of work is well distributed. The skills of each one of the team are better allocated and utilized. Take the example of students. If you ask them to fill in a questionnaire. It's better to have several students working with the patients instead of having one visiting all patients. And again, the better conflict management, as there are less when people work in teams. Productivity is increased, everything is better synchronized and organized, inequalities are reduced, and the entire man force and workforce is better enhanced and utilized. So this is how we've been working, and this is how we came up with better results by using all and different treatment methods, observing the protocols, the interdisciplinary protocols, and improving their lives. If I could highlight some points, I would say that in ONCO, this spirit involves specific steps. First of all, assess the patient, assess and record the challenges, and of course we need to deliver what we are promised, and last but not least, the final assessment, because the plan must be assessed together with the way it was delivered, thanks to the people around the patient. Thank you very much.
Indeed. Let's move on to...
Thank you for the invitation. I'll start from the moment a patient is diagnosed, which is a shock. And this is how a journey begins that I would describe it as something like Ulysses' travel, a journey under the menace of a life-threatening condition. So, full of anxiety, uncertainty, nobody knows what is there to be expected, and of course the fear of death. This system is chaotic. If nobody knows how to move through this system and she's not guided, so this is an enormous additional challenge. Lots of time is lost. People are waiting hours for an appointment, results of a test. Resources are wasted in a time period which for cancer patients every day is valuable, because they become more vulnerable and they lose their emotional resilience. So the holistic center, a breast holistic center, try precisely to make this journey less complicated. The complexity of diagnosis, treatment, and monitoring requires care delivered by multiple disciplines: precise diagnosis, correct treatment, proper monitoring and management of side effects. All those involve serious challenges that only a holistic cancer center may resolve, facilitating thus this journey ahead. With a suitable organization, those centers may provide a safe environment to all patients under very uncertain conditions. through the interdisciplinaries. In those interdisciplinary departments, a center may provide the best possible services, and the interconnected departments provide, of course, better scientific services, while saving valuable time. This journey becomes easier both for patients, their families, and the staff itself. And we should not forget that personalized treatments are provided, personalized care in the harder journey of patients suffering from metastatic tumors. The integrated centers provide, of course, better services, as I mentioned earlier, for their entire staff, because the framework, the setting is far safer. The procedures are very well standardized. Protocols and guidelines are there to be applied. And the committees, the onco-committees, assist their work. They are given incentives, whereas they are not burned out with whatever this might involve. There are assessment procedures in place, and in this way, both patients can get actively involved in the assessment by describing their experience. Meanwhile, they can cover the gap existing in the socio-emotional condition of families, which is significantly important for the reintegration of patients themselves. To wrap up, to summarize, the integrated cancer centers may be centers that can reduce the rate of incidence, increasing life expectancy by providing quality services. And let me stress again the following. Those centers do have a social role to play, either directly or indirectly, because by improving the quality of life of patients, they bring them back to normality with the less possible challenges through the journey. And by alleviating inequalities, well, this precisely may have a great positive impact on our social life.
Yep.
Thanasi.
Firstly, I would like to thank the organizers for this beautiful event, which allows us both to receive important information and to exchange viewpoints. And of course, it enables us to also present our own viewpoint on this specific issue. Let me start with something that might be already known to you, that cancer cases have multiplied. The incidence and the prevalence of cancer is increasing in modern societies, mainly in North America and in Europe. We see that the growth rate the incidence rate is quite high. So in this sense, the health span is twice as large for healthy individuals. And this means a lot for the healthcare systems. So we heard a lot about prevention, but I would like to stick to this slide. The importance of quantifying the results, both with respect to individuals and their communities, and with respect to the healthcare system's performance. These data do not come from Greece. These data have been extracted by the insurance market statistics, so there might be bias to some extent because these data relate to populations that are better off, to put it like that, but they illustrate the following. A well-organized prevention system, I'm talking about primary and secondary prevention systems, may improve the life expectancy to a great extent, but it can also protect the healthcare system's finances so that the system itself can better allocate resources. We know very well that the most costing parts of the cancer pathway have to do with radiotherapy and PET-CT of prostate and breast cancers. I think we should emphasize on coming up with comprehensive care solutions and treatment solutions, knowing that this is the most costing part. As I said before, the radiotherapy, the speaker said just therapy, the slide says radiotherapy, and given that some organizations aim at becoming profitable, they invest more in the parts where most money can come from. That's why in many European countries, as it seems, the development of these cancer centers turns out to be quite a lucrative activity. In Greece, over the past years, important steps have been taken to this direction, and I want to isolate, let's say, this important initiative by the ministry and the Agios Savas Hospital for promoting the in-house treatment. It's a very well organized initiative, and all of us, private and public sector organizations, have to support this idea and help its performance, let's say. However, there are opportunities that arise, and we can use the best practices from abroad. And I'm going to talk to you about the good examples my company is involved in. Cases in which PPCs might lead to building comprehensive cancer centers that can let's say, attract the interest of the public. And of course, these centers may provide important health-related and social benefits. This is an example. It's the Aphidia Center of Excellence in Zurich. We have one of the same in Milan. In this center, we have a holistic approach to breast cancer. We start from the so-called wellness aspect. Prevention, wellness, good diagnosis, and then we go to treatment, rehabilitation, and psychological support of the patients. One might say that, yes, this is a center financed by private organizations. Yes, but the Swiss system is what allowed for the environment to be, let's say, created for this initiative to flourish. Part of these costs are covered by the Swiss NHS. We have such a center for prostate cancer in Hungary. In an equally holistic approach, we deal with prognosis, diagnosis, and treatment of cancer. I would like to emphasize on the following. Both this center and the previous one, actually, we have many healthcare systems, especially the Anglo-Saxon ones, that have created policies in the context of which treatment, actually diagnosis, is very quick, as early as the first symptoms appear. In the UK, we have diagnosis coming up in 15 days, within 15 days. And from the moment the diagnosis is established, within 15 days more, the treatment has to be launched. So it is very important to have organized infrastructure so that this kind of policies may be in place. Data play a very important role in that. But I believe that what the Anglo-Saxons have achieved, and that's something that the Germans and the French are doing to some extent, is they link this result, the social impact, the thing I told you before, 15 days for diagnosis and 30 days for the onset of the treatment. They link that with the financial savings for the national hospital or the private hospital, private clinic. Let me close with the following. The global trend right now is to bring patients out of the hospital, to take them out of the hospital so we can be more performing. In this context, I think that Greece has to create these cancer treatment care centers. We only have one, Iatropolis, I think, right? But I think that our system need more. We need more than 10 centers of this type. Private or public, doesn't matter. But they will play a very important role in promoting this, in fulfilling this objective. There will be something like satellites of big hospitals that will allow us to improve the healthcare status of our population. Let me close by saying that AI, which is gradually being introduced in Greece, can help largely to this extent. I know very well that part of the cervical cancer diagnosis uses treatments such as the uses various tools in order to help the diagnosis. So under specific circumstances, if we use AI, even in that, we can reduce the cases of cervical cancer. Thank you very much.
Thank you very much. We're really short on time. In fact, we're over time, but we're making time because we want to hear the comments from Eleni and Vasilis. Can I ask you to be to the point, fairly brief if you can, please? So first, Eleni, your thoughts.
Καλησπέρα και από μένα. Ευχαριστώ πολύ για την...
Thank you for the invitation. I'll try to be brief and consistent. What differentiates humans from all other animals is that we pass from life to having a quality way of living. The first who put forward this meaning was Aristotle, speaking about well-being, that is a balance between spirit and body. Cancer, however, impacts the quality of patient lives. Now, how, as an oncodoctor, I am very satisfied because our patients have access to all clinical trials and protocols and treatments. However, they can't be holistically supported. So I believe that in our country it's high time we pass to another model, the integrated medicine, where standard approaches shall be accompanied by supplementary treatments such as indicatively acupuncture, yoga, exercise, praying, meditation, other forms of arts. You know that in some countries visits to museums can be prescribed. Many patients claim that they do not wish to live longer, but they want to live better. So we need to serve the desires of our patients in any possible way. And this is a very delicate point, together with the structures that they would support patients at a terminal stage. So let us hope that we'll manage to develop palliative care in our country, meaning the way you deal with the patients at the last stage of cancer. This is the only way to demonstrate that we do understand the needs of vulnerable people. Thank you, Eleni.
to forget that actually there are people at the other end of this process. So thank you for raising that. Vasilis, you can finish us off, please, with your comments.
Ευχαριστώ πολύ και από την πλευρά μου για την πρόσκληση.
Thank you for the invitation. We've followed a very significant and interesting presentation by the previous speaker, but let me set the framework, starting from the minister's presentation, who proposed this new system for cancer. And it is very interesting that there's a totally different approach for the management of cancer, focusing most on improving the life of patients by providing safest and more efficient services. Thus, in other words, services need to be standardized. We need to have treatment paths on the forefront and create a model similar to the Nordic example. First, effort to maximize and optimize the services in our country. For the first time, patients shall be given care, home care, in a safe way. Standardization may produce more benefits, but let me refer just to several points that illustrate the benefits of the standardization and optimization of care. Let us take the example of an interdisciplinary committee. This may reduce the time from diagnosis until treatment and improve the overall journey for a patient. It is very important that we have it when managing patients in our country. The onco committees are managing patients in-house, inside hospitals, so hospitals need to change their internal procedures to produce all those multiple benefits, standardization of procedures, better, safest procedures, better and measurable experience on the part of patients, measurement of prems and proms, that is of the patient experience, their satisfaction from the services they were given. Mr. Nicolaou, having the experience of NOSPI, supports indeed that it is very useful for both sides to understand how positive this experience might prove, having patients back home being given their services, and again this is a win-win situation for both professional and patients. When we streamline the patient management procedures, we'll witness that long hours were wasted in other different duties, missing the core value of healthcare services. This time must be utilized in the best possible way, and being in an era after a severe health crisis, we need to take all the above into account whenever designing similar paths in the future. And again, there have been other initiatives. I'm happy that we have with us the Secretary General, because we've been recently discussing other initiatives for onco patients, different paths that need to be built. And I'm deeply satisfied witnessing that there are so many different in place beyond the National Cancer Plan. It is very important that we have a framework to best manage all those parameters, and this shall be the best benefit for the design and the reform of the new national healthcare system. Thank you.
From an extremely enthusiastic delegate, please. Keep the question very brief, please.
Extremely so. You would allow me to speak in Greek then, okay?
Of course.
Of course.
Okay. I congratulate the panel, all panels, most of them refer to the quality of life. Do we have actual real data demonstrating the quality of life? There has been a lot in a university study to measure the quality of life of cancer patients by utilizing specific questionnaires connecting with Eurocode and RTC, specialized databases, specialized tools. So what did we measure? We measured the way a patient is integrated back to the society as a productive entity. I remind you that she loses time, so we need to understand how well it can be reintegrated in a professional environment, the family environment. We wanted to measure
measuring quality of life, and do we have any data? Who wants to answer that?
He answered also. He also answered.
Yeah. Does anybody want to add anything?
They have done it.
Have we had as full a declamation as we needed? Okay. I think you've asked and answered the question, which is extraordinarily efficient. Thank you very much for that. Please join me in thanking our panel and the Deputy Minister, who I would love to have come back to, but I'm afraid we don't have time for that. Thank you, ladies and gentlemen. Thanks. Along because we have another very busy panel, and I want to give everybody a fair chance to present their case. This is a really interesting topic. I'm looking forward to hearing what our panelists have to say about it. That is the future of innovation in cancer. We started out today in a fairly hopeful vein, talking about how things have changed, how many tools for diagnosis and treatment there are on the horizon. So we're going to hear more about that now. So I'm delighted to invite up to talk about this theme Lilian Venetia Vilderidi, who is the Secretary General for Health Services at the Ministry of Health in Greece. Please come up and join me on the stage, Lilian. Anastasia Kritara, who is the Associate Researcher at the Institute of Informatics and Telecommunications, and Nikos Iosif, who is the President of the Human Health Intelligence Organization and CEO at Brains ICS, an encouraging title, and Thanos Kosmidis, who is the co-founder and CEO of Care Across. Please come and join us, Thanos. Christian Hosius, who is the Senior Clinical Director at MSD European Clinical Development, and as a commentators for us on this session we have Ioannis Souglakos, who is the Medical Oncologist, Professor of Medical Oncology, the Faculty of Medicine at the University of Crete. We have Emmanuel Saloustros, who is the Associate Professor of Oncology, the University of Thessaly, a member of the Board of Directors at HESMO. And finally, we have Elena Linardou, who is the Medical Oncologist Director, 4th Oncology Department and Comprehensive Clinical Trials Centre at the Metropolitan Hospital, FEW. We got through all of that. There's a lot of you, and you have a lot of titles. I'm very grateful to you for joining us. I'm really looking forward to hearing what you have to say. I don't want to waste any more of the time we haven't got, so let me hand straight across to you, Lilian, please.
Hello. Καλησπέρα σας.
Hello, it is with great pleasure that I find myself amongst all of you in order to exchange opinions and knowledge on this very important issue, the treatment of cancer in our country. Cancer is the major challenge for the Greek NHS, and I dare say perhaps the majority of healthcare systems across the world. It's a disease that is multifactorial, that calls for innovative and modern solutions so we can have a comprehensive and universal access to both the necessary structures and the services needed for every cancer patient. So in this context, the Ministry of Health took some important initiatives investing in systems and initiatives focusing on evidence-based approach in order to reach an anthropocentric approach. I know that many things have already been said, but I will try to focus during my brief intervention on the initiatives taken in order to promote healthcare services from diagnosis onwards. Now we have I will give you the full spectrum of the things already launched and in the pipeline, and I will close with our approach in order to finalize the holistic approach to cancer. As mentioned before, with an aim to improve the quality of cancer patients' daily lives and with an aim to improve the sustainability of our system, we have the home care initiative launched by the ministry. It's a program funded until 2025. 14.7 million euros come from the RRF, and it goes without saying that we have already paved the way for the ongoing phase of this project following the RRF contribution, so that the program will be fully organized at the level of regional healthcare units, and the organization for health services, for the quality of health services, will keep on following up with that. As Mr. Balani said before, an important component of this project is the following. We assess the healthcare services provided, both through patient-reported experience measures and on the basis of patient-reported outcomes, the POS. This project is run in three hospitals, including Agios Savas. We plan to have 10 more hospitals included in the program, and it is based on a comprehensive network of reporting centers that are fully equipped and staffed for the promotion of holistic and ongoing follow-up of cancer patients. Moving on. Let's talk about the digital transformation projects. Many reforms in this context have already been launched because we recognize the potential of using digital technologies in healthcare. The Ministry of Health has already prepared a set of reforms that will help prevention, early diagnosis, and treating cancer patients. I will emphasize on two of them. An iconic initiative is the digital care program for oncological patients, funded also by the RRF. There's three sub-projects. The first one is the National Registry of Neoplasmas. Second, this will be an IoT system handling all therapeutic methods, and an application, an app, to support patients who, for the very first time, will be allowed to have access to the entire medical record of their disease, and of course this app will allow them to have immediate communication and contact with their physician. Second, we have the telemedicine program in Greece, funded by the RRF, 30 million euros. Telemedicine in our country is developing more and more. Let me say that the second healthcare region of Piraeus and the Aegean Sea has been the first one running this project. Currently, they have 57 islands including the network and 66 points of contact between patients and doctors. Given that Greece, because of its layout and the insularity, creates problems when it comes to the access of cancer patients to healthcare infrastructure, we believe that this project will help mitigate these inequalities if we also take into account the fact that the telemedicine program will cover all our country, the entire of our country, within 2 years. Next point that also touches upon other aspects of this issue. We always say that in order to efficiently take care of an issue, we have first to make sure that we collect reliable and timely data so that every intervention we take is fully targeted. So in this context, we systematically collect data on the waiting times. Those who know what is the current state of affairs in Greece, they know that at the ministry level, at the Ministry of Strategy making, we didn't have this kind of data. So in our ministry, on a monthly basis, we collect this data. And when I say waiting times, I mean the time needed from the moment a patient is diagnosed until the very first therapeutic intervention. It can be an X-ray, or it can be the administration of a specific drug. So the original findings and reports we have collected, one might say that Greece ranks, it's quite high when it comes to the objectives and the standards that apply to other countries, including the UK. Let me indicatively just give you some details. So according to January data of 2024, findings showed that the weighted average of waiting time from the time of diagnosis to the first administration of a drug is 3 days. In Greece, when it comes to X-rays, it's 20 days. Access to palliative care following the first X-ray is 3 days. Of course, these are January data, and if we are to say that the pool of data is statistically significant and the data are robust, this means we have to go on with collecting this data. I think Mr. Kaptanakos will agree with me that there is a systematic approach being made. One last thing. Cancer survivors who are completing their treatment have sentimental and social challenges to face. I believe that we have every reason to be proud of the fact that in Greece, in Attiko Hospital, 2 months ago, we started the first clinic of cancer survival patients. That's a huge thing for our country. This center offers guidance on, for instance, diet, working out, etc. Plus, a comprehensive plan of monitoring for on a cancer patients. Cleveland Clinic, Mayo Clinic have the same thing. Carlinian Health Hospital, they have the same things. So we have a standardized process. We allocate costs. We're going to have specific standards for the staffing and the organization of this clinic, and we believe that within the next 3 months we will have a clear idea and a clear timeline for this program to be further expanded. And if I have, and I can comment on the moving forward aspect in my next intervention.
Just to wrap up, saying that all of that.
Just to wrap up, let me say the following. All the things I mentioned before, all these things that are in the pipeline, will be included in the National Action Plan Against Cancer with a 4-year horizon. So whatever I mentioned is being considered as we speak. We will have specific pillars in place for this action plan, starting with with prevention, early diagnosis, etc., emphasizing greatly on the quality of life and our holistic approach. This is why we have the survivor clinics playing an important role. So what is specific or particular about this program, that something that has never been done in the past, is that apart from communicating with all stakeholders in order to add their bid, patient associations, etc., we're going to have all co-competent ministries involved. Ministry of Finance, Internal Affairs, Ministry of Labor. So all measures will be taken jointly. All these measures that might affect every aspect in the life of a cancer patient. Thank you.
Along, Anastasia, one of the positions you hold, which I didn't mention when I introduced you, is your General Secretary of the Hellenic Artificial Intelligence Society, which is an evocative title. Let me hand over to you. Let's hear what you have to say.
Thank you very much. Εγώ λοιπόν έρχομαι από το χώρο της τεχνητής νοημοσύνης, της έρευνας
So I come from the world of AI research. So I will emphasize mainly on the use of AI for medical purposes. We see that there are AI-related developments every day. Things will change rapidly to a positive way, I hope. I'm talking about the healthcare sector. The aim is to have better decision-making, faster decision-making, and evidence-based one. We're talking about early prevention, diagnosis, treatment, decision-making for the treatment of a patient, etc. This is something enabled right now because of the fact that we can synthesize, we can combine big data and diverse data using the necessary algorithms. So there's a great deal of research on that. FDA has already approved certain applications, oncology, X-raying, and neurology, and EMA has also given positive feedback for the use of AI-enabled applications for faster clinical trials. So there is involvement by many stakeholders, hospitals, clinics, etc. So their implementation in Greece is quite limited by hospitals. There are certain barriers, certain obstacles we have to overcome. Two of the main challenges are the following. A, processing big data of critical mass, so we can come up with reliable applications. And the second challenge is the security of this information, of this data, so that health professionals can rely on them. And the same applies to the patients. They have to rely on this data. I have the honor of being a member of the Experts Committee on AI under the National Bioethics and Biotechnology Committee, which has recently published their opinion on AI-enabled applications on healthcare in Greece. So the report says that the underlying objective is to build digital tools, digital applications that will take into account both the requirements of the health professionals and the patients. We are not here to replace the experts. No, we're here to support them. We're here to support their decision-making process, and the aim is to make sure that these applications positively help the experts to take the right decision to the benefit of their patients. So the first point has to do with how we process data. So we need to accelerate digitalization involving registries, etc. So we have to have the EMR in place, a holistic EMR, the electronic medical record. At the same time, there is an issue here. How do we process these sensitive personal data? Because these data are useful, of course, if we are to use these applications. But on the other hand, the patients have to have control of them in order to protect their privacy. So there is an answer we have to give. there is a preliminary ethical issue. Does the value of personal data rank higher than the value of these data to the general public? In healthcare, AI-enabled applications that will analyze all this data will have a positive impact. That's what we believe. They will have a positive impact on public health. To this direction, we have to take into account that there is a need for access to this data by researchers so we can come up with more reliable systems. Now, talking about the security of these applications and the trust that every user should have vis-à-vis these applications, this boils down to the evaluation between the risks and the value. So before we approve these applications, we have to first assess whether potential risks that may arise are less than the benefits that may be delivered. Another important topic is the following. In order for us to reach the point of full use of AI-enabled tools, there is a thorny issue. How do we bridge the huge digital gap? We need digital literacy, both on behalf of the health professionals and the general public, so they can entrust and understand the kind of positive benefits they can get from AI. Ending, allow me to say that quite recently there has been a study. It's an empirical, evidence-based approach for a very innovative strategy on forecasting. They tried to display the kind of impact AI will have on all social aspects. We're talking about the generative AI. And this is a study on Greece, trying to foresee the impact until 2030. That's something built together with the General Secretariat of Digital Planning, the National Research Center of Demokritos, and other stakeholders. So it seems that we have a huge potential. AI is here. It will change the world of healthcare. What we need is for Greece to take the necessary steps so that we can keep up with the changes and have a positive impact on them. Thank you very, very much.
It's definitely a topic that we'll all be keeping an eye on, I suspect, and next time you're here on this stage, you'll be talking about that as well, I would imagine. Let's move on to Nikos from the Human Health Intelligence Organization and CEO of Brains ICS. I'm fascinated, what is Brains ICS?
It's activated absolutely only to the health sector.
Okay.
So what we are doing is only health, it's innovation, it's technology. And we are trying to learn every day something more in order to be able to help all the stakeholders of the health sector.
That's a great start. Let's hear your introductory words.
Can I have the...
yeah.
Oh, thank you very much.
So let me congratulate the organization committee and thank you for the invitation. Well, let me start from where Mrs. Krithara concluded her topic, referring to the significant need for digitization of the healthcare system. She set the framework of implementation of the AI in the healthcare sector. So let me move forward and discuss what Mr. Vilviridi discussed earlier concerning the digital transformation, where In the healthcare sector, AI plays a critical role in changing the management of cancer. Why? Because this is the tool that enables us to utilize all the scientific knowledge in a way to redefine standards and methods for prevention, diagnosis, treatment, and holistic care of onco patients. From the existing application, AI applications in the cancer care, well, let me put forward what I shall not discuss, meaning by utilizing AI, we are in a position to analyze genetic mutations inside a cancer cell and come up with the best treatments for onco patients. The use of algorithms, machine learning algorithms, in interpreting complex gene data has led us to highest precision relevant to the patient's response to treatment, meaning SVM algorithms achieve a precision higher than 80% in predicting the response of patients with ovary cancer. So when I want to discuss that deep learning and algorithm methods in screening may reduce pseudo-false results. Meta-analysis on JAMA Oncology reveals that imaging based on human analysis enhanced by AI increases the sensitivity rate in detecting cancer from 88 to 98%. And again, AI maximizes and optimizes tissue analysis, enabling the detection of cancer cells at a precision rate which would be impossible with human eye. The deep eye technique reduces pseudoanalysis and by 7%, and I will not discuss that embedding AI in the analysis of real-world data has opened essentially the path ahead for personalized medicine. Why? Because by analyzing models and data of patients, AI tools may detect correlations between therapeutical results and features of specific patients, essentially pacing the path ahead to more specialized treatment. And again, something already mentioned by Ms. Krethara, we are heading towards the redesign of clinical trials because algorithms may reduce the cost and the time required for trials, and the AI capacity monitors at real time and adjusts the therapeutical protocols, thus putting forward new models in terms of safety and efficiency of trials. Those are just few indicative examples that I will not refer to, however, leading to something that I would like to discuss. They lead us, if we embrace AI under, of course, safety and ethical conditions, reliability conditions, and the continuous training of all of us, leading us to avoid just adopting one more application, but open the path towards a treatment that shall be fully personalized in line with the patient's data and results. And I'll discuss that we change and transform the care of oncopatients, we reform the healthcare system. And this is the most important point. Thank you very much.
I think that's the first time I've heard a presenter take up all of their allotted time telling us what they're not going to discuss. And then what you did discuss, you were very, very brief. So I'm grateful to you for that. Let's move on. Thanis Kosmidis, who's the co-founder and CEO of Care Across. Tell us about Care Across and give us your thoughts on innovation, the future of innovation in cancer.
Of course, thank you. Ευχαριστώ πάρα πολύ για την πρόσκληση και την...
Thank you for the invitation and the opportunity I'm given to share with you some few results and a case that we've just heard earlier. Digital support, this is my topic, and on my slides you'll see a clinical trial, Clementine, clinical trial Clementine. It with advanced microcell lung cancer. HiCoG is the leader with the support of Stavros Niarchos Foundation. One of the innovations of this trial in terms of design is that it has 3 different pillars. The first one, recording of clinical practice. With the assistance of different centers, we really actually record what a trial represents in the specific disease in our days. Second pillar, the molecular analysis from NGS. We bring patients closer to personalized medicine and precision medicine. And the third pillar, digital support, which in practice means that the quality of life is supported by means of different digital tools. So let us see some features. We are speaking about a digital online platform, interactive platform, accessible from anywhere, focusing on the side effects. Side effects that are recorded anonymously by patients themselves. And I'll get back to that later. Similarly and in parallel, the doctors have a continuous access by remote patient monitor to all those data. And getting back to the side effects, this is a significant part of the study relevant to randomization through the platform. While patients record their side effects in a structured way, there are 2 arms. In the intervention arm, we have support via evidence-based data to improve finally the life of every separate patient. We try to help every individual to acquire a higher quality life. The basic ingredients of this support is as follows. Practically as material, texts that are based on scientific instructions, drafted in a very simple and understandable language for all patients. This is very important. We need to stress us. Of course, we need smart algorithms to provide personalized support, and this is done thanks to the support of scientists. And of course, we come up with measurable results. And last but not least, the concept leads us to a simple and usable, easy-to-use technology. It doesn't require specific knowledge. It is accessible and practical. All the above by utilizing interdisciplinary experience and cooperation of years. So medicine, thanks to applied technology. This is relevant to Care Across, the question that was asked earlier. Digital health and cancer company, having a patient-centered orientation, putting the emphasis on the quality of life. And of course, Thus, the professionals' part by means of remote patient monitoring, and in the last years, we are in a position to collect a higher number of evidence relevant to the impact of those tools on the patients, the professionals, and the system itself. Getting back to Clementine, let me share with you something that we have discussed in ESMUS conference, the interim analysis, where we demonstrated that this interaction is feasible. It is feasible to have those patients, even those with metastatic lung cancer. Despite the difficulties, they are very systematic in recording their side effects. And this is important to be stressed because we are speaking about a daily recording of side effects and challenges, which is very important both for the clinical practice and the research. Remote patient monitor is a reality for healthcare professionals as well. And let me stress at this point that it has been already clear that the patients randomized in the intervention arm present far better quality life results as measured by the data they record themselves versus the control arm patient. It appears, in other words, that it supports the patients in many different ways while being helpful for doctors. Let me conclude by thanking, first of all, the patients that have joined the study, HECOG, and the Stavros Niarchos Foundation. And of course, there's my email. I'm available to answer any eventual question. Thank you very much.
Christian, MSD, please.
Yes, thank you. Is it moving forward here? Can you give me the slides, please? Okay, thank you. So thank you for the opportunity to present on the future of clinical trials. When it comes to the prediction of future, I'm not sure if I, coming from Germany, can be as precise as the local experts here with a long experience of the Oracle of Delphi. However, I will do my best. Here you can see data from a successful trial in metastatic breast cancer. In a way, it is the agenda of my short talk. At that time, we were happy with the results because patients represented in the green line in the experimental arm benefited from a new treatment when compared to the standard of care in red or brown. The study was positive and led to an approval of the new molecule. However, when we look more closely, we can see that many patients died early on, and not enough patients had a long-term benefit. So we need to identify the patients who will benefit from a treatment before we start to treat. We also need to start the efficient treatment before the tumor starts to develop metastasis. And we need to speed up the development of our compounds with better trial designs. Otherwise, patients in need may miss opportunities. Traditionally, drug development starts in the late lines to reduce the risk of for the patients to receive a treatment which is relatively new. However, we know that patients benefit longer from an effective treatment when it's given earlier. Today, we see more patients are diagnosed in the early phase, and we have heard it today several times, in the early phase of the disease due to technical progress and improved prevention policy. You can see the dark green in these circles is an early stage diagnosis, and let's say 20 years ago, most of the patients were diagnosed in the metastatic stage. Therefore, we need the best treatment options for a growing number of patients when the tumors are still small. Cure is only possible in the early stage of cancer. So we need more trials in adjuvant and neoadjuvant setting. Another important objective is to identify the right patient for the right treatment before the treatment starts. So we call it tailored treatment. Of course, this is not always possible for all patients since we do not always have a target. In the lower part of the slide, you can see different tools like liquid biopsies, novel imaging technologies, or machine learning or artificial intelligence as examples for this approach. It also means that the design of our trials will change. We need to come up with new trial designs to allow the identification and testing of smaller patient groups with a specific marker and characteristics. We can design these trials, however, the agencies need to support and agree to this strategy. Here you can see an example of a modern trial design. Without going into the details, we try to identify which molecules could be effective in a certain type of cancer in only one trial. Later, we expand for confirmation of efficacy and tolerability in a phase 3 trial for each component. And finally, with our trials, we need to focus more on what is most important to understand if the molecule is safe and effective to be approved. There are many questions which could be answered since we have a trial. However, not all of them are important. Every additional question makes it more complex and eventually harder for patients. The question is, which data are required to answer the relevant questions without compromising the quality of the trial? The lean design is another challenge which also offers a lot of opportunities. On my last slide, you can see what has been achieved in Greece over the last few years, and we hope that the importance of clinical trials will continue to grow. Since 2019, the number of MSD trials in oncology was more than tripled. We all together, physicians, patients, payers, health authorities, and companies can make a difference, and none of us can do it alone. Thank you.
Thank you very much. We're going to move along to the first of our commentators, Yannis, medical oncologist, professor of medical oncology, the Faculty of Medicine at the University of Crete. Your thoughts, please, on what you've heard, where we stand in this question of innovation in cancer.
Thank you very much. I try to keep it as short as possible.
I would appreciate that.
Οι Έλληνες ογκολόγοι με έχουν ακούσει.
Greek oncology.
Oncologists know my view on hematology and oncology, that those are the two most thrilling professions on earth. Even though we get very tired, we go beyond our capacities. However, there are no 2 days alike. Repeating, meaning every day the same thing over and over again. This doesn't exist in oncology because we accumulate fresh knowledge every day. So whatever you do in a month, it's totally different the way you deliver it a month later. This thanks to technology, advancements and innovation in the field of computers, the power of internet, AI and so on and so forth. However, The term innovation is misunderstood because we're limited on biomarkers, new drugs, even though this is something quite wider, including personalized pre-symptomatic early there is detection, which inspire us in terms of early diagnosing. Aris Patrinos and Nicholas Papadopoulos in Johns Hopkins have pioneered in this field, mainly the CDD program. Innovation is the study presented 12 years ago by the Indians in ASCO, and there has been an extreme case by utilizing different other standards before the test PAP, which ended up in the diagnosis of 20,000 women with cervical cancer. Or other examples existing in different parts of the world. Innovation, all those trials and studies which indicate that doing less is very significant in the oncology, saving people from unneeded, unnecessary treatments which may destroy lives. MSI, colon cancer, they won't be operated, they won't undergo radiotherapies, thus they may save their lives. To have those studies and those trials, we need to free the trials in the field of academia, whose role is different. The academia needs to investigate the way different methods are applied, and for this reason it would be good for it to be in a position to deliver studies. And innovation would be if we had at last a national cancer center which would survive irrespective to the governments in office. At least this is my knowledge and my experience, having worked in 3 different countries. And last but not least, and a verbal observation, because I've been listening to must need several times, multiple times this year. Let us replace it with I want, I wish, because we need involve some kind of obligation that other people might need to do it, whereas I want, I wish indicate a personal desire for involvement. Thank you.
Let's move to the University of Thessaly, Emmanuel Salustros. Welcome, it's good to see you. It's always a relief to see someone who's appearing virtually actually appear. So welcome in your electronic form. Would you like to give us your thoughts, please, on what you've been hearing of this panel?
Thank you very, very much. Thank you for giving me the opportunity to be here with you online. I think there are no better words to describe innovation in oncology better than the ones used by Mr. Tsouglakos before me. However, allow me to make some comments, a bit more practical, with respect to Mrs. Vildiridis' amazing contribution on innovation and the developments in oncology in Greece. Allow me to add the following. Access to drugs. The Greek state has always been quite generous towards our patients. Talking about novel drugs, there is room for improvement, of course. But this doesn't let's say, invalidates what we said before about the access to drugs. So we have to cater for our patients at all stages, from screening, prevention to treatment, and as for prevention, it is a fact that in Greece screening is voluntary, it's not mandatory, and there is no specific pathway following the initial examination in order to have proper evaluation of results. Access to treatment is quite satisfactory, but the circumstances of its administration can be improved. I have worked in various hospitals and they are extremely pressed in order to cater for many patients within a very specific morning shift. So the same way we have the so-called afternoon surgeries, we can have something like that for cancer patients. As mentioned in the previous panel discussion, there is a need to improve the post-treatment life and the palliative care levels. Last but not least, technological developments, AI, these new technological enhancements, they are amazing. They bring about a new realm of scientific research, but also under these new circumstances, a human touch, human smile remain of major importance. They will be irreplaceable. I try to remind myself of that, and I try to teach that every day whenever I have the opportunity to my students. Thank you very much once again for giving me the opportunity to be part of this really interesting event of Economist.
Indeed. We don't have a lot of time. When do we ever have a lot of time? But we certainly don't now. But I do want to come back to all of you actually with a general point that I think has been floating around in the discussion all day, and I'd like to sort of address it here. This will take a slightly different form for you, but we've been talking about how the industry is surging ahead with really promising, expensive potential treatments, potential diagnostic tools, machines, artificial intelligence, processes and the like. How do we square that with the requirement that we offer equality of access across the board, and that cancer doesn't only choose people who can afford to pay for expensive treatments, but it affects absolutely everybody? So I want to look at that question of how innovation might help improve access across the board to everybody in all of our societies. Let's start with you, Deputy Minister. What's the government's view on this? What efforts are you making? What plans do you have in the context of innovation to extend access to cancer treatments and diagnosis across the board?
The general context is the following. One of the major challenges we face right now, and we all know about that, although we talk about innovation and policies, etc. Currently, we have no registry. I believe that the Neoplasma Registry will enable us to have a full, complete understanding of the people in need, the stage they find themselves in, so we can have a comprehensive, holistic context and framework in order to identify the required interventions, the extent of these interventions, and then, of course, we will be able, in a targeted way, to identify the funds needed. Drugs, therapies, treatments. We have here the General Secretary of HTA and Drug Assessment. We have to do that in a coordinated way. For us, the most important thing is to map the current state of affairs, as I said before.
Your turn, please. Your thoughts on this. I'm going to come back to you because you haven't given us your comments on the session. Perhaps you could tie them in with your answer to this question, please.
Yes, I do believe that equitable access is of major importance, and of course technology can help to this direction. I'll give you an example. Technology may enable people living in remote areas to have access because they live in faraway places, but thanks to IT applications they will be able to get treated, have a follow-up by physicians that are somewhere else. So yes, technology can help in this regard. It will help us also collect data, and this will allow us to identify where the problem lies. what other population groups, for instance, who have no equitable access. Technology can help us overcome this problem. And as I mentioned before, this is why the RRF funds actually an IT system registering all therapeutic methods. And as you said before, with the use of technology, we're going to have a mix and match of requirements and treatments across the board. I think, let me start from the point I finished before. The use of technology and AI is actually the only feasible alternative we have to revamp our NHS and allow all citizens to have access to it. Access, I mean, to high quality healthcare services. Why is that? Because it is a utopia to say that we can inaugurate 100 new hospitals. It's a utopia saying that we can have an equally big number of well-paid physicians. It is a utopia to say that we can triple the nurses, all right? So, with the existing staff, and also by means of training and upskilling ourselves, we will be able to replace or to cover up for our deficiencies with tools that will allow us to provide good and quality results to the ones whom we all report to, the citizens.
Move to Christian, next in line.
I think we have kind of contradictory objectives. On the one hand, we want innovation, and innovation is always expensive. On the other hand, we want to provide cheap drugs, which are affordable for all of us. So that's a contradiction. However, I think we can, and this is also proven by the past, when we all work together, we will find ways. Everybody has to focus on their objectives, and then we will realize that, for example, with new technologies, the production of drugs will be much cheaper nowadays when you compare with the past. So personally, I'm very optimistic for the future, but we have to realize that this is something kind of contradictory, but we will bring it together, I'm sure. We all have to work together on that.
Okay, work together sounds like an innovation in itself. Thanos, your thoughts?
Well, thank you.
Firstly, this last part of our discussion is a great summary. I mean, we're talking about interdisciplinary collaboration, we're talking about AI, we talked about data collection, very important thing, and we also heard about the need to upgrade our NHS. Technology is not the solution, it's the means that will bring us closer to the solution. So, if we put all this in the same pot, let's say, we come up with what it is at stake. But let me add to that something I heard from various stakeholders in another discussion, equitable access to cancer care. It's the following. Apart from access to drugs and treatments, which of course everybody wants to have access to these new technologies and drugs, do have a way to map the preferences of patients in this balance between toxicity and life quality, access to drugs and quality daily life. We're not all the same, right? So we have to have this kind of opportunity to take some distance and listen to what our fellow citizens say. Technology enables us to do that. Hopefully we will make it. I believe that over the past years, oncology is gradually turning into the art of handling rare diseases. Depending on the biomarkers and the biomarkers, etc., this is something very rarely achieved. That's why, in some cases, we have been able to increase the value we get out of what we pay, just by turning the treatment into something more affordable. And I think this is the way. What we believe it is expensive, it has to give us high value.
Your thoughts, please.
Είμαι πολύ εντάξει. Θα δώσω το χρόνο μου στην κυρία Λινάρντο και όσους είναι στην αίθουσα και εγώ θα συνεχίσω να σας παρακολουθώ με πολύ ενδιαφέρον.
Okay.
Έχεις διαφανίες.
Elena, apologies first of all for missing you out on the first round.
That's okay.
You're just so far away. I could barely see from here. Your thoughts, please. I'll give you the final word. You can sum everything up and you can give us your own presentation
Okay.
on the topic.
Thank you very much. I think it's extremely important that in this round table you integrated health professionals and technology professionals. So allow me as a health professional to give you my views on technology.
Please.
I believe that η τεχνολογία επιτρέπει πλέον
So I believe that technology allows us to collect huge volumes of diverse data information from patients, starting from simple clinical data and medical records down to very accurate and granular medical data. So this big data, this is the new jargon we are currently using, so this big data play a catalytic role in AI-enabled applications. It allows us to identify common patterns which might be critical in the context of therapeutic processes, treatments, etc., in the context of what we called before personalized approach to medicine. So, integrating big data analytics and algorithms and AI, I strongly believe as a health professional, not as a technologist, that will bring about a revolution. The revolution is already here with us. And this revolution changes the future of healthcare by introducing strategies that will allow us to offer healthcare in a completely different way. I'm a GP oncologist. I believe that in my area we always innovate. We are always at the forefront of innovation, as Mr. Souglakos said, and in order to overcome the existing challenges and the skepticism, and especially from those who develop technology, not the ones who use it mainly, there are a couple of things we have to do. A, we have to intervene in a very specific way and target way. Second, we have to have the same language, all of us. Third, we have to invest heavily in technology. And the fourth most important thing is to collaborate. As said before, we have to come together and have a discussion ourselves, the health professionals, who will use AI and other technologies. We have to have the same language with the people who develop this new technology. And let me give you an example, just 60 seconds. This is an initiative which I have had the honor of being part of for the last 12 months. This is an initiative entitled I3LANC. It's a huge pan-European program, fully financed by the European Union through Horizon 2020. Our country is part of this project, and it's important to say that Greece is part of these initiatives. We take on such initiatives, and it finds itself always amongst stakeholders from around the world. We have 16 centers of excellence from Israel, Europe. You can see the oncological centers listed here. Some of them are of great statute. So, Greece is part of this program building this. We have already launched the program 1 year ago. It will be completed in 5 years' time, fully financed, in order to build the first patient avatar, lung cancer patient who is receiving some immunotherapy. It's a very targeted initiative, and we feed these AI-enabled models with data, clinical tests, pathological ones, genomics, whatever you name it, radionomics. So we built a platform using all this data coming from 2,000 European patients that will be used later on by the patient themselves, or the doctor, or the researcher, specifically to the benefit of lung cancer patients with immunotherapy. I think such an example shows you that AI is here, it is with us, and it can help build the future of oncology in Greece. Thank you.
And I have good news. The bad news is that I'm cancelling the coffee break. Sorry. But I won't take offence if you want to wander out, pick up a coffee. I do suggest you bring it back in, because the good news is that our next presentation is going to be excellent. Before we go on to it, though, I want you to join me in thanking what's been an excellent panel. Thank you very much indeed. The next presentation is coming from us remotely. We have a single speaker who's going to address us on the topic of EU and national investment opportunities, which sounds like a very promising topic. We have Sofia Chesfinki. Forgive me if that name is unrecognizable. Horizon Europe NCP Health and Cancer Mission, Project Manager of HNN 3.0 and ECHOS in Greece, and the Chair of the ENN SG Health.
I think that Sofia is unwell, so I think that she won't be here. I think we will move to the panel directly.
Is she not joining us remotely?
By connection, maybe it's changed then. She will join by connection. Okay, she's there.
Is she with us?
Okay, perfect. Then she's here.
Sorry? She's not available. Oh, she is available. Yeah, that's okay. Let's just go straight on. We have, Sofia, we have you here on the screen. No, I didn't. I said they could go if they want to. But Sofia, welcome. It's good to see you, albeit remotely. If people would like to take their seats, and so we can all hear Sofia, please take your seats. And we'll move straight along. Okay, Sofia, please, your thoughts on this area, the EU's and national investment opportunities. Thank you.
Thank you, and for this honorable invitation. No worries about my last name, it's difficult even for the Greeks. I'm going to switch to Greek. And before that, I'm giving you my apologies for not being there with you. Σας χαιρετώ λοιπόν, σας ευχαριστώ για την πρόσκληση.
Thank you for the invitation. I represent the National Substantiation Center responsible for health and cancer in Europe, and I'm pleased to be coordinating the European networks, whereas I chair the Enterprise Europe Network. I'll be as consistent and brief as possible. So you all know that cancer affects all of us, irrespective to our social status. It is a social challenge affecting both patients and their families. On the basis of today's data, the number of people suffering annually from cancer shall exceed 4.5 million people in the next decade. Of course, aging and chronic diseases require multiple and different treatments, increase the relevant costs and raising it to unsustainable rates, requiring more healthcare services. However, dealing with cancer remains one of the top priorities for the EU. As of 1985, the European Commission has been investing on technology and innovation to deal with all those challenges. Thus, the method for funding the battle of cancer, starting from September 21, in line with the European plan starting in February 21, reveals that we need a far more holistic approach. Thus, the mission involves the improvement of life of 3.5 people in line with three pillars: improvement of their quality of lives, both of patients and their families, a holistic approach aiming at activating both private and public structures, investors, including patients and their families themselves. A specific agenda is proposed at the European level, together with policies, mainstream policies throughout all fields. Thus, all investments need to be rationalized, and you can easily understand that those initiatives are different at European level. Unfortunately, the new working plan for 24 hasn't been published by now, so there haven't been any calls. However, dealing with cancer is clear on the calls of different other projects. EU for Health, for example, it started as an ambitious response of the European Commission for COVID-19 and currently provides technical and financial support to the EU member state, enhancing the relevant systems horizontally, focusing on cancer. Well, it is clear that there are several attempts and efforts in Europe. In Greece, we have different challenges that need to be dealt with urgently, relevant to the lack of knowledge, fragmentation of the information in place, the responsibilities allocated between different organizations, even though there are multiple actions in place that can operate as sources for the production of data that may help us to put in place more projects and plans. So this might involve finally a network, and this is actually the ECOS network focusing on actions for cancer. The consortium brings together the knowledge coming from 28 different countries, our center being the Greek body, the body representing Greece. We wish to create cancer hubs in every different country. Why? Because we wish to have the involvement of all stakeholders, both from the private and public health, and activate them in different fields, both at a national, regional, and European level. Currently, we have completed the recording of all actions that are relevant to the fight of cancer at the European level, and currently we are building synergies because we want to build a single mechanism under which all those hubs shall be active, reducing thus the different levels existing in different countries. Namely, there are countries having national hubs for cancer. There are others that have cancer hubs without, however, being closely related to the actions of the mission. There are others that are just getting built, and there are others, such as Greece, that could develop and take the form of cancer hubs. However, this transition hasn't been completed by now. So this is the stage we are currently in cooperation with the Cancer Patient Federation. Our center has been providing support services to research centers and the academia, and we invite you to support our effort so that we can deal all of those challenges together, pace the path ahead for more synergies. Thank you very much.
Thank you. Thank you. Okay, well, let's move along with many thanks to Sophia again for participating and joining us remotely. And we'll move right on to our next session, which is the last of the panel sessions of the afternoon. So we're going to be talking about, we did mention previously that, and a number of our speakers have mentioned, reminded us that actually what this all comes down to in the end is the experience of the patients, and that's where we're going to focus in this session. How can healthcare systems respond to patients' needs? We have another busy, full panel, but an excellent panel, and I'm looking forward to meeting all of them. First up, we have Aris Angelis, who is the Secretary General for Strategic Planning at the Ministry of Health here in Greece. Mr. Angelis, please come and join us. We have Amanda Psiri, who is the Professor of Medical Oncology at the National Kapodistrian University of Athens and Chairman of Internal Medicine at Attikon University Hospital. Welcome to the stage. We have Maria Avgoustidou, who is the Medical Oncologist, Palliative Medicine, Athens Medical Center. Please join us too. And Nikki Tsuma, the President of the Board and CEO of IDICA, the e-Government Center for Social Security Services. We have Olga Sisku, Emeritus Professor at the University of Piraeus, who is joining us remotely, as, by the way, is Amanda Psiri, who I mentioned earlier. And then commentators for this session, we have Paris Cosmidis, Head of the 2nd Medical Oncology Department at Hygeia Hospital, former President of ESMO. Paris, please join us. And Athanasios Kotsakis, Professor of Medical Oncology at the Faculty of Medicine, the School of Health Sciences at the University of Thessaly, who's also joining us remotely via a connection. Please, those of you who are here with us in the room, come and join us here on the stage. Responding to patients' needs. It seems obvious, it seems what you would guess all of this is all about. But let's hear the government's response to this particular aspect of this topic. Mr. Angelis, would you please take us away on this?
Right, yes, thank you. Thanks for the intro.
Welcome.
I think there's a coffee break, that's why some people...
Well, I cancelled the coffee break.
Okay. Right. So I have prepared my speech in Greek, so if you don't mind, I'll switch to Greek and then we can exchange in English again.
Allow me to skip some points that I have prepared on the epidemiological status of cancer in Greece and Europe, because it has been already clear the way the condition of the disease develops in the long term and its severity in our country. I'll discuss some points on how you can help the patients in having access to new innovative treatments. So I'll try to be well substantiating and justify whatever I'll be putting forward in 4 different sections. First of all, well, we are living in a totally different era compared to what was the case 4 or 5 years ago. We have all the more new innovative treatments of cellular treatments, gene treatments with impressive results, which, however, are coming at increased prices, and the systems need to deal with a higher costs, and oftentimes there is a uncertainty in terms of the final outcome, which might be even marginal, if any. So the access to affordable and effective treatment becomes all the more important. And now let me put forward some data, beginning with the number of treatments in the market, getting in the market, the new drugs in the past 20 years. FDA in the US approved 720 drugs, out of which 100 were onco, anti-cancer drugs for 455 indications. Now, the real innovation, the real studied in trials in the pipeline for medical products, will see that we have 428 treatments as of the beginning of the year in more than 528 clinical trials, and this is what we're expecting to come. The prices now of those drugs, 548 drugs launched between 2000 and 2001, demonstrate that the average prices, the launch prices of those drugs increased from $2,000 in 2008 to $185,000 annually in 2021, which is an impressive increase of 20+ per year. And if we consider the new treatments approved until 2023, in 5 years' time, those prices was less than 150,000 euros. However, considering the number of treatments that were higher than this price, well, this would indicate an increase by 47%. And the net prices increased from 1,000 euros in 2001 in 168,000 euros until last year. The expenditure in the US for prescribed drugs in the past 20 years, 2020, the prices tripled their prices. And in Europe, between 2008 2018, the prices doubled the amount. And for rare diseases, and rare diseases account for 50% of the overall expenditures. Concerning the forecast and what is predicted, the global pharma industry shall represent 1.8 trillions in the years to come, an increase of expenditure reaching as high as 472 billion for onco drugs, currently represented to 224 billions. In the next 4 years, in other words, there shall be an increase by 248 billion euros, 14 to 17%, and an overall and a total expenditure increase higher than 100%. Now let us see the clinical value of those drugs. The data as of the 70s demonstrated that 1 out of 6 new drugs, or rather 1 out of 10, present significant benefits. Same outcomes are in place, supported by recent studies and trials. The HTS bodies of France and Germany indicate that most new drugs, however, present little benefit, and in terms of the life of patients themselves. In the onco field, the assessment of EMA between 2009 and 2013 demonstrate that most drugs got into the market without significant clinical benefits for the health quality of life and significant improvement. In other words, they have been using surrogate endpoints. In the next 3 years and a half after being launched in the market, for most of those drugs, we didn't have convincing evidence as to the added value in terms of quality of life. There are more similar studies, have got more data concerning the extent, concerning the additional benefits generated by those drugs. Now let me get back to the access. What is the problem for the national healthcare system? The patients shall keep asking for fast access to new treatments, even though their clinical benefit might not be fully demonstrated. So what do we need? We need to change our culture, our mentality, because the current one feeds a philosophy which is equal to the following: all new treatments are best, are the best. Even though there are radiotherapies and all the treatments that are efficient, so we need to enhance the assessment of new technologies, the new treatments in terms of clinical performance. That is, we need to be well convinced that new treatments produce significant new benefits, and we need to assess them in terms of their value for money. That it is worth investing and making them available. And again, we need to consider the sustainability, the budget impact, in other words. They need to be clinically performant and effective and sustainable in terms of their budget. For the time being, the Ministry has been developing different actions, well-coordinated actions at a European level as well, in a way that we are well prepared when the new HTA regulation is in place in 2025, which will allow cooperation for the assessment of new healthcare technologies at a European level in different countries and at scientific consultation level, beginning with medicinal oncoproducts, cellular and gene therapies. Thus, we are preparing the field so that we are ready to be active participant in this new regulation and cooperate with other countries. And something more that we can do, the use of different assessment tools is required. Allocation of risk, agreement on the basis of outcomes, as there's lots of uncertainty in relation to those drugs. We can't be discussing for risk agreements focusing on the outcome without taking into account the actual number of patients recorded, and of course the real-world data, the real-world evidences, where the interest is very high. However, we need to come up with a correct way to embed them in the assessment. And of course, there are more structural issues, the supply chain, the organization of different agencies involved. Well, currently, the priority of the Minister is to structure a strong patient-centered system which will allow full coverage of the needs of patients by balancing the policies required both for the patients and the industry itself. Thank you very much.
we're going to move on, but just before I do, I just very, very briefly wanted to put a question to you. You mentioned a change of culture and introducing patients to the idea that it may not be that the newest treatment is the best. Is this a Greek issue? It seems to me to be a very commonplace thing.
Not at all. I mean, it's a global trend, right?
Yeah.
And there is this, like, I don't know, misconception that everything new that comes into the market is also better and improved, which is not the case. And because of the high trade-offs of having to pay excess amounts of money in order to get access to these new treatments, this is why it's much more critical to focus on the right, robust scientific assessment of these new treatments and these new therapies. Otherwise, the implications of providing access to something which is not worth its money is detrimental towards the improvement of the health to the rest of the population of the country.
Yeah, okay, that all makes sense. Let's move along to Amanda Siri for your thoughts, please. Yeah.
Here, so I can go there.
Of course, please.
Good afternoon. Thank you very much for the invitation. This is a very important event for cancer patients and stakeholders. I'm going to present one of the activities of my department, the development of survivorship clinic, which is the first survivorship clinic in Greece. I am professor and chairman of Attikon University Hospital, and we are building a new cancer center there. I did my training at Yale University, where I was a professor, and I'm trying to introduce new ideas and new concepts to my department, aiming to meet the international standards of cancer care. So we developed, what about the survivors? We know that the treatment of cancer has made substantial improvements, and a substantial subset of the population, of the cancer patients, is cured with novel treatments. So now, with the novel therapies, immunotherapies and targeted therapies, a substantial percentage of patients, even at metastatic stage, survive the disease. So how do we define the survivor? The survivor is every patient who is diagnosed with cancer at the time of diagnosis. So every new cancer patient is considered a survivor. And we have made improvements in cure rates. However, improvements in survival should be accompanied by improvement in quality of life, because it's the quality of life which matters most. Many patients survive the cancer but suffer, so we are trying to minimize the side effects of treatment, the long-term toxicity, but also the disabilities associated with cancer itself. So, since cancer treatment has made significant steps, now a new issue in our care is how to deal with the survivors and their quality of life. And in international centers, several cancer centers have developed survivorship clinics, Of course, you know, they have been ahead of us. It's when I went in 2013 in Australia to give a lecture at Peter MacCallum Cancer Centre in Melbourne, there was Olivia Newton-John Center, a spa, where patients could do yoga, get advice regarding nutrition, sleep quality, smoking cessation, and all these issues that are very important, and the psychosocial issues associated with the treatment. We were far behind at the time, but now I think we are very close to develop a state-of-the-art survivorship clinic in Greece. And we see across the globe several cancer centers, and psychosocial support is a big issue in cancer care. We see that cancer centers such as Royal Marsden, for example, had developed even beauty clinics that they give beauty advice, makeup advice and everything to the patients. And we hosted a makeup event in my department in collaboration with Sephora regarding skin care and makeup advice. And the patients who attended the seminar were very happy with that. So we built the first survivorship clinic in Greece. You know, our patients were very happy with this initiative. So how this clinic works, we book an appointment with the patient, and this is the team. You know, I'm the chair of the department, and Dr. Kalaidzi is a physician specialized in physical medicine and rehabilitation. She is specialized, is the president of the Greek Society, the Hellenic Society of Lifestyle Medicine. So Poppy brought this initiative to my department. She has been educated in lifestyle medicine at Harvard University. She did her residency at Charité in Germany, where the survivorship is you know, a focus of cancer care, a major focus of cancer care. And you know, she developed the program, the algorithm of the evaluation. And we have 6 very important assessments. So the patient is getting an interview at the first appointment and an evaluation regarding physical activity, nutrition, psychosocial needs, quality of sleep, addiction, and you know, social issues or side or toxicity associated with the treatment, such as cardiotoxicity. We have cardio-oncology section in my hospital, and I'll
have to ask you to accelerate a little bit.
Yeah, with European funding. And also the assessment of the risk of secondary cancers. And then the patient is referred to all these subspecialties of our network, and then receives a report on the needs and the appointments that are needed to improve all these aspects of the quality of life. There are 6 weeks intensive sessions. Of course, everything begins from the patient and the need and the decision to make a change in his or her life. So this is the concept, and the challenge is to build on this program and disseminate the program in different different areas of Greece, because we need to build a network, not just one program. And the Ministry of Health is very much interested in this context, and we have industry support. This is a summary of our program. Thank you for the opportunity to present briefly our initiative.
Thank you very much. Let's move on now to Maria Augustidou.
Thank you. Thank you for inviting me. Ευχαριστώ για την πρόσκληση. So I have a presentation. Θα μιλήσουμε για την
We'll discuss palliative care. You may be aware of the data that I shall be presenting regarding the value of palliative care in terms of home care, delivered services or in a hospital. I assume that you know this holistic care as recognized by the IWO, covering the patient and her carer as of the onset of the disease, the first diagnosis menacing her life. It aims at providing services at an emotional, physical and social level. And of course, as I mentioned earlier, it involves all stages whenever there is a life-threatening diagnosis. In our country, we've got 3 specialized programs for palliative care. Practically, however, we'll see whether they are truly specialized. 50 oncology departments and 57 pain clinics. Some of them provide general palliative care services. There's 1 specialized palliative care for home care, where I'm active personally. In Greece, 135,000 patients and their families need palliative care service annually. Approximately 15,000 patients per day, and strangely enough, 95% of those patients that need such type of care for bodily issues, pain, breathing problems or other challenges relevant to their daily activities, well, they could have been resolved by a scientific group visiting the patient at her place. Out of those 120,000 patients, only 3.5% need essentially to be admitted in a hospital, in a hospice. Such a structure is Galilea in the area of Sparta, the only one in Greece supported by an NGO. Why we are stressing the importance of palliative care? Because if it is introduced at an early stage, it could relieve the system from unnecessary costs that need due to useless treatments, unnecessary admission to hospitals. It is an overall burden for the family, emotionally and financially. It's a burden on the staff and, of course, for the entire healthcare system. Thus, speaking about an improvement, the first that I would propose is to recognize palliative care as an essential specialized healthcare service as it stands in the entire West world. in our country there isn't a clear legislation framework recognizing it and providing for the training of professionals together with a part of financing such care. 70-80% funded by the state, at least. And of course we need to train the medical personnel accordingly. The staff in place is enough, but we need to train 4,000 health professionals, both nursing staff, doctors, psychologists, but we need to define the training framework and have it well well organized. To conclude, all those efforts started thanks to this lady, Cicely Saunders, who made it clear that it is not important whether we are alive or dead. The point is to leave this world in a decent way. So the way we leave this world is extremely important. Thank you very much. Mrs. Zuma, you have the floor. Yes. Good afternoon, and thank you very much for the invitation. It is an honor for me to be part of this event, a very important conference on health, and discuss the value of digitization throughout the entire spectrum of our discussion. I'm very pleased that I can speak about prevention. Many things have been said on treatment. However, prevention is equally important. We are proud, as in the past 2 years we had organized together with the Ministry of Health, we have put forward rather a healthcare prevention on mammography for selected women group, which means the following. Technology was able to support the Ministry of Health in a way that this action is not simply mandatory, but it actually reached all women that need to have a mammography, a ready-made prescription. As you know, there have been several rules and campaigns, and that was it. In this action, we did locate in line with medical guidelines all those women that had to have a mammography. We produced the mammography prescriptions that were sent via mail to their personal e-addresses, or were ready-made on the system, and the first doctor the woman visited could present it to her. So it wasn't just a notification, it was actually received by all those women. With this prescription and referral, the action is still on. She could use it and have a mammography in any center, depending on the result of the mammography and the diagnosis which was recorded. Depending on the type of BI-RADS, you know what I mean, you doctors, there was a referral for an ultrasound, meaning for a further test, provided that there was a finding detected. So this, without any bureaucracy procedures, well, everything was resolved. They've received the referral and the prescription on their phone. 300,000 mammographies were delivered and executed in this way, 60,000 results BI-RADS 0, 212,122, and the rest of them BI-RADS-3. In other words, those that received finally an ultrasound, undergoing ultrasound. So this has been a very successful preventive action of prevention. Those are the steps that I have already explained, simple, digitized steps, ready on and delivered on the beneficiary's phone. And a side where each one could check the contracted doctors, the diagnostic centers, connected with the program, so the entire piece of information was there on available. This is the PACE graphic representation of the pace of mammographies during the year. So that was a very simple way, and this is how we'll continue prevention, putting in place prevention for cervical cancer as well, and for cardiovascular diseases in this simple and easily accessible way. All citizens, as dictated by doctors, will have easy access to a prescription and a referral so that they can visit immediately a diagnostic center. Meanwhile, as there has been lots of discussion on the registers and prevention for onco patients, together with the Ministry of Health, we are in a position to announce that the integrated healthcare onco system is at an implementation stage, rather the contracting stage of the agreement. We've just received the approval on the part of the ministry, and our goal is to put in place technically this national register for neoplasmas and related diseases, a full HEMA software system, in a way that all onco clinics throughout the country be connected and having available the necessary tools for the treatment of those patients. This shall be very helpful for all our doctors, together with the digital tools for patients that have been explained earlier, relevant to the needs of patients, and the medical consultant tool for the group of doctors, so the doctors themselves organizing their onco conferences and meetings have available digital tools that may help them to make well-informed decisions and continue their work. So that was it. Thank you very much.
Let's go across to Olga Siscu, who's the Emeritus Professor at the University of Piraeus, joining us online, I believe. Olga, are you there? You are. The floor is yours. Please go ahead.
Okay, thank you very much for this invitation. I'll talk on behalf of Professor Kaiteridou, and please let me share a very few slides. I'll turn in Greek. Καλησπέρα, ευχαριστώ πάρα πολύ για την πρόσκληση.
Hello, thanks very much for the invitation. I have a few slides that I will present along with my contribution. So we're talking about placing patients. I think it's high time we listen to what the patients have to say, and not just stick to the physical symptoms. So placing, actually having the patient receiving this care and placing the patient at the center of our care means that we have to place him at the center of decision making. Decision making with respect to their clinical care and other issues. Of course, placing him at the center of decision making process means that during the design of his treatment, we take into account all his actual needs, his experiences and preferences. These parameters should guide our clinical practice and other policies. So by means of such a practice, we believe that there will be an improvement in the services offered, since these services will be tailor-made, will be customized to his or her needs, and as a result bring better results. And given the experience and the academic results, it has been found that such a practice contributes greatly to securing increased loyalty and compatibility of the patient with the treatment, because they feel as if they are part of this treatment plan, since they have been involved in building the therapeutic plan. And as a result of that, health policies are more effective because they take into account the genuine needs of the patients. But the critical question is the following: how can we have a substantial contribution of patients in the decision-making process and the process of designing the therapeutic plan? At a research level, when we design studies that early enough take into account the needs of the patients, that's one thing. And even more, when such research practices have some kind of are time cohesive. What do I mean? They are recurring. We have a specific mechanism for follow-up of the experiential needs of the customers and their contribution. And it's not something that happens in a fragmented way. It is also very important to disseminate these findings, the findings of the studies that take into account the patient's viewpoints in the various scientific fora, and also in the by means of other means that can be more easily accessible to the patients themselves. And also the results should be presented in a more easily comprehensive way by the patients. Of course, the patients have a very important role to play when it comes to their rights. They have to know their rights, and the physicians and the health professionals should help on that. And the same applies to the measures for encouraging active participation of the patients. We're talking about the Paris cross-country study coordinated by OECD. At a national level, it's being implemented by the HTA organization. They are the project managers of this initiative. And of course, this project is sponsored by the Ministry of Health, which has secured funding for this study. Let me clarify that this funding has to do with the fees we have to pay as a country to the OECD. Project managers and other stakeholders are volunteering in this project. So we have to praise the contribution of IDICA, thanks to which, without their contribution, we wouldn't have been able to carry out the study, because IDICA took on the delivery of SMSs and text messages to patients. And last but not least, OEDTP. This is the Quality Assurance in Health Services organization that took on the communication campaign. So it's a study in order to investigate the experiential the experiences that the patients have after their interaction with the healthcare system. And also it's a project on investigating specific health issues that relate to the patient's behavior. And it's also a project in order to display self-reported results by the patients. This study, actually the aim of the partners of this study is to develop a common set of markers to be used by all countries participating in this project at the pilot stage, so that in due time we will be able to come up with a common let's say mapping or a common set of markers when interpreting the results and the findings, so that we can have a common mechanism in place which will take into account the patient's viewpoints in the future. The pilot stage of the study has already been completed. The main study has already been completed as well. More than 1,500 patients took part in this effort, and 80 physicians were involved, because at the same time we were taking note of the reports by the physicians who have been treating the patients. So we are looking forward to the results of this analysis in the coming period. The results will be shared by the OECD, and in the future we'll be able to disseminate them to you. The challenge in such initiatives is to continue with data collection in a systematic way. In the past, the Ministry of Health has undertaken a commitment to support that, so as to have at a national level such a mechanism in place which will take into experience the experiences of patients and their self-reported assessment with respect to the effectiveness of therapeutic interventions on themselves, and also with regard to the expectations they have had from the healthcare system. So our wish is that these findings will be integrated in our daily practice, clinical daily practice, and also in the health-related policies. Thank you very much for your attention.
Okay, well, we're going to move on now to the final two speakers on the panel, who are going to give us some comments, I hope, possibly summarising what we've heard, possibly your own thoughts on this, but either way, I'm afraid I have to ask you to be extremely brief, because we are very short of time. So first, across to Paris Cosmidis, head of the second Medical Oncology Department at the IGEA Hospital and former president of ESMO.
Thank you very much. Really enjoyed coming here.
Thank you. Thank you for being given this opportunity to be with you today. In the previous panels, in this one as well, we have heard very interesting topics and analysis. We need to accept that in our country we are through one of the most productive periods for onco patients. Let me confirm what was mentioned earlier relevant to new innovative treatments, because in our country we do have lots of prospects. As a clinical oncologist, medical oncologist, I can confirm the latter. Our patients have access to all innovative drugs, irrespective to the cost. They can be given even the most expensive treatment, even those that aren't actually in the market, which is not the case in all other countries, EU countries. Thus, the struggle somehow in our field has proved successful thanks to the work of the different societies and associations. The oncology developments were, and its outcome well, means that actually we've got hundreds of survivors involving a community of 30 million people in Europe and a similar group of people in the US, people that have been through the cancer journey. Many of them are fully cured, however, carrying the stigma because of the treatment or the disease itself. At an emotional or physical level, and this is why advanced community societies have established clinics for such people. And indeed it is extremely important the fact that there's such a clinic for adults and adolescents in the Mitera Hospital. The adults initiative needs to be praised and needs to be copied from other centers as well. It is worth being copied from other centers. Palliative care, on the other hand, is part of the oncocare. At some point, most patients will be in need of some kind of palliative care. There again, there has been a long debate as of the optimal way to deliver such services. I believe that societies have been through different, have made different decisions relevant to the way those services could be delivered. Some societies believe that this would create some kind of ghetto, which isn't the best emotional solution, and that home care would be the best solution. There are, of course, pros and cons. I believe that they are both necessary, well-balanced solution depending on the healthcare system in place in different countries. It is very important to have everything, of course, digitized, of all onco services, one of such relevant to prevention. This is a very sensitive issue. Mammographies particularly have been present on the media for obvious reasons, and this is good, according to my opinion, because this proved to be a very useful campaign. It is equally important to train the people, to educate the people, and let me remind you that in the past, when there were similar actions in place, we would visit different areas in Greece after being in communication with the head of the community, the mayor, and when reaching there, the mobile unit reaching the place, well, most women would have disappeared. They weren't there in the village, in the community. Fortunately, things have changed, even though still we need to stress the value of prevention and go beyond breast cancer. We need to focus on colon cancer, lung cancer, and other type of conditions. I believe that the developments are there. Recently, I've browsed the government bureau on Gazette on the Neoplasma register, and let me remind you that I was member of the first committee where the first decision was made for the establishment of this register back in 1985. And let me remind you again that the first home care was delivered by Metaxa Hospital back in 1980. Looking after and taking care of different patients on the island. Unfortunately, it was eliminated, disappeared due to lack of resources after several years.
Yes, please, thanks.
As this journey is long for all cancer patients, and the onco procedures involve continuous struggles, there need to be a continuous continuum and work on the part of the authorities, which of course need to consult a national coordination body, the National Neoplasma Committee, responsible for tracing policies. Thank you. Thank you very much.
For the General Secretary for Strategic Planning nodding, so I take that as a general agreement with your comments. Let's move on then to the final member of the panel, Athanasios Kotsakis. Athanasios, welcome, it's good to see you. Very briefly, please, your thoughts on what you've heard.
I'll try. Thank you. Good afternoon. I'll continue in Greek.
So firstly, I would like to thank on my behalf the organizers for inviting me to be part of this roundtable in my dual capacity, both as a speaker and as a listener of these important things that have been said. I'll try to be brief. A couple of comments. It seems that cancer is too frequent, something like sort of an epidemic. That's something we have all to realize, both physicians, the government and the patients, because it comes with its set of difficulties. My impression is that we live in an era which is too complicated and makes life even harder. On the one hand, Mr. Kosmidis is right when he says that we offer quality services, higher quality services to cancer patients compared to the past. But of course now we are knowledgeable, we are specialized, we know many more things compared to 25 years ago. On the other hand, we have exactly what the Secretary General said before, the cost issue. There is a cost for prevention, there is a cost for diagnosis, there is a cost for treatment, there is a cost for rehabilitation, there is a cost for hospices. So we have to see how we can overcome these challenges and provide the right services to our patients. I'm quite concerned. On the one hand, we have never had a shortage of drugs throughout the difficult, fiscally speaking, periods of the past, both in private and in public hospitals. And on the other hand, we have a huge problem when it comes to the access of patients to diagnosis because of the biomarkers needed in order to develop specialized treatments. So there are two different things we're talking about. I'm saying that because I'm quite perplexed. I don't know how to explain to my patients that you will get the drug, but you will have no biomarkers, so you're going to have to pay for the biomarkers. I don't know how we can talk about personalized medicine and big data and meta-analysis and the survival rate, etc., given that every patient has his or her own specific condition. And we know all these things, but at the same time, we have to see what the solutions we will come up with. That's something we should discuss in the coming years. Thank you very much for your attention. I think I was quite quick.
In terms of time, thank you very much. Although we are way over time, I don't want to leave without giving the Secretary General an opportunity to respond. You've heard an awful lot. You heard a very quite specific question there about how you really ration out what are some very expensive potential treatments and post-treatment follow-ups. How do you do that? What's the response of the government? Public policy is a very, very difficult area. You have to bring everything together. How are you going to do it?
We are not alone, you know. We have many examples for other European countries.
Yeah.
So, you know, we have a process in place. We know the limitations and the weaknesses of the process in place. And we're working towards improving and, you know, making the best out of it. So we understand, given the plurality of different new therapies coming to the market, as I mentioned, with all these associated uncertainty in relation to their incremental health benefits, right? Although at the same time coming in at much higher cost to existing therapies, it's an obvious no-brainer. I mean, you have to assess the incremental clinical benefits first. You need to understand what is really clinically beneficial for patients compared to existing therapies. That's the first step. Second step, you have to then assess incremental clinical benefits over the incremental costs of the same treatments in order to understand if it's really good value for money. I mean, it's the same as with all different consumers on any other sectors, right? You step into a supermarket or in a retail shop, you're actually unconsciously even trying to make the case for your buy. You're comparing what you're getting for the money you're paying. It's like the return of investment in all sectors of the economy. You have to assess what's the benefit for the purchase. The same happens with drugs, but you have different components to assess. As I mentioned, you start with the clinical benefit, then you move on to the incremental cost, or cost per outcome, or cost benefit, and then at the end you also have to balance everything out in the total budget. You know, realistically speaking, it's a practical accounting problem. Mm-hmm. You have a specific budget, and you have to balance out all the different budgets that you can make out of the budget.
In the case of government, you have to take the public with you, which is an added pressure, something else to add into your calculation. You had a word.
Yeah, I would like to say that the European Society of Medical Oncology has developed the magnitude of clinical benefit scale. So every drug receives a grade based on several factors, including activity, quality of life, and then several factors result in a score. And based on this score, the drugs are classified to different categories. For example, Class A, these drugs should be reimbursed in all European countries because it improves survival, quality of life and stuff. And so I think this is a very helpful tool for the European governments to decide based on scientific assessment.
May I intervene very briefly?
Yeah,
I mean,
final word.
we are all very aware of, clinical assessment score tools as the MCBS, which is a great example. The issue is that new drugs come into the market. Even if you assess their clinical benefit score using the ESMO tool or another tool, you don't see an association between their clinical benefit and their prices. So this is what we have to understand. We have to be transparent and rational with the view that we cannot pay or we cannot buy treatments of a lower clinical value compared to other treatments. We have to make the case transparent that we need to maximize the return of investment for the government and the public. And so there has to be an association with different such tools, such as the MCBS, compared to their price and the purchase of the government.
Okay, great. Thank you very much. I mean, that's a kind of complex place to leave things, but I think it does sort of summarize the difficulty of public policy in the context of all of the hopeful things we've been talking about. We have to close the session there, I'm afraid, because we really are seriously out of time. But please join me in thanking our panel. Thank you very much.
Great.
Okay, while our panel leaves the stage, let me introduce our next very, very brief session, just 5 minutes. We're going to hear from Thomas Hofmacher, who's the health economist with the Swedish Institute of Health Economics. And he's going to tell us about the role of cancer care monitoring in covering patient needs, so very relevant to the topic we've just been talking about. Please run Mr. Hofmacher's comments. Thank you.
Good afternoon, ladies and gentlemen. I wish I could be with you today in person in beautiful Athens, but I will be sitting on a plane to Japan when you see this video. I hope you just had an inspiring day discussing about cancer care in Greece. At the Swedish Institute for Health Economics, we are currently also running a research project about cancer care in Greece, and my intention is to give you a short preview of this current project. We call our latest project Cancer Dashboards in Europe, in European countries. This is sort of an international initiative aiming to facilitate the exchange of best practices in cancer care among European countries. And we are currently working with 6 countries, Greece being one of those countries. And the dashboard, what is a dashboard? A dashboard is sort of a monitoring framework, and a monitoring framework that tries to cover the whole continuum of cancer care. It includes indicators for different areas of cancer care. So, for instance, for the area of prevention, it could include indicators for the smoking rate, alcohol consumption, obesity rates, or the HPV vaccination rates. For early detection, it could include the screening participation rates, or the participation rates in screening programs. For diagnosis and treatment, it could include the availability of physician, nurses, the availability of diagnostic equipment, availability of cancer medicines, and for the last area of survivorship, it could include indicators for palliative care services, rehabilitation services. But it's also important to include indicators related to the aims of cancer care, such as reducing cancer incidence, reducing cancer mortality, and improving survival rates. And all of these indicators that are part of the dashboard are supposed to show the current status quo in a country such as Greece, and it should also show how far away countries are, or how far away the status quo in a country is from a national or an international target value that has been defined by a national body or an international organizations, or it could also be the EU average. And I'd like to show you an example today from the country of Poland, because we don't yet have results for Greece. But I'll show you Poland. We published this earlier this year in January, and you see that we have built the dashboard around a set of areas and indicators for each of these areas that you saw on the previous slide. And it shows how far away Poland is from the benchmark. The benchmark is in the middle, that's the yellow area. But you see that all of the blue bars, the horizontal bars that are emerging, are mostly stopping in the red area, meaning that Poland in areas of prevention, early detection, diagnosis, treatment, and survivorship always tends to be below the benchmark values, which could be either a national aim or the EU average in that case. And you also see that at the end of these bars, there are circles with triangles, and these triangles show whether progress has been achieved in recent years. And many of those triangles are either green or yellow, meaning that there is progress that is happening. So Poland seems to get closer to the yellow or even the green area in this dashboard. And we are currently building something similar now also for Greece. So please, everyone, stay tuned for the publication of the IHE Cancer Dashboard for Greece in the coming months. We hope that this project can also inspire and encourage a future introduction of a national cancer control program in Greece. But for now, thank you very much for the opportunity to speak to you today online, and have a great rest of the conference. Goodbye.
Excellent, thank you. Okay, well, that's something to look out for, I think. Maybe for next year's conference, we can catch up with progress on that dashboard. They were with us at the very first session of the conference, and they're here to help us close the conference with some closing remarks. I'd like to welcome to the stage Xenia Saridaki-Sores, who is the medical oncologist, president of the board of directors of the Hellenic Society of Medical Oncology, HESMO, and George Kapetanakis, who is the president of the Hellenic Cancer Federation. Please come up, George and Xenia, and give us your concluding thoughts. Do we have George and Xenia? George, but not Xenia. George, never mind. You can get started and take it away with your concluding thoughts for us after what's been a rather long and very crowded day. So we're looking forward to some concise summarizing.
Να περιμένω για την κυρία Σαριδάκη.
Should I wait for Mrs. Saridaki? Just a second. Okay, I'll get started. I have a short presentation. Could I have it on? Dear friends, dear guests, one more significant economy summit is over. High standards of speakers which depicted the oncocare in Greece and its prospects together with the desire of the state to move forward for the transformation of cancer care. Indeed, there's great momentum in place thanks to the ministerial decision on the creation of neoplasmatic diseases register and the development of a national action plan. In my introductory speech, I referred to the challenges that need to be taken into account in the design of...
So, closing the conference, allow me to discuss about the priorities in fighting cancer for the coming year. The way I have listed them, there are 10 priorities. I will be very brief. I'm not going to spend lots of your time. Actually, it's a challenge. It's an additional challenge so that in 12 months' time we will be able to discuss whether we made it or not. So, A, we have to develop prevention and screening tests and early detection tests. Following the announcements made, it seems that our country will move forward to that. So it seems that this priority is an ongoing one. It's in the pipeline. That's why it's first. Second, access to innovative therapies. We heard the ministers, we heard the secretary generals, etc. However, we have to make sure that oncological patients will have access to novel therapies in the context of precision medicine by means of building a new framework for biomarkers reimbursement, which is the main concern of our scientific committee, of the scientific community. Time is of essence when it comes to oncological partners, and it is only by means of timely intervention that we can do something. Of course, this takes into account other types of interventions such as X-rays, etc. Also, We have to invite more clinical trials in our country. We believe that time has come, and this should be one of our priorities for the next months. Palliative care. In December 2022, there was a law voted for the framework of palliative care. There was no such thing in the past. There has been no steps taken since that moment, and we believe that this is the year to do so. Also, mitigating the inequalities in cancer treatment access. I think this is of critical importance. We have parameters such as social, economical condition, religion, culture. This should not be obstacles when it comes to have access to these treatments. Promotion of a healthy lifestyle. This will lead to 30 or 50% less cancer cases. This would have been the case should we adopt a different way of living. So this public health has been highlighted as a top priority in our conference, so I think we have to see certain things happening in this regard as well. Mental health. It's time for mental health to come to the forefront. So the provision of mental health services are of major importance, including support groups, consulting, etc. And this should be an integral part of the treatment pathway for cancer patients, because they have a set of challenges they have to face in their journey. In the last roundtable, there has been a discussion about digitalization, digital transformation of oncological treatment. And yesterday, actually, the Court of Auditors approved the tender that was already ongoing. So we're going to have some reforms in the way our hospitals operate. There will be changes, and this will have a great impact. Also, AI. It will play a very important role, and the same has to do with the issue of survivorship. That's something discussed before. That's the international term. We have to develop survivorship programs in order to deal with the unique challenges faced by survivors. And this is where we should also include the follow-up of minor cancer patients, because when they become adults, we have to follow up with them. There's a huge gap there. Another issue, the right to forgetfulness, if I heard correctly, because the minister signed a decree that will cater for those people who are totally cured. Funding of cancer care. That's a very important priority, because we always need more money, more funds to take care of cancer treatment, and I think it will be priority. Following the RRF, through which many interventions are being funded in the healthcare sector and in oncology, we have to find resources from elsewhere so that we can secure financing after the RRF is over, in order to have a sustainable system. Last but not least, we have to strengthen cooperation with the EU programs like Cancer Mission, etc., in order to improve interoperability of the system and, of course, the development of new technologies. We've seen that there are such projects and programs, financing ideas like the one in Agiosavas, the Cancer Center. Last but not least, strengthening collaboration with the international cancer care ecosystem. So, collaborating with international organizations like the WHO, ESMO, European Cancer Organization, UICC, OECI, and others. We have to work with them, and this should be our priority, because this will help Greece to implement best practices, to disseminate best practices that will give added value to our efforts. Dear friends, with this few thoughts of mine, these priorities for the future represent also a challenge for the future. So I hope that next year, in our 5th Economist Impact Summit, we will be here taking stock of what we have achieved, what steps have been taken, and what more steps we need to take. Thank you very much for your attendance throughout the day in this really interesting conference, and of course all our speakers who honored us with their presence. Thank you very much. Welcome to Greece, those who came from abroad.
Xenia Salidaki Soras. Your turn.
Yes, so, ευχαριστούμε πολύ τους...
Would like to thank the last ones who remained. The survivors, yes. I have nothing more to add. I believe that the conference has been comprehensive. It was the fourth annual summit. Hopefully we'll see you next year, and we're going to have even more positive things to share and achievements to take note of. I hope we will all stay healthy until then, cold-blooded, and let's say stay happy. Thank you very much.
Okay, well, it only remains for me to add one or two final thanks, which I want to do. We're going to have a picture taken. We normally, where are we required? Here? And while we do, I'll carry on speaking. It won't show up on the picture. Don't worry. But we do have some thank yous that we need to give. The first one, of course, is to all of you who have stuck it out despite it being a very long and focused, concentrated day. I think an awful lot of what we heard just reflects how complex this condition is, how broad it is, how many effects it has. And I'm glad that you've been with us to explore some of that over the course of today. I do need to mention that we have, this event has taken place under the scientific auspices of the Hellenic Society of Medical Oncology and the auspices of the Hellenic Cancer Federation, along with the support of MSD, and I'm really grateful to them for their support. Also to Affidea and our contributor Medtronic, who have also sponsored and been important supporters. Really important to thank the Economist Impact team, I would say that, but without them and their quiet, efficient work behind the scenes, things would have been much worse than the minor disasters that I managed to deliver to you over the course of the day. And one personal thank you from me for the heroic work of the interpreters. Again, without whom I would be totally lost. They very rarely get thanked. They should be first on the list. So thanks to all of you. We'll see you again at the 5th summit. Thank you a lot. Bye-bye.
Τι είναι η ΕΟΠΕ? Είναι απλά τα αρχικά μιας ακόμα ιατρικής εταιρείας? Είναι τα 36 χρόνια συνεχούς παρουσίας? Τα 380 μέλη? Τα 26 πανελλήνια συνέδρια? Οι 122 υποτροφίες και τα 180 ερευνητικά προγράμματα? Οι 7 εκδόσεις θεραπευτικών πρωτοκόλων? Οι περισσότεροι από 3.600 ασθενείς που έχουν ελεγχθεί για μεταλλάξεις? Είναι μήπως οι ελληνικές και διεθνείς συνεργασίες? Οι πολυάριθμες ημερίδες και οι 480 εκχωρημένες αιγίδες? Η ΕΟΠΕ δεν είναι μόνο αυτά. Είναι πολλά περισσότερα. ΕΟΠΕ είναι το πάθος και η αφοσίωση. Είναι το όραμα και οι στόχοι. Είναι η αστήρευτη ενέργεια και η καινοτομία που μας καθοδηγεί απέναντι σε έναν κοινό εχθρό, τον καρκίνο. ΕΟΠΕ δεν σημαίνει απλά εταιρεία ογκολόγων παθολόγων Ελλάδας. Σημαίνει ελπίδα για καλύτερη ποιότητα ζωής. Σημαίνει πρόληψη και ίση πρόσβαση στη θεραπεία που αποτυπώνονται σε χαμόγελα και αγκαλιές συνανθρώπων μας. Και αυτό σημαίνει τα πάντα για εμάς. ΕΟΠΕ. Δίπλα στον συνάνθρωπο, απέναντι στον καρκίνο.
Από κανέναν δεν μπορεί να αφαιρείται το δικαίωμα στην ελπίδα. Γι' αυτό και εμείς στην Ελληνική Ομοσπονδία Καρκίνου συμπορευόμαστε με τους ανθρώπους που νοσούν από καρκίνο, γιατί συναισθανόμαστε τις ανάγκες, συνδημιουργούμε το πλαίσιο και συνεργαζόμαστε με όλους τους φορείς ώστε να έχουν άμεση πρόσβαση σε έγκαιρη διάγνωση, κατάλληλη θεραπεία, ψυχολογική υποστήριξη και ομαλή επανένταξη στην κοινωνία και την εργασία. Ελληνική Ομοσπονδία Καρκίνου. Ο άνθρωπος στο επίκεντρο. Μάθε περισσότερα στο elok.org.
How far must we go to find answers?
to discover new medicines and vaccines, and foster a place where science, curiosity, invention, and humanity converge. This is where extraordinary breakthroughs happen. We've been preventing and treating life-threatening diseases for over a century. We've pioneered new antibiotics and led practice-changing research for childhood diseases, cancer, HIV, heart disease, and diabetes. And we're only just getting started. Every day, our scientists from all backgrounds and disciplines work together to use the power of leading-edge science to save and improve lives. Because we believe research is the will to conquer the impossible. And that science will lead the way.
Στη Nova χτίζουμε το μέλλον με αξίες, με κοινωνικές δράσεις που αφήνουν ένα θετικό αποτύπωμα στους ανθρώπους, στην κοινωνία και στο περιβάλλον. Εταιρική υπευθυνότητα και βιώσιμη ανάπτυξη. Μια στρατηγική επιλογή που εδραιώνει την παρουσία μας στην κοινωνία και μας κάνει μια πραγματικά μεγάλη εταιρεία. Συνεχίζουμε δυναμικά.
Check this out.
It hasn't been such a long time since people first started shopping online, and it was easy to keep up with the clicks. Little by little by little by more, the clicks added up to be more than the stores, and e-tailers worked harder than ever before because they had to keep up with the clicks. The clicks came from laptops, then tablets and phones, Monday through Sunday, office and home, 24 hours in every zone, and still they kept up with the clicks. Now shoppers ask more from the websites they're on, their language, their currency, their way, or they're gone, so you'd better keep up with the clicks. All of a sudden, there are so many must-dos if you want to keep selling, like delivery there, no there, or there.
And make it tomorrow, first thing.
No time for borders. Gotta stay in control, to stay in the flow and continue to grow. But we'll help you. Keep up with the clicks.
Τι είναι η ΕΟΠΕ? Είναι απλά τα αρχικά μιας ακόμα ιατρικής εταιρείας? Είναι τα 36 χρόνια συνεχούς παρουσίας? Τα 380 μέλη? Τα 26 πανελλήνια συνέδρια? Οι 122 υποτροφίες και τα 180 ερευνητικά προγράμματα? Οι 7 εκδόσεις θεραπευτικών πρωτοκόλων? Οι περισσότεροι από 3.600 ασθενείς που έχουν ελεγχθεί για μεταλλάξεις? Είναι μήπως οι ελληνικές και διεθνείς συνεργασίες? Οι πολυάριθμες ημερίδες και οι 480 εκχωρημένες αιγίδες? Η ΕΟΠΕ δεν είναι μόνο αυτά. Είναι πολλά περισσότερα. ΕΟΠΕ είναι το πάθος και η αφοσίωση. Είναι το όραμα και οι στόχοι. Είναι η αστήρευτη ενέργεια και η καινοτομία που μας καθοδηγεί απέναντι σε έναν κοινό εχθρό, τον καρκίνο. ΕΟΠΕ δεν σημαίνει απλά εταιρεία ογκολόγων παθολόγων Ελλάδας. Σημαίνει ελπίδα για καλύτερη ποιότητα ζωής. Σημαίνει πρόληψη και ίση πρόσβαση στη θεραπεία που αποτυπώνονται σε χαμόγελα και αγκαλιές συνανθρώπων μας. Και αυτό σημαίνει τα πάντα για εμάς. ΕΟΠΕ, δίπλα στον συνάνθρωπο, απέναντι στον καρκίνο.
Από κανέναν δεν μπορεί να αφαιρείται το δικαίωμα στην ελπίδα. Γι' αυτό και εμείς στην Ελληνική Ομοσπονδία Καρκίνου συμπορευόμαστε με τους ανθρώπους που νοσούν από καρκίνο, γιατί συναισθανόμαστε τις ανάγκες, συνδημιουργούμε το πλαίσιο και συνεργαζόμαστε με όλους τους φορείς ώστε να έχουν άμεση πρόσβαση σε έγκαιρη διάγνωση, κατάλληλη θεραπεία, ψυχολογική υποστήριξη και ομαλή επανένταξη στην κοινωνία και την εργασία. Ελληνική Ομοσπονδία Καρκίνου. Ο άνθρωπος στο επίκεντρο. Μάθε περισσότερα στο elok.org.
How far must we go to find answers, to discover new medicines and vaccines, and foster a place where science, curiosity, invention, and humanity converge? This is where extraordinary breakthroughs happen. We've been preventing and treating life-threatening diseases for over a century. We've pioneered new antibiotics and led practice-changing research for childhood diseases, cancer, HIV, heart disease, and diabetes. And we're only just getting started. Every day, our scientists from all backgrounds and disciplines